আচ্ছা, ওখানে কি আমাদের কেউ দাঁড়াবে? আমাদের কেউ দাঁড়াবে?
নিয়ে যাবে তো, কেউ একজন নিবে না? চল ভাই।
তো ও যাক, করে দিল, ইন করো, ইন করো, ইন করো, ভিতরে ইন করে রাখো, ইন করে রাখো।
ওই পাশে ক্যান্টিনে।
হ্যাঁ, ওই পাশে নিয়ে যে দাঁড়াবে,
ওই পাশের ওই
নিয়ে
গেট
যে দাঁড়ান। না না, বলছি যে অফ করতে না দেখো, ভালো লাগবে না।
পুরোই বলে দিয়েছে।
মুখের কাছে যা বসেন, হ্যাঁ আপাতত বসেন, যখন করবো তখন প্রশ্ন করলে বা জিজ্ঞেস
কেস
তখন
কিভাবে
জিজ্ঞাসা
করবো?
করবেন।
একবার হেসে।
হ্যাঁ, মানে প্রজেক্টের পাশে।
অন করা আছে।
Good morning. May I have your attention, please? We can see that the Meet the Expert session is quite interesting and people are enjoying the interaction. But unfortunately, due to the time limitation, we need to start the parallel session. Today, we have 3 parallel sessions. In this hall, Hall 1, the session will be on gynae-oncology. In Hall 2, it will be on GU oncology. In Hall 3, it will be on lung cancer. So may I request the speaker, chairperson, rapporteur, and the interested audience to split to the 3 hall. Whoever is interested to attend the gynae, they stay here. And the GU and lung, they can go to level 2 and 3. Whoever is missing the parallel session, say is interested to see the other session, you can log in and see it later on, because we are recording all the sessions and this is given to a web link from where you can see it live and also see it later. So don't worry, if you are missing something for a parallel session, later on you can definitely enjoy it. Thank you.
Cancer, and then give continuous progestin and do the endometrial biopsy at regular interval and once in 6 months, dilatation and curettage. In postmenopausal women, you will do the dilatation and curettage to exclude cancer and can give progestin, and if necessary, you can proceed with the vaginal hysterectomy. But if there is a compressed hyperplasia, you will do hysterectomy in a postmenopausal woman. And if cancer is found, then you will stage these patients and then you will treat them. If you look at the actuarial survival of clinically stage endometrial cancer patients, then in stage 1, it's 70%. Of 70% of these patients clinically stage will be stage 1, and survival there is 75%. And progressively it gets worse, but you will note that surgically stage 1 has far better survival. That is because in clinically stage 1 patient, there may be some patient who actually have nodal involvement. And I do not know why it has gone blank. Okay, so once the diagnosis of cancer is established, operative management would consist of history, physical examination, dilatation and curettage, chest X-ray, serum CA125, pelvic ultrasound, and in some places where MRI is available, they may do an MRI, but it is not necessary. And the reason MRI is done is that they can have some idea about the myometrial invasion, and then they can anticipate if it is grade 1 and 2, and if the myometrial is not deeply invaded, then they will omit lymphadenectomy. So once the surgery is decided, oh, I didn't realize that you were not seeing any image. Now, once the diagnosis is established and you are proceeding with surgery, if you open patient and you find that there is advanced disease, then you try and do debulking as much as possible. TH, BSO, if you are able to do, then estimate the prostaglandins and endometrial receptor, both from the metastases as well as from primary. But if you do not see any obvious disease, abdominal disease, then proceed with TH-BSO and cut uterus to assess clinically the myometrial invasion. If it is grade 1 and 2 on the dilatation and curettage beforehand, if myometrial invasion is less than half, then there is no need for any further surgery. But if there is a deep myometrial invasion, or if it is grade 3 or any other bad histologies, then you need to stage properly. You need to do lymphadenectomy and omentectomy and washing. This is little controversial insofar as that many people might want to give radiotherapy anyway, and they may not do lymph node dissection, but we can discuss this at a later time. Now, the indication for adjuvant radiotherapy actually historically has been based on GOG study, PORTEC study, and some cooperative group study. But I think PORTEC study is pretty good. They looked at the high intermediate risk patients who are more than 60 years old, more than half myometrial invasion, whether grade 1 or 2, or they were grade 3, but inner half of myometrial invasion. And external beam radiotherapy was given in these patients, and they found that the long-term side effects, even though they were low grade, were still seen in 26% patient. And grade 2 complications, grade 3 and 4 complication was about 2%, but it appeared that it was a rather toxic treatment. So then they did the randomized study between this group of patients who received external beam radiotherapy or vaginal vault brachytherapy alone. And they found that the vaginal vault recurrence was identical in both groups. However, higher pelvic relapse was seen when patients were treated only with vaginal vault brachytherapy. However, the overall survival was not statistically significantly different. So nowadays, these patients might be treated only with vaginal vault brachytherapy. So if you look at the histology, the grade and the differentiation actually is a combination of the architecture as well as the nuclear morphology. And the rule really is less than 5% solid component, more than 5 to 50% solid component, or more than 50% solid component will decide whether it is well differentiated, moderately differentiated, or poorly differentiated. And then, of course, there are clear cell features and the serous features. But if you look at the nuclear grade and the grade 1, grade 2, and grade 3 based on the nuclear atypia, if you have a grade 1 histology architecture, but the nuclear atypia is grade 2, then usually it will be bumped to moderately differentiated cancer and like that. Now, this is a handy matrix. You can see myometrial invasion is in the lower row, and grade are appearing on the left-hand side column. So this cell represents myometrial invasion 0 or no myometrial invasion and grade 1. So if you put patients into this grid after surgery, and if there's no myometrial invasion, then grade 1 and grade 2 don't require any adjuvant treatment. Sometimes brachytherapy is given in grade 3 who still may not have myometrial invasion. On the other extreme, you have more than outer half of myometrial invasion, and if it is grade 3, then they will require external beam radiotherapy provided lymphadenectomy has not been done. So if lymphadenectomy has not been done, then grade 3 patient with any myometrial invasion, or grade 2 with outer myometrial invasion and grade 1 with outer myometrial invasion would still require external beam radiotherapy. Elsewhere, you can simply give vaginal vault brachytherapy. The grade 2 inner half myometrial invasion, lymph node not done, is sitting on the fence. You may want to give brachytherapy alone, or you may give external beam radiotherapy depending upon your local policies. I have found that estimation of LVSI is important, and if lymphadenectomy has not been done and LVSI is negative, then I tend to give more brachytherapy alone rather than give external beam radiotherapy, particularly in grade 1 and 2. But in grade 3, if lymphadenectomy is not done and myometrial invasion is present, I have to give external beam radiotherapy. Now, it is important that we should minimize the radiation effects, and where available, you may want to use IMRT, but in my practice, I still don't use IMRT. Instead, I use belly board so that the patient is treated prone, and you can see here the barium, and this patient, this was supine, so you can see a lot of intestine. Once the patient is prone, lower pelvis is empty of the intestine because it is pushed out. This case was particularly extraordinary in the sense that she required radiotherapy, but the intestine, there was too much intestine in pelvis, And I was very scared to give radiotherapy, and as an exception, I asked our surgeons to put a breast prosthesis in the pelvis so that it can act as a spacer, and the intestine was pushed out, and then radiotherapy was given. Now these are the fields, it's old films, but I still like these films because they can explain the treatment volume quite clearly rather than looking at the CT scan and stacked up one over the other. So these are the fields. If you have to give extended field radiotherapy, then it goes up. But otherwise, the pelvic radiotherapy field is at the intersection of S1 and L5. Quite often, if any of these patients are failing at it as distant metastases. So if you look at the prognosis of endometrial cancer, it actually depends upon the histology. It also depends upon the myometrial invasion. But more importantly, it also depends upon the lymphovascular space invasion and lymph node metastases. So I tried to look at the prognostic factors, which was less complicated than age and inner half and outer half and the histology and so many prognostic factors. So when we try to look at the interaction between the different prognostic factors and the interaction between the known prognostic factors, then I found that when in multi-factor analysis, when nodal status was not taken into account, then the fractional myometrial invasion, histology, LVSI were significant predictor for the failure-free survival. But when the nodal status was known, in other words, if I just take the patient who had lymphadenectomy, then histology and LVSI remain significant factors. So then I tried to look at only the histology LVSI at nodes and to see whether the model, prognostic model, which is based only on histology LVSI node is as powerful as the conventional multi-factor prognostic factors. And what we found was very interesting. So here you have got a matrix of LVSI nodes and the grade or histology. So if you look at the top row, when the patient had LVSI positive and node positive, then in grade 1 and 2, there was 41% relapse rate. In grade 3, 65% relapse rate, and clear cell 60% and serous 68%. So you can see that both low grade as well as high grade, when LVSI and nodes are positive, the relapse rate is very high. But when both were absent, then it is very interesting that grade 1, grade 3 and clear cell had no statistical difference. In other words, they did not behave more aggressively even though they had bad histology. Serous had a slightly higher failure rate, but again we can discuss that when there is a time to discuss. But I believe many of these patients are actually new primaries because this is a serous histology. It can be multicentric and sometimes it can relapse outside pelvis and it may actually be a serous peritoneal second primary. But isolated, if the LVSI is negative, then nodes are rarely positive. And if the LVSI is positive, of course, failure rate is still high. So in this setting, when you only consider LVSI nodes and histology, then the histology, LVSI was the single most prognostic factor. So if you look at 5-year overall survival, it was 61%, that is intermediate and high-risk patient. There are no low-risk patient here. And disease-free survival was 59, and in this, there were 4 groups. You had grade 1 and 2, then grade 3, clear cell and serous, and in multivariable analysis, grade 3 endometrioid, serous and clear cell, and the upper parietic nodes had lower overall survival, and serous histology had the worst survival. So now this study is only those who had positive nodes. Yeah. If you look at the patterns of failure in all node positive patients, again, you will see that vast majority of patients are failing distantly, and they are all failing at multi-site, and the pelvic failure rate itself is very limited. So in node positive cancer patient also, I believe grade 1 and 2 were managed adequately, and in fact, any histology patients were managed adequately in the pelvis, and they failed outside pelvis, and I don't think giving more treatment radiotherapy wise would have made any difference. So we just need some kind of innovative approaches in dealing with high risk node negative patients, and as you know, there is a POTEC 3 study going on which is trying to address this system, but unfortunately in POTEC 3, 40% patients are low risk in my opinion because they are LBSI negative and they have a very low relapse rate, and in my opinion they should not have been in this study. But since patients are stratified, we will still have some useful information, but it is likely that the trial might be negative. Thank you.
Thank you, Dr. Koilesh, for your nice and informative speech. Now I request Dr. Jeffrey Lowe to deliberate your speech on management of cervical cancer in pregnancy. Dr. Jeffrey Lowe. He is working in Singapore as an associate professor in National University Cancer Institute.
This five. This one. Second. F5. Assalamualaikum, and a very good morning to everyone. And I'd like to thank the organizing committee for inviting me to participate in your Cancer Congress. It's good to be here again, and very nice to meet all the old friends, and nice to catch up with all of you. Over the next 20 minutes or so, I'm just going to share on a condition which thankfully we seldom see, and but every now and then when it crops up, it is something that it can be very catastrophic and stressful, not only for the patient but also for the clinical team that's trying to manage the patient as well. So cancer in pregnancy, very fortunately, is a very rare occurrence, only about 1 in 1,000 pregnancies, and the most common cancer that we may encounter in pregnancy would be breast cancer, followed by cervical cancer, and then Hodgkin's disease, melanoma, leukemia, or ovarian cancer. When we look at the cancer incidence in Bangladesh, this is from IARC GlobalCan 2012 statistics over a 5-year period. The most prevalent cancer among the women in Bangladesh would of course be breast cancer, but not very far behind. Okay, sorry, can somebody do something about this? Okay. Not very far behind is in fact cervical cancer. So cervical cancer is the most prevalent gynecologic cancer in Bangladesh, and of course in many of the other Asian countries as well. So if you look at the cancers in pregnancy, then certainly, if anything, either breast or cervical cancer may be something that will be encountered. So the clinical challenges that will be faced would be, of course, the question of whether pregnancy is going to affect the cancer or not. Will pregnancy make the cancer worse? Will cancer affect the baby? And this is, of course, uppermost in the mind of the patient. Will the treatment of the cancer affect the fetus? Will treatment, if it is successful, is it going to affect her future fertility? What are the long-term effects on mother and child? And very importantly, what is the psychological and emotional impact on the patient, her spouse, and also her family? And these, I think, probably is the most important slide for my talk, and that such a patient with cervical cancer in pregnancy must be managed in the context of a multidisciplinary team in an institution where this team is working closely together. It will probably be best coordinated centrally by the gynecologic oncologist looking after the patient together with the obstetrician who is looking after the pregnancy, and together with a medical oncologist with an interest in gynecologic cancers, the pathologist, social worker, the neonatologist, the radiation oncologist, the radiologist with an interest in oncological imaging, and of course, very importantly, the religious counselor as well, because there are many ethical considerations to be taken on board. So the prime consideration we should always bear in mind would be to cure the patient, in this case the mother of the baby, to cure her of the cancer. But there's always be a dilemma between the priority. The mother obviously should take priority, but for the mother this may not be the case. You know, she would say that, oh, my baby is the most important thing. And what about the spouse, and what about the family? The Asian context, they have a very big say in the decision-making process. And in this current age of patient autonomy, particularly we see this in Singapore as well, the wishes of the patient and the family must be taken on board, and ever more so now in the medical litigation climate. We have to counsel the patient in such a way as to, of course, counsel them adequately, but sometimes we cannot influence them to make the decision that we want. So in other words, her decision has to be something autonomous and based on the information that we give to them. But this, of course, is variable depending on the country and the culture of the patient. So this slide, to me, I think is the most important and will be applicable throughout the rest of my talk in terms of taking all these other considerations on board. And this is a very useful approach because it shows the milestones of the pregnancy before viability. So this will usually be 24 weeks before the fetus is viable, or after viability, after 24 weeks, and after maturity. And in most developed countries, this would be once the baby is above 1 to 1.5 kilograms. It really depends on the neonatal ICU facilities and what the survival rates are for the baby at that time. So of course, the mother's womb is the best incubator, and maturity will be best determined by the best neonatal ICU facilities in that particular institution in which she's managed. So if the cervical cancer is diagnosed before viability, then we can usually disregard the fetus, you know, in the loosest sense of the word. Of course, we don't disregard any life form, but before viability, the treatment will commence nevertheless, okay? But after 24 weeks, then we will delay delivery and either commence some form of treatment which will be safe for the fetus, or delay the treatment until maturity is reached. If the cancer is diagnosed after maturity, then of course we'll deliver the baby, hand over to the neonatologist, and commence treatment for the mother. So for cervical cancer, it's the same anywhere, in the pre-invasive or in the very, very early micro-invasive stage. The patient tends to be asymptomatic, and this can be picked up with, say, a routine pap smear or a routine speculum examination. And in our country, certainly if a woman has not had a screen in the last 3 years, she will get a pap smear at her first antenatal visit. What is the impact of pregnancy specifically for cervical cancer? So, okay. Okay, now. Okay, this is challenging. Okay, so for pre-invasive disease, there's no mutual impact on the pregnancy. For invasive disease, patient may present with pervaginal bleeding, and as most, in most obstetric practices, the most common cause of bleeding in early pregnancy would be a threatened miscarriage, or in the second or third trimester would be thought to be an antepartum hemorrhage. And quite often, there will be a failure to inspect the cervix, because if you're worried about doing something to the pregnancy or causing some infection, then if a speculum is not performed, then you have a delay in the diagnosis. But in actual fact, there's actually no mutual impact. The cancer doesn't really affect the pregnancy, nor vice versa, and the survival is equal stage for stage. So if you have CIN in pregnancy, a cervical dysplasia or pre-invasive disease in pregnancy, it's very critical to have an experienced colposcopist to examine the patient, who will be very anxious with an abnormal pap smear. You will see an ectropion, that is a physiological phenomenon in pregnancy, and with experienced colposcopic assessment, you'll be able to rule out invasion just by visual inspection colposcopically, and you would only need to take a biopsy if invasion is suspected. If there's no invasion, then you can actually follow up the patient until delivery and then assess the patient 3 months post-delivery. If microinvasion is diagnosed on biopsy, then a cone resection would have to be performed, best in the second trimester. What if there is a frank cervical cancer in pregnancy? Then you have to consider about the initial clinical evaluation, which usually would depend a lot on imaging. Assessment in a gravid pelvis clinically by doing a vaginal, bidigital, or rectal examination sometimes can be very challenging, but certainly should be performed, especially by an experienced GYN oncologist. An MRI, if required, would be safe to assess the soft tissue, the perimetrum, and the pelvic lymph nodes. CT scans usually would be contraindicated because of the radiation hazard to the fetus and the effect of the iodinated contrast on the fetal thyroid. So far, there's no evidence of safety of performing PET-CT scans in a pregnant patient, so we avoid doing a PET-CT as well. So we do an MRI, you can do a chest X-ray by shielding the abdomen, and if you're worried about the liver, you can do an ultrasound scan of the hepatobiliary system to exclude any liver metastasis. So when do we intervene and treat the patient? So of course, the balance will be between the stage of the cancer and the gestation of pregnancy. As we said earlier, before viability, you disregard the pregnancy and institute the treatment straight away. After 24 weeks, you try and delay treatment until around 32 to 34 weeks, where you can achieve fetal lung maturity. Should we deliver vaginally or by cesarean section? Okay, essentially, in terms of the survival itself, there's no difference, as shown by some of the studies, but overall, most of us would prefer to deliver the baby by a classical cesarean section over a normal vaginal delivery because of the risk of hemorrhage through the cervical tumor, as well as sometimes implantation of tumor cells on the episiotomy site. So the default mode of delivery is a cesarean section. So in the case of microinvasive disease, remember this can only be diagnosed on a cone. You cannot diagnose microinvasion on a simple punch biopsy. So if it's stage 1A1, where the depth is up to 3 millimeters with negative margins on the cone, then you can continue with the pregnancy and follow up the patient postnatally. In this type of small disease, the risk of having positive nodes is extremely low. Now, once the depth of invasion is a little bit deeper to stage 1A2, or you have stage 1B1 cervical cancer less than 2 centimeters in diameter, then the risk of having positive nodes goes up somewhere between 7 to 15%, and hysterectomy will be required. So usually either a simple or modified radical hysterectomy tailored to obtain clear margins all around the cervical tumor, as well as a systematic lymphadenectomy. In expert hands, radical trachelectomy has been described in pregnancy, either vaginally or abdominally, but this obviously is a very challenging and difficult surgical procedure. And a pelvic lymphadenectomy, as I mentioned, should be performed. And these surgical procedures will be best performed in the early second trimester. Now, from stage 1B1, when it's more than 2 centimeters, or 1B2 onwards, then the standard treatment would be to give concurrent chemoradiation. If the diagnosis is made before viability, normally you can expect the fetus to spontaneously abort during the external beam treatment. But if it's diagnosed after viability, then one option is to give neoadjuvant chemotherapy until you reach fetal lung maturity, at which point you can deliver with a C-section, and then after the baby has been delivered, treat the patient with concurrent chemoradiation. So is neoadjuvant chemotherapy safe to be given in pregnancy? Certainly, there are no large studies to document its safety. We know that there is a risk of giving chemotherapy in the first trimester due to organogenesis from day 10 to around 8 weeks, and we would consider it to be safer to commence after 13 weeks when the organogenesis is more or less completed. Systematic analysis of platinum administration in pregnancy showed that there were 3 malformations in 43 pregnancies, including ventriculomegaly, hearing impairment, microphthalmos, but the exact causative link sometimes can be very difficult to establish. In an in vivo analysis of the use of cisplatin in 7 patients in the second trimester in a neoadjuvant setting showed that the umbilical cord blood and amniotic fluid levels of cisplatin were significantly lower than that of maternal levels. Another series looked at the use of paclitaxel as a neoadjuvant chemotherapy in 6 pregnancies, and which were then delivered at C-section at 33 to 35 weeks, showed that all the neonates were normal at birth. So neoadjuvant chemotherapy in pregnancy allows the fetus to progress to viability while keeping the tumor in check. And at the International Consensus Meeting of Gynae Cancers in Pregnancy, which was published in 2009, showed that the safety of cisplatin-based neoadjuvant chemotherapy in pregnancy is appropriate for stage 1B1, up to 4 centimeters with node negative on imaging. Stage 1B1 before pelvic lymph node dissection, or up to stage 2B, you can give it until fetal maturity. It was felt that carboplatin and paclitaxel was a safer and a better combination due to lower toxicity and better response rates. One of my colleagues, Professor Lencharan, did a review of all the literature and acknowledged his work in this review of 39 cases published in literature showed that only one patient had disease progression during neoadjuvant chemotherapy for cervical cancer in pregnancy, and at follow-up, 70% of patients, in fact, had no evidence of disease, and there were no fetal anomalies detected in these 39 cases. So, to sum up, this is a slide from one of the books which I think is very useful for clinicians who very occasionally will encounter cervical cancer in pregnancy in terms of the management algorithm. If the cancer is diagnosed up to 24 weeks and the patient is agreeable to discontinue the pregnancy and she's early stage, then treatment would be a radical hysterectomy with a fetus in situ along with a pelvic lymphadenectomy. If the stage is advanced, stage 2B to stage 4A, then treatment would be pelvic external beam radiation and chemotherapy, and we anticipate a spontaneous abortion, or you can extract the fetus with a hysterotomy, and then once spontaneous abortion has occurred, to continue the treatment and follow on with brachytherapy. If the cervical cancer is diagnosed after 24 weeks, or if the patient in the first trimester wishes to continue with the pregnancy, and if the tumor is small, then consider doing a lymphadenectomy in the second trimester and a conization to resect the primary tumor, or a radical trachelectomy if technically feasible. If the nodes are negative, you can follow up the patient to fetal maturity, then deliver vaginally or by C-section, but in this case, if the margins are negative, then you can deliver vaginally, and then after that, treat as appropriate. And then finally, if the cancer is diagnosed after 24 weeks, or if the tumor is bigger than 2 centimeters in diameter, then consider giving neoadjuvant chemotherapy until fetal maturity. After that, perform a classical cesarean section, and then treat according to whatever the stage of disease is. So I think this gives quite a good overview, and it's quite a logical clinical algorithm for management of what is otherwise a very challenging and stressful and catastrophic incidental finding in otherwise what would usually be a very happy situation for the patient. So this is a photo of a radical hysterectomy with a fetus in situ, thankfully not something that we see every day. And I would like to summarize by saying that the maternal well-being and the fetal well-being is a fine balance when we're dealing with cervical cancer in pregnancy. This is not only clinically challenging, but also ethically and morally very challenging for the patient and for the clinical team. The effect of cancer and the treatment on the mother and fetus cannot be underestimated, and the timing of the treatment and timing of delivery is something that really needs to be planned very, very carefully to achieve the best outcomes for both the mother and the baby. The patient and the family's perceptions very, very much, especially in our Asian context, will impact on what we can do and what we cannot do for the patient. And sometimes the patient will run away completely, and seek some traditional options for treatment. Otherwise, certainly the best place to manage such a patient would be coordinated in a tertiary institution with the best neonatal facilities and by a multidisciplinary team led by the GYN oncologist. Thank you very much for your attention.
Thank you, Dr. Jeffrey Lowe, for your nice and elaborate discussion. The topics was also the burning issue who deals with pregnancy with cervical cancer. Thank you, Dr. Jeffrey Lowe. Now, may I now request Professor Sabira Khatun to deliberate her presentation about What lies between carcinoma in situ and microinvasive carcinoma? Professor Sabira Khatun, she is the head in Gyne-Oncology Unit of Bangabandhu Sheikh Mujib Medical University. Professor Sabira Khatun.
টেকনিক্যাল প্রবলেম এটা
Assalamu alaikum. It's a technical problem. My topic is about carcinoma in situ and macroinvasion. We have started gyne-oncology very recently, and we are not so acquainted or so familiar with these two conditions.
প্রবলেম
In our country, we have started screening of cervical cancer. We are diagnosing many cases of CN3, but diagnosis of CIS and macroinvasive carcinoma and management of CIS and macroinvasive carcinoma, we are not very much familiar. And without diagnosis and management and treatment of CIS and macroinvasion, it is not possible to prevent the invasive cervical cancer. ঠিক আছে এটা চেঞ্জ করে কেমন করে এটা So my topic is what lies between cervical cancer, intraepithelial neoplasia and invasive carcinoma cervix. Carcinoma in situ and macroinvasive carcinoma. These two lies between CIN and invasive carcinoma cervix. I will start with the history of a patient to make you understand. This patient is Mrs. Aklima, 48 years old, and she had colposcopy directed pulse biopsy at colposcopy clinic of BSMMU on 26 August 2015. Hyper examination of this pulse biopsy specimen was carcinoma in situ, and there was a special note that the possibility of invasive carcinoma in the neighborhood of the specimen could not be excluded. Now the questions are, why possibility of invasive carcinoma could not be excluded? And how the possibility of invasive carcinoma in the neighborhood can be excluded? And is it necessary to exclude invasive cancer in this specimen? And to get the answer of these three questions, Mrs. Aklima had cone biopsy, cold knife cone biopsy on 7th October 2015. And high-power examination of this specimen shows that there is a foci of carcinoma in situ in two sections, but one of the sections in 9 to 12 o'clock position shows carcinoma in situ, and microinvasion of 2 millimeter. And we got the answer of my questions. Now, what is carcinoma in situ and what is macroinvasive carcinoma cervix? Is it necessary to specify the diagnosis? Answer is yes, because management of these two conditions are different. Now we will go through how the management of CIS and how the management of macroinvasive carcinoma is done. Carcinoma in situ cervix, this term was first introduced in 1932. Broder in 1932 described the lesion in which the undifferentiated carcinomatous cells involve the full thickness of the epithelium of transformation zone of cervix without disruption of the basement membrane. And in 1953, Regan introduced the term dysplasia to designate cervical interepithelial neoplasia, that is 1, 2, and 3, which is intermediate between normal epithelium and CIS. CIS is one step ahead of CIN3. Now, how the CIN3 and CIS can be differentiated? CIN3 is a dysplastic cell found in the lower, more than lower two-thirds of the cervical epithelium, but CIS, in which the malignant cells are found in full thickness of the epithelium of transformation zone of cervix. And in CIN3, very few or no mitotic figures are found, but in CIS, large number of mitotic figures are found. In CIN3, dysplastic cells are found, but in CIS, the frank malignant cells are found. CIN3 is more towards CIN, but CIS is more towards invasive cancer. Malignant potential of CIS is only 12 to 15%, but malignant potential of CIS is 30% after 20 years of diagnosis. Basic treatment of CIN3 is excision by lip, but basic treatment of carcinoma in situ is cold knife conization followed by total abdominal hysterectomy if required. Now, how to predict the development of CIS? By doing HPV, recent study shows that by doing HPV viral load may be predictive of future risk of development carcinoma in situ at a stage where the smear cytology is negative for squamous cell abnormalities. But these two differences are dependent upon the HPV type. It has been shown by a study that the women with high HPV 16 viral loads are at 30 times relative risk of HPV 16 negative women. Now, how the diagnosis and treatment of CIS can be done? We have in our country, we have no such study because we have started oncology very few years, and we have no study data collection, but a study done in the National Women's Hospital, Auckland, New Zealand in 1955, the progressive study done among the 984 patients with CIS. And in this CIS patient, 677 patients had cold knife cone biopsy or amputation of the cervix at the principal treatment of, and in 148 patients, pulse biopsy followed by cone biopsy. And in 1964, the hospital policy developed that the colposcopy-directed pulse biopsy, if it is CIS, then the initial procedure should be followed by cone biopsy. Another study done during 1947 to 69 in MD Anderson Cancer Hospital, Houston, Texas, the number of patients were age 61, age was 70 to 87 years range, and only 53% patients complained of had any complaint, and 47% patients diagnosed by routine smear, and cervical conization to exclude the invasive cancer was done in 72% of the patients, and simple hysterectomy done in 70% of the patients. and only conization was as the treatment in 10% patients who had no children. Now it reveals from these two studies that diagnosis of cyst can only be confirmed by cold knife conization, and treatment of cyst consists of, if no child, and cold knife conization can be taken as treatment, and family complete, total abdominal hysterectomy can be done. Now, invasive potential of cyst with continued abnormal if the continued abnormal cytology, then after treatment 28.8 times, and with normal cytology 3.2 times over the women who had never cyst. Now, macroinvasive carcinoma. It is a bit different from cyst because in macroinvasive carcinoma, the basement membrane has been crossed by the malignant cell. The term was macroinvasive carcinoma first introduced in German literature, and in 1961, Figo subdivided the clinical stage 1, the cervical cancer, into stage 1A, preclinical cancer, and stage 1B, clinical cancer. And in 1974, HGO proposed the measurement, proposed the measurement of the macroinvasive carcinoma should not exceed 3 mm beyond basement membrane. Then in 1985, Figo introduced the actual measurements in definition of stage 1A disease. And finally, in 1994, Figo adopted the more precise definition of macroinvasive carcinoma, as that the stage 1A1 up to 3 mm invasion, and stage 1A2 3.1 to 5 mm invasion. And in both stages, horizontal spread should not exceed 7 mm. And the lesion, macroinvasive carcinoma, further categorized as confluent lesion and non-confluent lesion. Non-confluent lesion, multiple finger-like process of differentiated invasive carcinoma stream. These are finger-like lesion. Early non-confluent macroinvasive carcinoma, and this is confluent macroinvasive carcinoma, that is fingers are fused. That these studies showed that their depth of invasion was up to 3 mm. And macroinvasive carcinoma, CIS or CIN diagnosis cannot be done by pans-biopsy patient, because pans-biopsy tissue is not sufficient for the diagnosis of CIS or macroinvasive carcinoma. Because in pans-biopsy specimen, whole circumference of the cervix needs to be examined, and in pans-biopsy specimen, whole circumference of the cervix cannot be examined histopathologically for the diagnosis, confirmation of diagnosis, and for exclusion of invasive cancer. So, how to diagnose? How to confirm macroinvasive carcinoma and CIS? How to exclude invasive carcinoma? So, definitive diagnosis of macroinvasive carcinoma with accurate measurement can only be done in a conization specimen, either cold knife conization or needle cone or laser cone, or in a hysterectomized specimen. Now, treatment of stage 1A1 disease, that is up to 3 mm invasion. Cone biopsy with histopathological report of clear surgical margin, negative EC endocervical curettage, and no lymphovascular space involvement can be considered as the adequate treatment for the stage 1A1 disease if family is not complete. And if the family is complete, then extrafacial hysterectomy without lymphadenectomy is the treatment of stage 1 A1 disease. And sometimes repeat conization should be performed before hysterectomy. Or modified radical hysterectomy or vertical hysterectomy with bilateral pelvic node dissection is the treatment. But if the fertility needs to be preserved, then radical trachelectomy with laparoscopic or extraperitoneal lymphadenectomy is an option. When microinvasion is associated with extensive vaginal VAIN, then local hysterectomy should be associated with proper vaginectomy. And if the patient is unfit, then standard cervic external radiation and intracavitary radiation. And if the chance of invasion is 3.6% and chance for mortality is 2.9%. Now in conclusion, CIN3, CIS and microinvasive carcinoma are three distinctive categories of lesions. And this should be distinct, diagnosed separately and managed separately. CIN3 is a pre-malignant condition. CIS is a pre-invasive malignant condition, and microinvasion is a preclinical invasive malignant condition.
Dr. K.J. Maula to deliberate her presentation about disparity between colposcopy and histological finding. Dr. K.J. Maula, she is the founder, organizer, and former head of Gynae-Oncology Department of National Cancer Institute in Dhaka. Please, Dr. K.J. Maula.
পেইন্টেড তো আমি পড়া লাগাইছি কাজ করে না দেখেছি আচ্ছা কাজ করে না দেখে হ্যাঁ কাজ করবে তো করবে না পেনড্রাইভ লাগাবেন না আসি আগে দেখবেন যে কেবলটা কি আছে কই শর্টকাটটা কই যায় না দেখলে করে মানুষ আপনাদের দিয়ে কেমনে কাজ হবে রিসাইকেল বিন নাই ম্যাডাম
তুমি একটা মানুষ খুঁজো বুঝছো তোমার সাথে আনার জন্য আচ্ছা ঠিক আছে আর কাউকে বলো
Please, our learned audience, We know you are thirsty about knowledge, but there is technical problem to set the session. Please. At the time, may I now request for further speakers to complete their session within 10 minutes.
Learned audience from home and abroad. My topic is disparity between colposcopy and histopathological findings. You know, cervical cancer is a virulent global problem of female genital cancer. Now it is recognized that it is and when the abnormal cytology is detected, colposcopy is the gold standard diagnostic tool for the pre-invasive cervical cancer. If it is clearly and truly coincides with the histopathological results. But sometimes the findings of colposcopic examinations and histopathological diagnosis unexpectedly differs significantly for the same patient, resulting under treatment or over treatment. Aims of this study is to evaluate the disparity between colposcopy and histopathological findings and to assess the accuracy of the two methods. This is a retrospective study. We examined 2,250 patients with cytological abnormalities. It is my own series, and also for the VIA positive from 6/3/9 to 6/8/2015. Age group was 23 to 50 years in a OPD setting of Comfort Nursing Home. It is a private hospital. All were parasitics. The evaluation was done by a single gynecologist, by myself, and histopathological examination was done by the senior single histopathologist of a corporate multidisciplinary hospital. This is I use this microscope. Colposcopic and colposcopic multiple-sided biopsy were performed upon the VIA positive and abnormal perpendicular smear. Results. 1/3 of the patients with cytological abnormality with VIA positive method, the biopsy results showed normal findings. A standard protocol of cervical biopsy was performed for this patient. Colposcopic findings of this study are the following. Colposcopic diagnosis is often overestimated, that is 31%, and also underestimated, that is 11%. It is globally. Referred patient with cytological abnormality for colposcopy was 2,250 patients. That is from the different corners of our country, that are the VIA positive patients, and the perpendicular abnormal positive patient from my own series. Out of them, 815 were colposcopically normal. CIN1 was 100. Histologically, CIN1 4% and CIN2 was 3%. The results, colposcopically CIN2 were 370 patients, that is 20 8% and CIN3 was 4%.
Lymphoblastic tumor, 88.6% having no idea about this disease, and 11 regarding untreated and uncared gestational topoblastic tumor converts to cancer like choriocarcinoma, 84.4% having no idea and 11.4% know it, and other 4.2% did not make any comments. Regarding knowledge about treatment of gestational topoblastic tumor, 79% having no idea about treatment, and other expresses different types of idea. And here there is a bar chart showing education and symptoms. There is obvious relation between the educated person having more idea about the symptoms of the disease, and that is the relation between profession of the respondent with the idea about choriocarcinoma, and there is an idea about the tumor arises from the placenta with the education of the respondent, and that is the idea about the treatment of choriocarcinoma. And on conclusion, I like to say education level influences attitude towards gestational topoblastic tumor, and actual awareness depends on education, income, and social status. This study shows that women had suboptimal level of knowledge regarding gestational topoblastic tumor. Day is coming, sun is rising, no darkness about gestational topoblastic tumor. New sun. Thank you very much for your patience hearing.
Thank you, Dr. Shirin Akhtar, for your nice presentation. As we are running in short of time, now we open our audience for question session for limited time. Please, our learned audience, have you any question you may ask our speakers, please.
Assalamu alaikum. I'm Dr. Sanjida Ahmed, Registrar Gynae, Coimbatore General Hospital. I have a question to the speaker, Dr. Kailash Narayan, but I'm not seeing him. So, may I have the question? If any speaker can answer, I'm throwing my question. In his presentation at the very beginning, he mentioned about vaginal hysterectomy in case of endometrial cancer. I just wanted to know clearly about the role of or indication of vaginal hysterectomy in endometrial carcinoma. I can see him there.
When you have stage 1 or 2, when it is grade 1 or 2, and if you are not suspecting nodes to be involved, you can do vaginal hysterectomy because lymphadenectomy is not required. But if you have to do lymphadenectomy, you can still do laparoscopic lymphadenectomy and vaginal hysterectomy.
Assisted vaginal hysterectomy.
Yeah.
There is laparoscopic assisted vaginal
Yes.
hysterectomy.
Yes.
Okay, sir.
Because people are even doing laparoscopic and vaginal hysterectomy even in poor grade Even in grade 3, people are doing it.
Okay, sir, that it will be a non-descending vaginal hysterectomy, I think.
Yeah.
Okay, sir. Thank you, sir.
You're asking tough questions from radiation oncologists.
Actually, you mentioned it in your slide.
Any other question?
Thank you, all the speakers in these sessions. Very good morning. I want to know from Jannatul Firdaus, right? According to your presentation, you say different management of the different type of CIN 1, 2, and 3.
Excuse me, doctor. The question session towards our speaker, please. Towards our speaker, please.
CIN 1. Who is the CIN? About the management of the 3. Luminal type. Is there any difference between the difference of management in the CN 1 to 3 during the interluminal type? This is the first question. And another question, we know that the radicals. Right?
Yes.
And in the case of CIN 1, 2, 3, there is a difference between the
Yes, there is
and
definitely there is difference in the treatment between CIN 1, 2, and 3. There is definitely CIN 1 is most of the patients can be observed and followed up because there is a regression of the CIN 1 to normal. And in CIN 2 cases can be treated or cannot be treated. There is variation. And CIN 3 cases, all the CIN cases needs to be treated.
Both in the interductal and interluminal case.
I cannot say interductal and CIN 3 is treated by excision, and CIN 1 and 2 is treated by ablation, and CIN 3 is treated by excision. Excision can be done by cone knife. Lip excision is the most important treatment. Lip excision, or excision can be done by cone knife conization, but CIN 3 most of the cases can be treated by loop electrosurgical excision procedure.
Is that family complete or not?
Yes, in case of CIN 3 is most of the cases are treated by conservative treatment by loop electrosurgical excision. There is no question of family complete or not. But if the family is complete, if the patient desired hysterectomy to extrafacial hysterectomy can be done for CIN 3. But there is no question of doing any hysterectomy for CIN 1 and 2. Always it should be treated by conservative approach.
Thank you, doctor. Please, we have to say there is scarcity of time. Only last question is invited from our learned audience. Please.
I am Dr. Fahima working in Kurmitullah General Hospital. I have a question to Professor Jeffrey Lowe. Sir, thank you for your nice and very interesting, informative presentation. My first question is there any recent international consensus on gynecological cancer in pregnancy after the Belgium 2008? To Professor Jeffrey Lowe, my first question.
The most recent one that I'm aware of is 2009. So.
That is so far.
I'm not aware of any other more recent consensus.
Yes, I have gone through your article published on the Baylor Best Practice Journal, that is Gynecological Cancer in Pregnancy, that is based on the International Consensus on Gynecological Cancer in Pregnancy, Belgium 2008.
Those are review chapters that we wrote after a review of the literature.
And my next question is regarding the emotional impact.
Thank you, Doctor. Please. Now we are towards the end of the session.
Thank you. Thank you, sir.
Thank you.
May I now request one of our chairperson, Dr. Parveen Akhtar Banu, who is the clinical oncologist and working as a chief consultant of Delta Medical Hospital Limited, to say something about our session.
Good morning, everybody. Thank you very much, all speakers, for your nice presentation. And our first speaker, Dr. Kailash Narayan, has very nicely showed us the adjuvant treatment of endometrial carcinoma. As we know that stage 1A, grade 1, we usually don't give any adjuvant radiotherapy if surgery is a radical one. And he highlighted the nodal status and lymphovascular space invasion are the most important predictive factors for deciding the treatment, adjuvant treatment. If the lymphovascular invasion is present, then lymphadenectomy, pelvic, para-aortic, and peritoneal washing is, he highlighted during surgery. And stage 1B, grade 2, 3, intermediate, high-risk intermediate, and grade 3 patients we treat after surgery with vaginal brachytherapy or external radiotherapy. There is a study which showed vaginal brachytherapy alone or external radiotherapy alone does not differ much in the pelvic recurrence, around 4.5%. So sometimes we can give only external radiotherapy or vaginal brachytherapy because both the treatment is combined is more toxic, especially external radiotherapy, because intestines and large gut comes in the field and lead toxicity is there. So we have to do the proper staging, and we have to take into account all the predictive things, then decide for the treatment. And for high-grade patients and stage 2, 3, we give concurrent chemoradiation or chemotherapy and radiotherapy. It means radiotherapy may be followed by chemotherapy. Concurrent is not superior, or it is not important. It is not superior as showed in different trials. So sequential is better and tolerated also better. And vaginal brachytherapy, we practice only vaginal brachytherapy 3 sessions, 3 fractions, usually 7 gray into 3 weekly fractions we practice in our center. Our next speaker, Dr. Jeffrey Lowe, he also highlighted a very important topic, management of cervical cancer in pregnancy. It is a clinical challenge, and he highlighted that multidisciplinary team is very much important here to take the decision and manage the patient all through. And here also comes the screening. As we have just started our country the cervical cancer screening program. So it should be widely, steps should be taken to bring more and more women in this screening procedure. So the complication of cervical cancer concomitant with the pregnancy can be bring down. This is rare cases, but we have encountered sometimes. It is really complicated. And next presenter was Professor Sabera Khatun. She highlighted carcinoma in situ and microinvasion, and it is very important because the management differs. Carcinoma in situ or CIN and invasive carcinoma management is totally different. So it is very important to diagnose correctly and then take the decision of treatment accordingly. Then our fourth speaker talked about the disparity between colposcopy and histology by Dr. K.J. Maula. It is also a very important topic, and we can see that there is a disparity, and 1/3 of biopositive patients comes normal when colposcopy done. And so there she highlighted a consensus between histologist and colpologist should be there. And Dr. Shahana Parvin presented her own series of primary malignant melanoma in vagina. It is a very highly malignant cases. I have also had several patients. Outcome was very, very fatal and very, problematic for management. And she took concluded that women have suboptimal knowledge about the trophoblastic tumor. So thank you very much, all the presenters. Thank you all.
Thank you. Dr. P.A.
And last of all, I like to thank the organizers to invite me and to chair these sessions. This is a good start for the gynecological oncology subjects, and I hope it will go forward. I must thank Professor Maula because she took a lot of trouble.
Sorry, madam. Professor Saiba Akhtar will hand over the memento to our Dr. Koilash. Now I request Dr. P.A. Banu to hand over the memento to Dr. Jeffrey Lowe. Please, Dr. Jeffrey Lowe. সামনে দিয়ে দিলে ভালো হয় না? সামনে জায়গা আছে? সামনে দিলে ভালো। ম্যাডাম ভুল তো ভুল, ম্যাডাম ভুল হয়ে গেছে। সব কিছু ম্যাডাম সরি ম্যাডাম। অ্যাকচুয়ালি তো ভুল হয়ে গেছে। কাছাকাছি না। আরে না হয় না। No. Now I request our chairperson, but Professor Saiba Akhtar, to hand over the memento to our speaker, Dr. K. Khatun. From Dr. P. A. Panu. Now I request our Professor Saiba Akhtar to hand over the memento to our next speaker, Dr. Shahna Parveen. Dr. Shahna Parveen. Now I request our senior professor, Professor Saida Farida Begum, professor working in Bangladesh Medical College, to hand over our crest to our chairpersons. Please. Professor Saida Farida Begum. Next, please, Madam, hand over our next chairperson to Professor Parveen Akhtar Banu.
Now I will request our chair, Professor Roshan Ara and Dr. Parveen Akhtar Banu, to hand over our crest to our moderator, Dr. Nazma Haq. Thank you, our honorable chairperson of these sessions and moderator. Now this is the conclusion of this session. Now we will have a mini symposium on gyno-oncology. Now I will request our presenter, Dr. Jannatul Firdaus. She is associate professor of BSMMU. Now I will request Dr. Jannatul Firdaus, Associate Professor BSMMU, to have a seat, and the chairperson of this session, Professor Fauzia Soban, he is the head of oncology, medical gynecology department, NICRH, to have a seat, and to have a beginning of this session.
সবাই চলে আসবো বলে দিচ্ছি আপনি দেন আপনাকে তোর দিয়ে দিচ্ছি
এটা আমি জানি শোনে এক্সকিউজ মি
Now I will request the panel of experts, Dr. Jeffrey Low, Dr. Koilash Narayan, Professor Sabera Khatun, Dr. K.J. Maula and Dr. Parveen Akhtar Banu to have a seat as a panel of experts on the dais. I'm repeating the name again, Dr. Jeffrey Low, Dr. Koilash Narayan, Professor Sabera Khatun, Dr. K.J. Maula and Dr. Parveen Akhtar Banu. Now I will request our moderator, Dr. Jannatul Firdaus, to conduct this session.
Presenter, কোনো moderator নাই. Presenter to present.
Good morning, dear audience. I can understand that following the preceding session, everybody is a bit, perhaps they want to be refreshed. Nevertheless, I would request all of you to please attend this session so that we can have some useful interaction. This is basically a mini symposium, Gynae-Oncologic Symposium, and Dr. Jannatul Firdaus, Associate Professor, Gynae-Oncology, BSMMU, will speak on NCCN Guidelines version 2015 on management of cervical cancer. Dr. Jannatul Firdaus.
Honorable Chairperson, respected teachers, learned audience, Assalamu alaikum and good morning. It is my privilege to be here and to present NCCN guidelines regarding management of cervical cancer. Bangladesh has a population of 54.38 million women aged 15 years and older who are at risk of developing cervical cancer. Current estimates indicate that every year, 11,956 women are diagnosed with cervical cancer and 6,582 die from the disease in Bangladesh. It ranks as the second most frequent cancer among women and second leading cause of cancer deaths in women aged 15 to 44 years in Bangladesh. According to the hospital-based cancer registry of National Institute of Cancer Research and Hospital, cervical cancer tops the list of common gynecological cancer. It accounted for 70% of all genital tract malignancy admitted in Bangabandhu Sheikh Mujib Medical University in 2007. National Comprehensive Cancer Network guidelines are statement of evidence and consensus of authors regarding their views of currently accepted approaches to treatment. How the guideline was updated. At first, an electronic search of PubMed database was performed to obtain key literature in cervical cancer. Then the results were narrowed by selecting studies in humans. Results were confined to clinical trial, phase 2, 3, 4, RCT, meta-analysis, systematic reviews, and validation studies. NCCN guidelines cannot incorporate all possible clinical variations and are not intended to replace good clinical judgment or individualization of treatments. Many exceptions to the rule were discussed among the members of the cervical cancer panel during the process of developing these guidelines. NCCN consensus may be categorized into 3 groups. Category 1, based upon high-level evidence, there is uniform consensus that the intervention is appropriate. Category 2A, based upon low-level evidence, there is uniform consensus that the intervention is appropriate. Category 2B, low-level evidence, there is consensus that the intervention is appropriate, but the consensus was not uniform. And category 3, based upon any level of evidence, there is major disagreement that the intervention is appropriate. Now, before going to definitive treatment, a thorough workup is needed that include history, physical examination, complete blood count, cervical biopsy, cone biopsy, liver function test, renal function test, imaging, sentinel lymph node mapping are category 2B recommendation. If the disease is stage 1A1 with LVSI and stage 1A2, then there are two options, surgery or radiotherapy. Surgery include modified radical hysterectomy with pelvic lymph node dissection. Para-aortic lymph node sampling and sentinel lymph node mapping are category 2B recommendation. Radiotherapy is pelvic radiotherapy with brachytherapy. For stage 1B1 and 2A1, category 1 treatment option is surgery, that is radical hysterectomy with pelvic lymph node dissection with or without para-aortic lymph node sampling, or radiotherapy that includes pelvic radiotherapy with brachytherapy with or without concurrent chemotherapy. Radiation can be an option for medically inoperable patients or those who refuse surgery. Now, for stage 1B2 and 2A2 tumor, actually there are 4 recommendations, and category 1 recommendation is radiotherapy, definitive pelvic radiotherapy with concurrent chemotherapy with brachytherapy. And other option is similar to this type of radiotherapy, but brachytherapy is needed a little bit lower dose with adjuvant hysterectomy. And category 2B recommendation is surgery that include radical hysterectomy, pelvic lymph node dissection with or without para-aortic lymph node sampling. There is another alternative recommendations that I will discuss later on. Now, when fertility sparing is an issue, if the disease is stage 1A1, no lymphovascular space invasion, cone biopsy is indicated. If margin is negative, then no further treatment is required, only follow-up. But when the margin is positive, then 2 modalities of treatment, either doing repeat conization or trachelectomy with pelvic lymph node dissection. For stage 1A1 with LVSI and stage 1A2, again cone biopsy is the recommendation. If the margin is negative, no further treatment is required. But when the margin is positive, then either repeat conization or surgery that include radical trachelectomy with pelvic lymph node dissection. And here also para-aortic lymph node sampling and sentinel lymph node mapping are category 2B. Presence of LVSI that meets this criteria with or without concurrent chemotherapy. And when positive for pelvic nodes or surgical margin or positive parametrium, then category 1 recommendation is pelvic radiotherapy with concurrent chemotherapy with or without vaginal brachytherapy. If para-aortic lymph nodes are positive by surgical staging, then distant metastasis should be excluded by doing X-ray chest or PET-CT. If distant metastasis is negative, then para-aortic lymph node radiotherapy with concurrent chemotherapy with pelvic radiotherapy with or without brachytherapy. But if the distant metastasis is present, which is biopsy confirmed, then systemic therapy is indicated. Now for the advanced stage disease, that is stage 2B, 3, 4A, and early bulky stage. The pelvic lymph node is positive, then treatment is pelvic radiotherapy, concurrent chemotherapy and brachytherapy. But when the para-aortic lymph nodes are positive, then distant metastasis should be excluded. If the distant metastasis is positive, then systemic therapy, but if there is no distant metastasis, then extended field radiotherapy with concurrent chemotherapy and brachytherapy. Sometimes we get patients after hysterectomy, that is incidental finding of invasive cervical cancer after simple hysterectomy. Then histopathology, review of the histopathologic slides of hysterectomized specimen is required. If the disease is stage 1A1 without any lymphovascular space invasion, no further treatment is required. But for stage 1A1 with LVSI or stage 1A2 and margin is negative or negative imaging, then there are two options, surgery and radiotherapy. Radiotherapy includes pelvic radiotherapy with brachytherapy with or without concurrent chemotherapy. And surgery includes complete parametrectomy with upper vaginectomy with pelvic lymph node dissection with or without para-aortic lymph node sampling. When margin is positive or positive imaging or gross residual disease is present, but there is no negative lymph nodes in imaging, then pelvic radiotherapy, concurrent chemotherapy,
of cervical cancer management as mentioned by NCCN. We have amongst us a number of experts from Australia, Singapore, as well as Bangladeshi counterparts. The purpose of this mini symposium was really to underscore what lies between ground reality in developing countries and the method of treatment where state-of-the-art facilities are available. Cancer cervix is an extremely common condition. I need not go into that. But in a country where there are resource constraints, both at governmental level as well as individual levels, patients, especially those who work in government institutes, are perhaps subconsciously conditioned to go for minimalistic approach in terms of investigations. That is CT scan, MRI. Now, those of you who have come here from abroad, you are comfortable with ordering CT scans, MRI in case of CS cervix. But FIGO states that for surgical staging, you need not go into all these expensive high-tech tools. So I would now request you all to please comment on these NCCN guidelines with special reference to management of cancer cervix in countries where there's paucity of resources. This would be very much helpful for us. So I now request Dr. Kailash Narayan. He's from Peter MacCallum's Cancer Center, Melbourne, Australia. Sir, your field, as I could understand, is radiation oncology. And you are comfortable with LINAC machines, which we do have, but in certain in a limited number. So what is your suggestions regarding the use of LINAC or Cobalt machine in our context? As well as I would like to remind you that we have a backlog of patients waiting for radiation therapy. substitutes. The machines are sometimes working, at other times they're out of order, or the patient is unwilling to...
Okay, so answer is no.
Yeah.
If the CT scan is not available...
It is available sometimes, other times it is not.
Okay.
Not all the time.
No, I think you need to give me a scenario and then I can say how I will treat it.
Okay,
So,
sir.
if you are asking me how will I treat a patient when there is only cobalt machine and not even intracavitary brachytherapy?
No, we do have brachy.
Okay. So there is a cobalt machine and there is intracavitary brachytherapy, and the patient is given to me who is not fit for surgery because this is advanced cervix cancer patient. I will do a chest X-ray. Is IVP available?
Yes, certainly.
Okay. So I will do of course, I will first examine in the clinic. I don't believe examination under anesthesia is essential. I will do an IVP, I will do a chest X-ray. If IVP is normal, if chest X-ray is normal, then I will just treat pelvic radiotherapy and intracavitary brachytherapy.
It is available, yeah.
And prescribe to point A for the treatment. However, if you have an ultrasound available,
certainly,
then I would recommend that your radiation oncologist should study the result of giving conformal brachytherapy using ultrasound.
Ultrasound would be a substitute for sophisticated tools.
Yes.
That's very interesting.
So if you can use ultrasound, and we have published quite a large series where we have given conformal brachytherapy using ultrasound, transabdominal ultrasound, and our results are second to none. And the toxicity, we have been able to reduce long-term toxicity using ultrasound from 18% to less than 3%. And so I would recommend that people get familiar as anywhere else. The difference might be that because you cannot rule out metastasis for sure, that some of them will have metastasis and therefore the treatment will not be successful. But those patients whose disease is limited to pelvis, you should be in a position to give similar survival. The other possibility is that you may not know, if you don't have a CT scan, whether to give the lymph node boost or not. Because giving 40 gray to 45 gray to whole pelvis in advanced cervix cancer where you cannot see nodes may be difficult. In that case, you can simply assess and give parametrial boost, which will also give the nodal boost at the same time. So you can give 45 gray to the whole pelvis, and then you can give anywhere between 6 gray to 10 gray parametrial boost, and then give ultrasound-guided conformal brachytherapy, and you should still be able to produce reasonably good results.
Thank you, sir, for telling us informing us about the role of ultrasonogram-guided brachytherapy. This is something new, and this will certainly help us in tailoring our mode of treatment plans. If the results are similar...
Just a minute. The danger of not using conformal radiotherapy and prescribing to point A is that if you are giving 50 gray and you are giving 10 gray boost and then prescribing to point A, many times you are prescribing to far wider area. Because when we have given concurrent chemoradiotherapy and then done conformal brachytherapy, we find that our median dose to point A is actually less than 70 gray. But if you're going to prescribe according to the point A system, then they recommend giving 80 to 85 gray.
Yeah.
That means the envelope that is getting 85 gray dose is much larger, and sometimes after concurrent chemoradiotherapy, most of the patient tumor shrinks. So the intestine can get into that field and start getting very high dose, and that is the reason for having very large complication rate. The other thing you can do is try and treat them on belly boards so you can minimize the toxicity to intestine, And afterwards, you need to educate them in using vaginal cylinder with Ovestin cream. So if you keep the dose limited and use vaginal cylinder and cream, then you can also reduce the toxicity that way.
Thank you, sir, for your valuable opinion. Now, supposing in a patient with cervical cancer 2B and onwards, how long should be the treatment time? Because what is said that it should be completed with a specified time, and the more the delay, the greater is the chance of recurrence. So, is it possible to counteract it in some way?
So,
because there is a long queue, you can't really start the RT schedule in time, neither can you finish it many times in time.
You have to, I think, if you finish your external beam radiotherapy without any break, then, and you can certainly compensate for slightly longer time interval between external beam radiotherapy and brachytherapy by giving slightly higher dose during brachytherapy, and that will compensate for the lost time. But in order to do that, you really need conformal brachytherapy so that you can comfortably increase the dose for the primary site. Because once the pelvic radiotherapy is finished, the extended overall treatment time actually doesn't relate to the lymph nodes and the pelvis. It only relates to the primary tumor. So they recommend that your overall treatment time should be finished within 56 days. For every additional day, you need to give 0.6 gray more in order to compensate. But this 0.6 gray more only need to go to the primary tumor because the pelvis has already finished treatment within the prescribed time.
Thank you, sir. So since we are stretched for time now, I would request our second panelist, Dr. Jeffrey Low from Singapore. So what are your comments regarding treatment of cervical cancer, especially in the context of developing countries? From the surgical point of view. From the surgical point of view.
Yeah, surgical point of view is only one aspect. I think we all know that cervical cancer is the most preventable cancer, right, in the human body. We know exactly what causes it. So in terms of restricted resource environment, I would say that you really need to think very hard about allocating resources for vaccination. Nowadays, the data shows that the 2-dose vaccination with Gardasil in the younger teens is as effective as 3-dose. So that will give you a lot of cost savings and give you a long-term prevention to stop the epidemic of cervical cancer. Number 2, I would say it's very good that you launch your cervical screening program. I think you need to think and focus a lot of resources on screening, whether it's going to be with VIA and simple treatments for high-grade disease. That will really be another important step in stopping the epidemic of cervical cancer, because you can focus a lot of attention on treatment, but if you don't stop the causative factors in the country that's causing cervical cancer, then you're going to continue to be flooded with overload of cases. With regard to the treatment, I think that the organization of care is very critical. You can discuss all the minutiae about treatment fields and surgical techniques and all that, but if you don't organize in a meeting like this where you're talking about treatment protocols and guidelines, it's very important to have the collaboration and the buy-in and participation of your radiation oncologists whom you work with, as well as the medical oncologists. And I would say the radiologists will provide you the services for the imaging, as well as the pathologists who are very important in looking at your punch biopsies, in assessing your microinvasive disease and so on. So in terms of the surgery, I think from what I can see from the doctors here are all very, very good surgeons. So I don't think there's anything much further that I can add other than selecting your cases for surgery very wisely. So if it's not possible to do a CT, then certainly, as we've all agreed, the clinical assessment is very important. Training your fellows to do a very good pelvic and rectal examination for the patients to assess the resectability of the primary tumor, whether there's any parametral involvement, side wall involvement, rectal, anterior vaginal involvement, pouch of Douglas involvement, the resectability. The rest of the imaging, perhaps you can rely on ultrasound to exclude any bulky lymph nodes, a chest x-ray to make sure that there are no lung metastases, ultrasound of the liver to make sure that the liver is clear before you make a decision for surgical treatment. So this will select out many of the cases whom you would then shunt over for concurrent chemoradiation.
So you're in favor of concurrent chemoradiation in cases where ultrasound shows that there might be bulky nodes, or when the growth is massive or huge, naturally we can assume that the nodes are enlarged and many of them might be metastatic. So in these situations, should we go for surgical management or switch directly to concurrent chemoradiation?
Well, I think in this type of situation, that's when you might then want to send the patient for a proper CT, or if possible, if you have a PET scan somewhere in the city to actually assess these might be the patients that you then assess with a proper contrast CT scan to have a very good look and see whether these bulky nodes are, how far they are extending. If they are extending into the mediastinum, I don't think there's any role to do a surgical debulking. But it's quite fairly isolated on one side of the pelvis or isolated in the periaortic region below the renal vessels. I think your surgeons are good enough to perform a resection just of the bulky nodes before then putting the patient to concurrent chemoradiation for the primary disease as well as the nodal disease.
Thank you, Dr. Jeffrey, for giving your opinion regarding various aspects of carcinoma cervix.
I think the other comment that I'd like to make is in commending the planning to form a Gynae Oncology Society. I think the society will be poised to take a leadership role in planning resources for the country. The traditional view has always been that in a population, it's usually the ratio would be 500,000 population to 1 GYN oncologist, fully trained, without doing any obstetric practice, without doing any benign gynecology practice. So if you fully subspecialize your people to dedicate themselves to GYN oncology training, you can then plan the number of trained subspecialists who will be able to fully serve your country.
Thank you, Dr. Jeffrey. Now I request Professor Sabra Khatun to please give her opinion regarding NCCI guidelines as mentioned by Dr. Jannatul Firdaus and her comments.
Thank you, Dr. Fauzia, for asking me to say something about the NCC guideline. Comments about NCC guideline, which has been read by Dr. Jannatul Firdaus. NCC, there is nothing to do any comment about the NCC guideline because it is international. But the guideline which has been shown by Dr. Jannatul Firdaus is, I think, it's very critical. It's very critical thing, and it's very difficult to obey the NCC guideline for practical point of view. And practically, I am in question whether the very developed, well-developed countries like Singapore, they are able to follow completely the NCC guideline. Sometimes they have to, is it not? Sometimes they have to manage the patient according to the available situation. And we also have to manage the patients according to our situation available, according to the availability of the radiotherapy, availability of the expert surgeon. Expert surgeon is very important thing. And the one thing, we have to develop the expert team. We have to develop the expert team because the surgery for cervical cancer it is a specialized thing. We have to do very critical analysis of this situation and to take training. Training is very important. To do a cone biopsy, to do a lip biopsy, it needs a particular training. Without training, these surgical procedures are not possible. So I think for the application of the NCC guideline, we have to make ourselves very trained up, and we have to make training program, frequent training program about the surgical procedures which need for the management of cervical cancer. This is the different procedures. To do a cryotherapy, to do a cold coagulation, to do a lip biopsy, and to do cone biopsy, and radical hysterectomy. All these are very specialized training needed. So we have to do this training program, and we make our perfect manpower and make our perfect team for the surgical management of these cases. So we will try to apply the NCC, to try to follow the NCC guideline. Those has been read by Dr. Jannatul Firdaus. But before that, we have to make ourselves prepared for follow this NCC guideline. Thank you.
Now I thank you, Madam, for your comments. Now I request Dr. Khurshid Jahan Maula to say a few words.
Thank you, Madam. Madam Chairman, Madam. We should not have any headache for the criticality of guidelines, because no guidelines for long last or forever. Every 2 to 3 years, the guideline can change or may be changed according to the need of the, or according to the review of the mentality of the reviewer and the scientist of the patient who deals with cervical cancer. Cervical cancer is a common cancer, everybody know, and it is a very virulent cancer. It is the priority. It is prioritized before only the gynecologist can do the cervical cancer. But I am astonished in '92 that it is only to be done by the gynecologist, not the general gynecologist. But everybody has the right to do the surgery. If they do have the proper diagnosis and treatment procedure, then it will be possible. In our country, diagnosis should be done from the speculum examination, to visualize the cervix, whether the cervix is healthy or unhealthy. Because I have seen personally in my office chamber that hysterectomized patient, their histopathological report are squamous muscle carcinoma, and it is opened, it is laparoscopy done for PID or fibroid uterus, but they do not have examined the cervix, whether it is healthy or unhealthy, or any pap test or any cervical biopsy. So we have to take care from the speculum examination up to exenterization with their own expertise, own knowledge, and own attitude. Thank you, Madam. Thank you.
Now for the final comments from Dr. Parveen Akhtar Banu, who has a huge experience in dealing with CS cervix. Dr. Parveen Akhtar Banu.
Thank you very much. As we know, the cervical cancer is the most preventable cancer, so we should give emphasis on the screening and awareness. And women should understand the importance of the screening. And about the Guidelines is there, but we have to follow the guidelines. Half-heartedly done anything, surgery or radiotherapy, is not acceptable and does not help patients. Many a times we see half-hearted done surgery and also radiation therapy. And doctor was telling that, what about the gap between the surgery and radiation therapy? Especially we see after completion of external radiotherapy, patient is referred late, and brachytherapy time, it may be there about 3 months, 4 months time delayed. So we cannot expect good result with this huge gap interval of treatment. Treatment should be continued with external radiotherapy. At the later part of the external radiotherapy, brachytherapy should be started. But problem is this, we don't have much facilities. Centers are having external radiotherapy, they don't have brachytherapy, so patients are referred from some other centers and there is a long queue. So usually the treatment is not done as we desire or plan. That is problem. And Dr. Kailash was telling about the conformal ultrasonogram guided brachytherapy, which is not done in our country and we are not experienced, but we should train our people as we don't have that much facilities in every center to do CT guided brachytherapy every time. So it will be helpful, I think. So thank you very much for patient sharing.
Assembled participants, sorry for the session because we're already running behind time and people are having the refreshments in the same room, so perhaps you could not totally concentrate on it. But whatever you learned, I hope will be useful to you all. Now it's time for the crest presentation ceremony. Crest, there. Now I request Professor Sabira Khatun to please hand over the crest to Dr. Jeffrey Lowe, who appears to be a member also. Khurshid Jahan Maula to please present the crest to Dr. Kailash Narayan. Thank you. Now our local experts will exchange their crests. I request Dr. Parveen Akhtar Bano to hand over the crest to Dr. Khurshid Jahan Maula. Thank you very much. Now it's time for Dr. Khurshid Jahan Maula to reciprocate by giving crest to Dr. Parveen Akhtar Banu. We are running a sort of seesaw game because time constraint. Thank you. Now, Dr. Jannatul Firdaus, who took the trouble to inform us about the recent version of NCCIN, she also deserves one. May I request Dr. Khurshid Jahan Maula, who is a close mentor and friend, to please do the honors. Dr. Khurshid Jahan Maula to Jannatul Firdaus. Thank you. With this, we come to the conclusion of our ceremony. Hope you had a good time, valuable time. Thank you.
Thank you, Honorable Presenter, Dr. Jannatul Firdaus, Chairman, Professor Fawzia Shabnam, and the panel of experts. I would like to request to start the S.F Haq Memorial Symposium. And for that, I would like to invite the chair of this session,
May I request Dr. Jannatul Firdaus to hand over the quest over Professor Fawzia Shabnam.
Sorry for this misconvenience. Now I would like to conclude the session of the mini symposium Gyno-Oncology, and at the same time I would like to start the S.F Haq Memorial Symposium, and for that I would like to request Professor H.R. Ansari and Professor A.M.M. Shariful Alam and the rapporteur of this session, Dr. Firdaus Sharia Saeed, to have a seat on the dais to start this session. Again, I would like to announce, I would like to request to start the session of S.F Haq Memorial Symposium, and for that, I would like to request our session chair, Professor H.R. Ansari, Professor A.M.M. Shariful Alam, and our moderator, Dr. Firdaus Sharia Saeed, to have a seat. Now I would like to request our moderator, Dr. Firdaus Sharia Saeed, to conduct this session.
Thank you very much. Good afternoon to all participants, my teachers and my colleagues. As we are running short by 1 hour, I would like to basically invite Professor Dr. P.S. Chow and Dr. Lim Hong Liang to please come to the dais and take this seat.
Page number কত তো?
Sir, 59 ছোট ফ্লায়ারে 59 Professor P.S. Chow from Singapore and Dr. Lim Hong Liang from Singapore and Dr. Professor M.S. Salam.
শর্টকাট করেন একটা একটু করে ডাকেন যাবো
Okay.
একটা একটু করে ডাকেন এন বসানো
To start with, I would like to introduce Professor P.S. Chow. He's a renowned and professor of hepatocellular surgery and hepatocellular carcinoma, not only carcinoma, total hepatic surgeon from Singapore, and most of us know him. And his presentation is an evidence-based approach to management of HCC, the practice guideline of the National Cancer Center, Singapore.
Yes, thank you very much. Can I have my slides up, please?
সবগুলো শেয়ার থাকলে কালো কালো করলাম সকালে এটা লোক না না এটা না কিম ওটা লিম ছিল এটা তো কিম ইয়ারে চৌ নাম কি এটা এটা কি চোদাকার এটা
সবাইকে স্যার সবাইকে একটু রিকোয়েস্ট করবেন এটা এসে বসে সেটা ঠিক আছে না মনে হয় স্ক্যাটার্ড অবস্থায় আছে
Attention please, I would like to draw the attention of the audience. Please, I'd like to request all to have a proper seat here in front of the dais, so that you should not run around or walk around scatteredly. These are very important lectures. I'm sure that all of you will be benefited immensely by listening to all these plenary lectures. Thank you.
S.F Haq Memorial Symposium. S.F Haq Memorial টা বারবার বলবেন একজন শেষ হলেই দুই ইয়ার অন S.F Haq Memorial Symposium. S.F Haq স্যার সম্পর্কে একটু ব্রিফ করে দিলেও পারতেন না যাক
So since I have some time before the slides are to be discussed, I'd like to draw your attention regarding this symposium. Those of you don't know, Professor S.F Haq, he was the pioneer oncologist in this country. During the period of East Pakistan, he was the first person from UK to have his degree, post-graduation degree, and he started oncology department in DMCH. And during the 60s, Dhaka Medical College, the department of radiotherapy, was at par with all the departments of foreign countries. That was the era of cobalt era, and the cobalt machine that was from Canada, the latest machine at that time, that was available there, and the department was also like that. And at that time, we had three, most likely, FRCR in that department. And we all, our teachers, including our teachers and ourselves, are immensely grateful to him. And he started the Bangladesh Cancer Society also. So that's why this plenary session on his name.
Because the worry one is, okay,
So Professor Chow, please start.
Yes, thank you very much for your kind introduction. Good afternoon, ladies and gentlemen. It's a great pleasure and a great privilege to be here to attend your S.F Haq Memorial Symposium. And I'd like to thank Dr. Kamal and the members of the organizing committee for inviting me. My talk today will be on an evidence-based approach to the management of hepatocellular carcinoma. And I'll be talking about the practice guidelines of the National Cancer Center, Singapore. Now, as you know, the last decade has really seen better approaches and more efficacious therapies for HCC, such as better survival with improved surgical approaches, selective internal radiation therapy, radiofrequency ablation, and also, of course, new systemic therapies. Now, all these have resulted in significantly improved clinical outcomes. And paradoxically, the challenge to the clinician now is how to incorporate this new evidence to current clinical practice. Because for the individual patients, the best treatment depends on the stage of the cancer, the function of the liver and the health of the patient, of course, and also the availability of cutting-edge expertise and therapeutics. And the rapid evolution of new therapeutic guidelines or modalities has made it increasingly challenging for an individual clinician to be able to deliver optimal care for the patient without the help of a multidisciplinary team. It is with this thing in mind that the National Cancer Center in Singapore on the 2nd of June last year launched a comprehensive liver cancer clinic to offer comprehensive cutting-edge diagnosis and treatment in the context of a multidisciplinary team that will comprise surgical oncology, medical oncology, radiation oncology, nuclear medicine, interventional radiology, oncologic radiology, as well as pathology. And once the clinic is launched, one of the first aims of that group of physicians was to develop an evidence-based multidisciplinary practice guideline. And this was developed by a group of 19 doctors from 7 specialties. And these guidelines have been published online since September 2014 last year, and is currently in press to be published in the journal Liver Cancer. Now, the existing data was clearly and carefully selected and sieved and assessed based on the Oxford Center for Evidence-Based Medicine, with level 1A being the highest and so on. And this is incorporated to develop the guidelines. So, and the spectrum of the guidelines was wide to include both diagnosis, workup, management of early HCC, as well as the management of locally advanced and metastatic HCC. So what I'll do for the rest of my talk is to go through these indications one at a time, starting with the diagnosis of HCC. The current standard of care for diagnosis of HCC is really the 4-phase multi-detector CT scan or dynamic contrast enhanced MRI. And the features would be arterial hypervascularity and venous or delayed washout on the background of a cirrhotic liver. However, sometimes for very highly suspicious lesions that do not fulfill this criteria, then we will advocate the use of biological imaging. And today, the most common biological imaging modality used is really gadocytic acid or Primovis. So in the dynamic phase, Primovis behaves like any other intravascular agent. But in the uptake phase, it is taken up in normal cells, but not taken up in cancer cells. So this makes it a very, very sensitive and specific tool for diagnosis of difficult cases or small lesions that might be HCC or other cancers. Now, after diagnosis, of course, we need to work up the patient and then to stage the patient. And the staging of the patient and the workup must be very comprehensive and should include the CT chest. And in the case of patients that might be potential candidates for resection, should include the indocyanine green retention test. And with the end of workup, we should stage the patient. And this is important because the management of HCC is really predicated on, firstly, the stage of the cancer, and then secondly, on the function of the liver. And after workup, we'll stage the patient to either early stage HCC, locally advanced HCC, or metastatic HCC. Now, early stage HCC is defined as lesions within the Milan criteria. That is to say, HCC that is solitary, less than 5 cm, or less than 3 tumors, less than equal to 3 tumors, each not more than 3 cm, no invasion of blood vessels, and no evidence of distant spread. This is a very important concept because treatment of this group of patients is potentially something that can confer survival. So in this context, surgery is potentially curative for early HCC if the liver function is good and if there is adequate future liver remnant. And liver function should be assessed by a dynamic test such as the indocyanine green retention test. And it is also important to assess whether the patient has adequate future liver remnant. In a non-cirrhotic liver, about 25% would be adequate. But if the liver is cirrhotic, even in the face of a good ICG and good Charles-Pugh score, a 40% future liver remnant is crucial. We look at the outcomes of all patients resected within the Milan criteria and published this in the British Journal of Surgery and reviewed more than 4,000 cases. And the 5-year survival for this group of patients is now 67%, so conferring them a potentially curative modality of treatment. So for patients who are resectable within the Milan's criteria, surgery should be the first way to go. But there are many patients who are unresectable, not because the tumors are large, but because they either have poor liver function or that the future remnant is actually inadequate. So in this group of patients, there are 2 other modalities that potentially can confer cure as well. One is radiofrequency ablation for small tumors, and the other one is liver transplantation. Now, for tumors that are few in number, that is to say 3 or less, and each one of them is relatively small, less than 3 cm, radiofrequency ablation has been shown to confer very good survival, reaching 50% in many cases, thereby being potentially curative. And transplantation will be important for patients who have poor liver function that cannot be resected, but have tumors that are a bit too big for RFA, because in this group of patients, liver transplant again confers very important survival advantage. This is a very large series published from the United States of more than 4,482 patients. So in patients who are transplanted within the Milan's criteria, the 5-year overall survival is 67%. And this approximates very closely to the 5-year survival for resection, which is 67%. So you may have a patient now who is with early tumor within Milan's criteria and is Charles-Pugh A with very good liver function, in which case, of course, this patient is now a potential candidate for liver resection as well as a potential candidate for liver transplantation. So with these two also possible, which would be a better modality of treatment. We did a very effective, a very detailed cost-effectiveness liver resection and I think being experienced clinicians, you know that most patients present to us like that. Many of these patients actually still have good liver function, and in this group of patients, in carefully selected patients, after a multidisciplinary board discussion, they can also be candidates for resection. Although we know that, like this data from our own publication shows that resection beyond the Milan criteria actually gives you poorer survival than within the Milan criteria. And as the number of lesions get higher, the survival becomes poorer. In fact, resection of any HTC beyond 2 lesions usually give very poor survival. And of course, even for single tumors beyond 7 cm, they usually do badly as well. Many of these patients are also patients with poor liver function, in which case transplantation can still be a consideration, although they are beyond the Milan's criteria. And there are many attempts to try to give similar survival with transplantation beyond the Milan's criteria, meeting what is known as the extended criteria. But it is quite inevitable that as the tumor burden gets higher, the results of transplantation will be progressively poorer. Now, many of these patients with good liver function are in fact treated with local regional therapy. And local regional therapy is probably what is used to treat most patients with HTC in the world today. There are 2 main local regional therapies. One of them is transarterial chemoembolization, which is familiar to everyone because this is quite low-tech, relatively cheap, available to most countries in the world. The disease control rate is approximately 40%. And in this conceptually, chemotherapy of various combinations is introduced via the hepatic artery into the tumor, after which the artery is embolized. This requires that the patient's liver function be relatively good, in fact, be Charles-Pugh A. Complete regression is uncommon, and unfortunately, when the portal vein is involved, this is contraindicated. This very nicely published paper by Sandro Bruno in Hepatology in 2011 helps us to select patients for TACE. TACE works best for patients with small tumors, fewer number of tumors, usually in one lobe. They do poorly for patients with bilobar disease, with many tumors, and with progressive disease based on previous tests. Now, the other main local regional therapy today is selective internal radiation therapy, or SIRT. This has a relatively higher disease control rate of approximately 80%. And this is based on yttrium-90, which is a radionuclide. The radionuclide is coated on the surface of very small spheres called microspheres, and introduced to the tumor through the hepatic artery again. This has high energy, but because it's beta radiation, the range is relatively short. So this is in fact ideal for brachytherapy. The microspheres are very much smaller than particles in taste, and because of that, the behavior is quite different when you introduce it into the body. It tends not to embolize, not to block the artery, but to lodge within the capillaries, thereby giving radiation within the tumor without causing embolization, which is very important when the patient has portal vein thrombosis. And after we introduce this, we usually do what we call a bronch column scan in order to visualize where the radiation has gone to. The results are quite promising and very, very encouraging. Our own data from Singapore shows that in patients with BCLC-B, the median survival for patients given Y90 is actually 23.8 months in this group of patients with locally advanced disease. And the other very important feature of this therapy is the ability to shrink the tumor down so that potentially curative therapies like resection may be performed. For example, in this patient where the tumor has involved the middle hepatic vein, the response has been good enough for resection to be carried out, and this patient has reached 5-year survival. Comparing the ability of both SIRT or TACE to downstage HCC for resection, it would appear that SIRT has a higher efficacy. And it is also useful for patients with portal vein thrombosis, in which TACE is actually survival of 6.5 months over 4.2 months. So today, if a patient has a metastatic disease, the standard of care would be sorafenib. Either that or the patient should be enrolled in some kind of clinical trial where more therapies may be made available to the patient. Now, the rapid evolution in the management of HCC has really arisen because of all these new therapies coming up. There's going to be a much greater number of options. And the challenge to the busy clinician now is how to adopt a practical approach to HCC that can incorporate all these new advances that comes with every month. And at the National Cancer Singapore, our approach is to adopt a multidisciplinary practice where all new cases are discussed in the context of our guidelines. And we intend that our guidelines be reviewed once every few years to incorporate new data that has come from clinical trials so that it's evolving and so that our patients continue to receive the best care for their stage of the disease. Thank you very much for your attention.
Thank you, Professor Cho. I think we'll have question and answer session after the end of the all the deliveries. Thank you for your very nice presentation, and we have all learned a lot from you. And okay,
thank you very much.
Sit. Next speaker, he is also very renowned doctor from Singapore. He is Dr. Lim Hong Liang, a friend of mine. He's going to deliver his speech, the speech regarding anti-PD-1 immunotherapy in advanced lung cancer. Dr. Liang, your time is 20 minutes.
Okay, Dr. Fergus, thank you for the introduction, and I would also like to thank the organizing committee and especially Dr. Kamal Woodin for the kind invitation. I'm a medical oncologist with an interest in lung cancers. For this talk, I will talk mainly on anti-PD-1, PD-L1 immunotherapy in advanced lung cancer. Okay, this morning we had a talk by my fellow colleague from Singapore on targeted treatment in lung cancers. You can see that targeted treatment has been around for the last 10 to 12 years and has resulted in significant improvement in the survival of lung cancers. But however, although it has very high response rate, had a much longer duration of response. That the chemotherapy, the duration of response is 6 to 8 months. The targeted treatment is 9 to 13 months, resulted in a longer survival from median of 12 months to 24 to 6 months. However, almost all patients on targeted treatment, invariably, they will develop resistance and progress. So although they had increased the survival, the proportion of cure is very low and did not increase. The other limitation of targeted treatment is so far is limited to non-small cell lung, and it's also limited to adenocarcinoma and large cells, and limited to those only with mutation. So far, targeted treatment has not gained a foothold in the squamous cell, non-small cell lung cancers in small cells. So in general, I think about 1/3 or less of all lung cancer patients are amenable to targeted treatment at this stage. For this talk, I'm going to go through some points on immunotherapy, 2 slides on mechanism of action, and as a practicing oncologist, I will just go through the clinical data on anti-PD-1 and PD-L1 agents in the trials leading to the approval by FDA. For this year, for the first time, we have seen two immunotherapeutic agents or antibodies being approved by the FDA for the treatment of lung cancers. PD-1 is nivolumab and pembrolizumab, and the third one, atezolizumab, is anti-PD-L1. We'll also go through some data if we have time. It is also seen to be effective in small cell lung cancers. We'll go through some of the toxicities, the general and immune-mediated, and whether PD-L1 staining positivity is a good predictive marker for this form of treatment. I think so. I'm not an immunologist, so I just go through the general principle. The reason why in the normal immune system, in the normal body, our cells will divide, and anything wrong with the cell division, the abnormal cells, will be picked up by the immune system and destroyed or cleaned up by the immune system. The fact that cancer exists in the body means that our own immune system failed to recognize the cancer and recognize it as foreign, and there's no immune, so they develop immune tolerance. For this group, this is a cartoon about how the normal immune system works. I will not go into the details. In general, immunotherapy so far, for the last many years, has been trying to stimulate or increase the immune system against the cancer cells. But the checkpoint inhibitors, the 2 drugs that are like ipilimumab in melanomas and the anti-PD-1, PD-L1 is actually checkpoint inhibitors. Inhibition of it actually reduces the negative regulation of the immune system. So this is on the left. On the left, you have see a T cell in yellow and a tumor cell in purple. We know the PD-1 receptor on the T cell actually inhibits immune response. It's a normally present receptor to prevent the body immune system overstimulating to prevent autoimmunity. The PD-1 receptor is expressed preferentially by T cells when they are prolonged antigen exposure, like when the tumor is present for a long time. And the tumor can block the immune response by expressing PD-1 ligands. There are 2 ligands, PD-L1 and PD-L2. And the binding of the PD-1 to its ligands, PD-L1 and PD-L2, inhibits effector T cell function. So anti-PD-1, PD-L1 ligands or agents actually block the binding of PD-1 to its ligands and to restore the immune response. I go through the clinical data for the first drug, the nivolumab, which is the anti-PD-1 monoclonal antibody. These are phase 3 studies comparing nivolumab with docetaxel in the squamous cell population in second-line setting. So nivolumab at the dose of 3 mg per kilogram IV once every 2 weeks was randomized against docetaxel at the standard dose at 75 mg per meter square every 3 weeks. And both were given until progression or until unacceptable toxicity. Notice this is a second-line setting. All the patients will receive at least 1 platinum doublet. So in this was first presented in ASCO this year and updated in ESMO a few months ago. So there you can see from the graph, there was an overall survival benefit of nivolumab versus docetaxel in the second-line setting in squamous cell. The median survival was 9.2 months of nivolumab versus docetaxel was 6.0 months, with a hazard ratio of 0.62. If you're familiar with the second-line treatment for non-small cell lung cancer for the past 1 to 2 years, we had 1 or 2 new drugs, the nintedanib, and you have the ramucirumab. And these, although they had survival benefit, the hazard ratio was about at the range of 0.8. So 0.62 is a 38% reduction in risk in death. So it's a significant reduction. And you can also see that the median progression survival is also prolonged from 2.8 months to 3.5 at a hazard ratio of 0.62. The response rate, unlike targeted treatment, the response rate, the range of 60 to 70%, but you can see that in the next few, in the rest of my presentation, the response rate for unselected patients with the immunotherapy is about 20%. In second-line setting, this 20% is still higher than second-line chemotherapy, or 9-10%. But you can see on the middle, the median duration of response. Although the response rate is low at 20%, for those who have responded, they have very long, prolonged, and meaningful duration of response, and in this case, it has not been reached, where the chemotherapy is 8.4. But I can tell you from the second, it is usually probably more than double the duration of response of chemotherapy. This is a swimmer's plot for the patients who have responded for the duration of response. On the bottom, the green lines are the median duration of response for those patients treated with chemotherapy. The median duration of response is 8.4 months. And the top part, the top half, the part in blue, is the duration of response for nivolumab, and most of them, they're ongoing response, and that's why the median duration of response has not been reached. But from the graph, you can see that the duration of response is at least double that of the median duration of response of chemotherapy. That means probably more than 16 months. And the trial was first presented in May in ASCO, and it's now been published in the New England Journal of Paper in July and updated in ESMO. And because of this trial, nivolumab was approved by the FDA US in March this year for the second-line treatment for advanced squamous cell carcinoma. In a parallel trial, this is a similar trial design for non-squamous, non-small cell lung cancers. Again, the design is similar. Second-line, non-small cell lung cancers, non-squamous, nivolumab at the same dose, at 3 milligram per kilogram, IV every 2 weeks, again compared to docetaxel, and the primary endpoint is again overall survival. Again, similarly, in this trial, they achieved the primary endpoint of improvement in overall survival with a hazard ratio of 0.73 with a highly significant p-value. And again, you look at the overall response rate, again, it's in the range of 20% for immunotherapy and 12% for the chemotherapy. And in this particular trial, the median duration of response was reported as 17.2 months, more than 3 times the median duration of response for docetaxel at 5.6 months. Because this is, you can see, I want to point by patient subgroup, in particular the smoking status. So far, has been consistently been shown that the response rate for immunotherapy is actually higher in patients who are smokers versus non-smokers. In this particular trial, there was about 20% of patients who were smokers, who were never smokers, and in smokers, the response rate was in smokers, the response rate was 22%, and the never smokers was 9%. So it's an unusual thing that we see in the chemotherapy trials where the response rate is actually higher for nivolumab. And also look at the EGFR mutation status. You can see from this trial, actually for those patients who have EGFR mutation, the response is actually lower for patients treated with immunotherapy, 11%, versus 18% for mutation negative. This is the reverse of chemotherapy. And because the response rate is low, then we see whether we can select patients to enhance, to enrich the patient population to increase the response rate. So the expression of PD-L1 has been studied as a potential predictive marker. In nivolumab, the PD-L1 expression level was graded as more than 1%, more than 5%, or more than 10%. But you can see the overall survival was similar, regardless of how many percent, what's the percentage of cells positive of PD-L1. So for nivolumab, expression of PD-L1 is not a good predictor for overall response, and also for not a good predictor for overall survival. And again, this paper was first presented again in ESCO this year and published in the New England Journal in September. It was approved by the FDA US for the treatment of non-small cell lung cancers, non-squamous, second line, about 1 month ago. The second PD-1 agent is pembrolizumab or Keytruda, and again, this has been published. The approval by FDA was not based on the phase 3 trial, but based on the very large phase 1-2 study, about 500 patients, the Keynote 001. You can see the study design. These are very big studies, had a few components. Some catered for PD-1 positive, PD-1 positive or negative, and it also has a variable dosing. It varies from 2 milligrams per kilogram every 3 weeks to 10 milligrams per kilogram for every 3 weeks to 10 milligrams per kilogram every 2 weeks. And see that if you take all patients together, the overall response rate is again the 20% mark. So it's very consistent. In unselected patients for PD-1 treatment, the response rate is about 20%. And in this particular cohort, the duration of response is 12.5 months. Bearing in mind that this is the phase 1-2 studies, the patients are more heavily pre-treated. But again, you can see in this pembrolizumab, in these 500 patients, you can see again the response rate in smokers. The response rate in smokers is again higher compared to the patients who have never smoked, 22.5% response rate in smokers versus 10 or half the response rate in smokers. Okay, in this particular study, the PD-L1 was, again, they examined the PD-1 staining. So they categorized at less than 1%, the proportional score less than 1%, 1 to 45%, and more than 50%. At least in pembrolizumab, only patients with a proportional score of staining more than 50% has an advantage. You can see that if you have more than 50% staining, the response rate is 45%, versus less than 20% if you are less than 50%. So if you take the 50% mark as a positive, those who are positive of PD-L1 in the treatment of pembrolizumab has a greater survival compared to those below 50%. So on the right, you can see a randomized study, small randomized studies between a few dose ranges. So the outcome is like this. There seems to be no dose response in the treatment of lung cancers with pembrolizumab. So previously, the recommendation for the clinical dosing of pembrolizumab was 2 milligrams per kilogram every 3 weeks. But since the approval, I think going forward, the company has decided that you recommend a flat dosing of 200 milligrams every 3 weeks. So if you look at the different recommendation, going forward, the recommended dose of pembrolizumab will be 200 milligrams flat every 3 weeks. This one I just want to point out, but what is the proportion of patients, if you treated with pembrolizumab, will stain with IHC, what is the proportion of patients that has a proportional score of 50%? It's actually about 1/4. So majority of patients will stain negative for PD-L1. But if you belong to 1/4 who stain positive of PD-L1, you get the response rate of 45%. So this is one way we can enrich a patient like nivolumab. There's no predictive factors, markers, the response is 20%. If you use pembrolizumab unselected, you expect the response rate of 20%. But if you do the PD-1 staining and select the 25% of patients who have more than 50% positive, then you can increase the response rate 45% to reduce the number of non-responders. And again, the pembrolizumab for the treatment of non-small cell lung cancers was approved by FDA about 1 month ago. But the FDA only approved for patients who are positive, that's more than 50% staining with the PD-L1 markers. This is the treatment side effects of one of the checkmate, one of the nivolumab studies. Across the group PD-1, PD-L1, the side effects is very similar. You can see that the main non-immune mediated side effects is mainly decreased appetite, fatigue, and asthenia. And compared to Taxotere, it is a very much better tolerated drug compared to chemotherapy. But of course, we are interested in what are the potential immune-mediated side effects. The commonest is actually thyroid. You can either have hypothyroid and hyperthyroid, but the prevalence is not high. You get diarrhea, colitis, you have transaminitis, but all these are mild, and the majority are grade 1 to 2. Grade 3 and 4 are clinical significant side effects. They are in the 0 to 1%. But the most worrying side effects that we talk about is pneumonitis. You can see that the rate of pneumonitis or any grade is 5%, but clinically significant grade is grade 3 to 4 is only 1%. Just in case you go away with that immunotherapy is quite harmless. This is a patient that I just got about 2 months ago. Non-small cell squamous cell. The CT scan on the right upper was the CT scan before the nivolumab. The nivolumab number, the first cycle was given on the 21st of September. And 3 weeks later, you had a CT scan on the lower left. You can see frank pneumonitis involving both lungs. And this patient required intubation in ICU stay, but was treated with high-dose steroids. And luckily, the pneumonitis recovered after 2 weeks. So although immunotherapy is very well tolerated, pneumonitis is not common. But on and off, we do have patients who are severely affected. The third PD-1 drug is atezolizumab. Unlike the other two, this is anti-PD-L1. Again, these are randomized studies in patients previously treated with non-small cell lung cancers. Again, it's randomized against docetaxel, the standard second-line chemotherapy. In this particular PD-L1 drug, atezolizumab, not only do they stain for tumor cells for PD-L1, they also stain the immune cells around the tumor for PD-L1 expression. So they have the matrix. So what it shows is if the tumor cells and the immune cells stain 0, stain negative for PD-L1, the median survival is similar for immunotherapy compared with chemotherapy. But if the tumor cell or immune cells stain positive for PD-1, the overall survival is significantly longer compared to chemotherapy. Again, in this drug, at least, PD-L1 staining is a predictive marker for atezolizumab for response and survival. So now you have 3 drugs, atezolizumab, nivolumab, and pembrolizumab. Then the problem is the PD-L1 expression. The test that they do is immunohistochemistry. The monoclonal that they use for all 3 drugs are all different. And also the cutoff point is all different. And for the atezolizumab, not only do they stain for tumor cells, but they also stain for the immune cells. For nivolumab, the cutoff point is 1%, 5%, 10%, where the pembro, the cutoff point is 50%. But to summarize, so far, the PD-1 staining or PD-L1 staining is only predictive in pembrolizumab and atezolizumab and not predictive for nivolumab. This is just 2 slides on pembrolizumab in advanced small cell lung cancers. This open label phase 1b study. Previously, for extensive stage small cell lung cancers, inability to receive chemotherapy or progress beyond first-line chemotherapy, 20 patients, what they see is a response rate for these 20 patients is about 35%, and a stable disease is 5%. You can see for the clinical benefit of 40%, which is one of the first drugs to be proven effective in small cell for many years. And this is my conclusion slides. So, and for anti-PD-1 and PD-L1 immunotherapy, in second-line setting, the benefit has been shown to be greater than second-line chemotherapy, specifically Taxotere. And the magnitude of benefit, the hazard ratio of 0.6 to 0.7, is significantly bigger than the recently second-line drug, nintedanib, ramucirumab, or afatinib. Although the response rate is not very high, but for those who have responded, they have a very durable anti-tumor activity. The median duration of response is significantly more than 1 year, and they are very well tolerated with low immune-mediated side effects. And although the overall response rate in unselected population is 20%, at least in Pembro, we can increase the response rate by selecting patients with high PD-L1 expression. And a bit unusual is, number one, is PD-L treatment had a higher response in smokers, and the converse lower response rate for patients with sensitizing EGFR mutation. And the current, not only monotherapy trials, combination trials are in progress. And again, we have heard a lot of cost issue. The cost of this drug is tremendous. So we started off with targeted treatment is applicable for less than 1/3 of the patients, or less than 1/3 of all lung cancer patients. But you can see for immunotherapy, it has been shown to benefit in patients with adenocarcinomas, in patients with large cell, in patients with squamous cell, and also in patients with small cells, although the response rate is not high. So going forward, I think the main thing is finding the right predictive markers and maybe combination trials. This is my last slide. Thank you very much.
Thank you very much, Dr. Lim. Very nice presentation from your side. We have learned a lot about immunotherapy. Please have your seat. We'll have question answer session later on. Dear audience, learned audience, one announcement from my side. We have decided that we are going to provide you with some papers so that you can write your questions. Any question for any speaker, please write down your name and the speaker's name and the question. So at the end of the session, we'd like to have a discussion regarding these questions. Thank you. And our next speaker is Professor M.S. Salam. He's the pioneer uro-oncologist in our country. And Professor Salam is going to present his topic on current update of organ preservation in GU cancer management. Professor Salam, please.
Sir? It's okay.
Sir, your time is 20 minutes.
Mr. Chairman, thank you so much for the very nice introduction. This is the time for radical surgery. It's very difficult to summarize the current update which is happening in the organ preservation surgical techniques in the whole urinary tract in 15 minutes time. I hope I'll be skipping many of the slides to keep the time in proper. Please give me an indication 2 minutes earlier. Surgery, radiotherapy, chemotherapy, immunotherapy, all these things together or isolatedly are being used to treat the cancer or eradicate the cancer from the ancient time. And over the time we have learned how to compress our thoughts and ideas and implementation of this treatment from a maximally invasive technique to a minimally invasive technique. Maybe in course of time we'll achieve the standard that we'll come to a totally non-invasive techniques. There are examples. Say for example, the urinary tract is a very clear example. Radical surgery or removal of an organ in the urinary tract is intended to cure a cancer which is very much a standard care of art. However, with the advancement of the treatment trends are currently focusing to preserve the organ. This morning we are fighting to preserve the organ for the invasive bladder cancer. There are other organs in the urinary tract which can be preserved as well. We'll be trying to concentrate on few issues. One of the issues is kidney cancer. Say 10 years back, all kind of kidney cancer, those who are, the kidney cancer is very much famous for being radio-resistant, chemo-resistant, immunoresistant, etc., etc. But nowadays we understood that alternative options can be provided other than radical surgery. And we have tuned our surgical expertise to partial nephrectomy. Partial nephrectomy, by definition, is only to remove the cancer from the kidney with a negative surgical margin. And because of the advancement of the surgical technique, we have been able to do it for almost in every cases of T1 cancer, means tumor when it is located and the size is less than 7 centimeter, means T1 by definition, can be treated without any problem. But in practice, we have included the T2 even. We have removed in the last week 10 centimeter tumor which was in the upper pole, and the remaining portion of the kidney was perfectly preserved. And I hope he will survive with a good renal function in course of time, with the same efficacy of radical surgery. So if you summarize the indication, absolute indication is a solitary kidney. When there is a solitary kidney, you cannot remove the kidney. Otherwise, the patient is going to have a renal replacement therapy. So if you can preserve a part of the kidney, even that part of the kidney will be able to help the patient to survive with a reasonable renal function, if not to the normal. Relative indication could be the pre-existing renal disease, chronic renal obstruction, etc., where the situation is like this. When compromised renal function, then a part of the kidney is very important. So we try to preserve those things in our current practice. The incidence of the small renal tumors are increasing because of the advanced modalities of imaging like ultrasound is available in the doorstep of villagers. In all Upazila hospitals and in all Upazila private clinics, Upazila private clinic, not even the district, have got so many ultrasound installation. And the people behind the machine is quite capable of picking up the small tumors. So we are nowadays confronting with the small renal tumors which can be removed very easily without compromising the kidney function. Not only the surgery, renal cryotherapy, renal radio frequency ablation, high frequency ultrasound, microwave thermotherapy, intracavitary photon radiation, all these things can be used. But up-to-date knowledge is like this. Tumor of the kidney can be best treated by nephron-sparing surgery or the partial nephrectomy. There has been so many publications which will validate this proposition. So it is a standard care apart that partial nephrectomy is a very important surgical modalities. Relative contraindication could be renal vein thrombosis, multiple renal tumors, but all these relative contraindication is not absolute contraindication. I have done some cases with local invasive therapies, local invasive disease. I have done the partial nephrectomy, and then local invasive therapies are treated with immunotherapy like sorafenib and sunitinib. There is no such absolute contraindication, but there in malignant ascites, uncorrectable coagulopathy, and the these may be the relative contraindication, no absolute contraindication. These are the few slides which will explain how we do it. We try to put the clamp on the hilum, particularly the renal artery, and then the renal parenchyma become ischemic, then you can remove the tumor, and finally you end up with a situation like this, which require repair of the collecting system, control of all blood vessels, and finally sieving the kidney parenchyma to end up with a good result. So complications are also seen, but these list of the complication will decrease with the expertise. Oncological data, say about 2003, Desai and Gill, Professor Gill is a very important man in this field of the work. He was one of the pioneers. The long-term survival was significant in the partial nephrectomy group. This observation is very, very important, because if you can preserve the renal function instead of doing a radical nephrectomy, the patient will survive longer time because of the increased amount of renal mass, because we know with time, with age, the renal function drops down, and that is one of the issues that helps the longer survival. Oncological data are many. There are so many published series which all explain that you can have a much better result with the partial nephrectomy. Even further to that, in 2013, Krishover, who has published a nice data on off-clamping partial nephrectomy. This is more an advanced work. It carries a high amount of experience, and otherwise there could be bleeding and catastrophe. And emerging, it's a viable option that if you clamp the artery, it is potential threat to the live nephrons are minimized. As a result, off-clamp nephrectomy is preferred, but it is very, very difficult, and a lot of expertise is really needed. Cryotherapy was introduced, where this cryotherapy technique is very simple. Put the renal cryoprobe is placed under the laparoscopic guide or under the percutaneous image guide, and the temperature inside the tumor has brought down to -20 or -30, even to -51 degrees centigrade, and thereby it forms an ice ball, and the entire procedure can be controlled with hypothermia and the ultrasound, intraoperative ultrasound. And since this is not phase, but it requires long-term prospective trial. Having said that, I would like to draw your attention on upper tract urinary cancer involving the calyceal system, involving the ureter. These are nasty tumors. They are the killers. Within few months, the patient will be dead if detected, if not detected very early. But if it is detected early, then a very nice treatment conserving the kidney can be performed, because radical nephroureterectomy with the bladder cup excision, it means removal of the entire system of the either side, ipsilateral side, the kidney, the ureter, and a part of the bladder has to be removed when the cancer, transitional cell carcinoma or the urothelial cancer affects any of the system of the calyceal system or in the ureter. Standard care of treatment is nephroureterectomy with the cup of the bladder. But if we look into the advanced treatment, then partial nephrectomy could be done if it is located in a particular calyx. A segmental ureterectomy can also be done in selected cases. Endoscopic management with the laser technology with the flexible ureteroscope is a clear possibility in cases of low-grade tumor. The percutaneous nephroureterostomies have been performed in selected cases, and surgical ablation with the laser or with the diathermy can be performed. And finally, through this nephrostomy tube, one can put the topical chemotherapy like mitomycin or immunotherapy like BCG can also be performed. if we do a laser ablation through the ureteroscope, in those cases, a stent is placed and the intravesical mitomycin or BCG can be installed so that it can be well distributed in the ipsilateral side. But I tell you, these are very precisely defined area. If the case selection is not perfect, then good result cannot be achieved. If the patient has got a high grade and if the patient have got a urothelial cancer which has metastasis to the lymph nodes, this kind of treatment is contraindicated. Having said that, I come to the bladder, whether the bladder preservation is possible in invasive bladder cancer or not. This is a big question, big controversy and big fight between the radiation oncologist and medical oncologist and the urologist group. And today morning it happened. And we found that in Tata Memorial Center, from Tata Memorial Center, a very good presentation was made to preserve the bladder function in invasive bladder cancer in select patients. And we have understood that about 83% of the cases can have or enjoy the bladder sparing technology for invasive bladder cancer. So radical cystectomy and the pelvic lobe dissection is the most gold standard treatment for the invasive bladder cancer. In those circumstances, if you would like to preserve the bladder, then trimodal treatment may be a good option. And trimodal treatment is something like transurethral resection of the prostate to the maximum extent or a partial cystectomy, and this should be compounded with radiation therapy as well as systemic chemotherapy as a combined modalities. If it is done in selected patient or well-selected patient, then I believe that some of the patient will end up with almost cured. Long-term survival may be almost close to the radical cystectomy group of patients. But I would like to warn you that failure rate are there, and the failure rate can be controlled with the salvage cystectomy if it is needed. And when it is needed, it should be performed as early as possible in order to preserve the life of the patient. Partial cystectomy may be an option, but partial cystectomy should be augmented with radiation therapy as well as chemotherapy. So a good teamwork is very much needed in cases of preserving the bladder in cases of invasive bladder cancer. This is a big challenge and this is an area of controversy. So if somebody would like to do it in the protocol of study, then it would be very good. I think I can skip all these scientific discussion. Because of the short of time, I would like to go to the area of penile cancer. Penile cancer is also a devastating disease. Maybe penis is the most important organ for the human, for the male people. When they are confronted or when it is confronted with invasive cancer and it's an advanced cancer, then surgery become a very good aid. But radical penectomy and radiation therapy, chemotherapy, all these things make the life meaningless to the person. But if you would like to convert this situation into a meaningful life, then surgery can help in addition to radiation and chemotherapy, we can achieve a organ preservation. Say, for example, non-surgical treatment can be offered by topical ointment. Radiation therapy can be offered either by interstitial brachytherapy or the external beam radiotherapy. Cryosurgery has some places in addition to chemotherapy. In surgical technique, we have got something to do. Laser ablation can be performed either with carbon dioxide laser or ND-YAG laser. Sometimes circumcision might be helpful in non-circumscribed patients whose cancer is limited to prepuse. Then Mohs micrographic surgery has been introduced in order to preserve the maximum length of the penis. and partial glanectomy with the primary closure with some form of skin grafting, maybe from buccal mucosa or from inner aspect of the thigh or post-auricular skin can be used. Total glanectomy can also be performed, and distal corporotomy and reconstruction can also be achieved. About even a partial length of the penis become useful. Understanding this, if we can preserve a part of the penis, that would be very good for the particular patient if the oncological safety is established. Having said that, I would like to conclude my talk by finishing the last issue is the testis sparing surgery. Conventionally, the testicular tumor is removed through the inguinal route, and further it is compounded with chemotherapy, radiation therapy, or surveillance. But if we look into the early cases, then we will find there is a small testicular tumor. When there is a small testicular tumor, detected or picked up by ultrasound can be studied very carefully with CT and MRI about the lymph node status and the metastatic workup. If it is suggests that it is still localized, then it can be explored. And following the exploration, you can see this kind of picture. The tumor is quite localized inside the testicular tissue, and you can remove the entire tumor without any problem. We have done in several situations. One of our colleague, son, he is about 16 or something like that. He developed a tumor in the testis it has been detected as a lump. Then it was brought to me, and we studied him very carefully, and we found that the tumor can be removed. My colleague is a uro-oncologist. So he was very much confused that whether this treatment will be effective or not. So I assured him that I have some experiences to deal with such kind of problem. Then we explored him under anesthesia, and under operating microscope, we have removed the entire tumor in toto. We expected some kind of malignancy inside it, but fortunately, it was a benign tumor. But the issue is, have I got time? Go ahead, sir. Issue is, he was mentally prepared, my colleague was mentally prepared to do a radical orchidectomy. And finally, he was smiling that, well, sir, it was a great challenge and you have won over the situation by doing a testis sparing surgery. So the issue is a great issue. In a newly married couple who has got only one testis, then it becomes a very important issue. If he doesn't have any child, then preserving the testis is really very important. Having said that, I would like to tell you the indications. The indications are benign testicular tumor, malignant testicular tumor if it is detected early. Non-palpable testicular tumor can be washed, and testicular tumor in the pediatric age group should also be tried with this technique. And having said that, this kind of operations are going to close. Say, for example, in breast surgery, in our childhood time in the medical college, we have seen our professors are fighting with the patient. They have removed the entire chest wall for the sake of the breast cancer. Nowadays, most of the ladies who are suffering from breast cancer, they can save their breast. So the same principle applied in urological surgery. Conserve the organ as much as possible if you cannot conserve the total organ. So we would like to say goodbye radical surgery, but I don't know when the days will come, but I'm sure that in 20 years' time, the radical surgery is going to be an end. Thank you very much.
Thank you, Professor Salam, for your nice presentation. Sir, would you like to have a seat? We'll have discussion later on. And our last speaker, Professor Afiqul Islam, is going to present his topic on pediatric oncology network database registry initiation in Bangladesh. So, Professor Afiqul Islam, please.
Respected chairpersons of this session, both of whom are very close to my heart. And at the outset of my presentation, I would like to thank the organizer for inviting me and giving me the opportunity to talk about pediatric challenges of pediatric cancer in Bangladesh. We know Bangladesh is one of the densely populated country in the planet, and 47% of this population is children. And in the health budget in 2007, the 7.4% was for health, and that has been reduced to 5% in the last budget. In spite of this low health expenditure, Bangladesh has achieved significant improvement in the health sector, especially in child health sector, which was published in the prestigious journal Lancet with the title of Good Health at Low Cost, 20 years on, Lesson for the Future Health System. And this article has shown that Bangladesh has the lowest infant mortality rate, the highest longevity, and the highest immunization coverage, better than India and Pakistan. And Bangladesh also achieved all the Millennium Development Goal in child health and also in maternal health. And in the Sustainable Development Goal for the last coming 15 years, one of the goals is to reduce the premature mortality from non-communicable disease to 1/3. And the call was to way forward childhood cancer by synergistic childhood cancer intervention with the child health strategies. WHO has also given importance to the generation of reliable data and maintenance of registry. In spite of those achievements, those commitment and the rewards, the pediatric childhood malignancy, the condition is still miserable. And that was discussed in a meeting which was chaired by late Professor Fazlul Karim. The journey of pediatric oncology started in 1945 in Bangladesh under the leadership of Professor Mannan. And that in 1991, the pediatric oncology got government recognition. In 1999, we started our post-graduation course in pediatrics. In 2006, the BSMMU has a department of pediatric oncology. In 2006, there was post-creation in 8 medical colleges in pediatrics. These were the faculties where Professor Mannan got his farewell. Now the department has more than 27 residents, and we are hoping that in coming next 5 years, the number of pediatric oncologists will be more than 50. This was the pediatric oncology service in 1980s, where pediatric oncology were given within the pediatric ward. And this is the pediatric oncology inpatient. We have 31 dedicated beds now. We have a busy outpatient department, a daycare chemotherapy system, and a separate procedure rooms. This was the laboratory in 1980s. Now, the laboratory has developed. We have facilities for flow cytometry. A new flow cytometry machine has been installed. We have facilities for cytospin. We have facilities for automated blood counter and also access to essential biochemistries. This was the record system of our hospital. This is also the record system of most of the hospital in Bangladesh. Then we think an attempt was made to convert to electronic record system. But because of number of troubleshooting, we have to give up these things. This is the first study by our postgraduate student regarding the childhood cancer registry. She found that 71% of patients continued treatment after 3 months, and there was a 16% refusal from the outpatient department. Then the opportunity came. We had a visit by WCC team headed by Professor Tim Eden and Shara Stoneham from University College Hospital and Xuan Luins from Royal Marsden. And in 2012, the department was linked with 2 prestigious institutes, University Hospital London and British Columbia Children's Hospital, Vancouver. And they give us the opportunity to develop a pediatric oncology network database. This is called POND. This software is given us through St. Jude. 70 centers in the world use this database. The aim is to register all new cases, to monitor disease pattern, to see the treatment refusal and outcome of all patients. Till last week, in our database, 1,833 patients has been registered. And this has started from January 2012 to November 2015, and all children below 16 years are enrolled, and it is a prospective study. And this data is registered by a whole-time data manager, and the variable captured are patient demographic, the tumor type and site, the clinical status, investigation profile, disease status, and treatment refusal and abandonment. Every patients are reviewed at 6 months at the clinic or by telephone. The results shows the most common of the 19 different types of malignancies, the most common malignancy was acute lymphoblastic leukemia, followed by non-Hodgkin's lymphoma, then AML and neuroblastoma. And we have seen that in the last 4 years, the number of new patients has varied from 462 plus 500. And there is a significant number of refusal. And we can see that 20% patient refused from the outpatient department. 15% patient abandoned. Abandoned, we have defined a patient who failed to complete the curative treatment. The 13% patient has TRM, treatment-related mortality, and 7% patient was lost in the follow-up. This network has been extended to other 4 centers. One of the centers is Dhaka Medical College. They have registered 471 patients till last week, and their most common malignancy is also leukemia. The second center enrolled they have enrolled 1,084 patients, and of them, their disease profile is different. The bone tumor constitute 26%, retinoblastoma 23%, and CNS tumor 14 tumors, and germ cell 6%, soft tissue sarcoma are 8%. They have, most of them are solid tumor. So in this registry, we have found that ALL is the most common malignancy in children, and another finding is that we have a very high refusal, abandonment, and toxic death. And this registry is not only enabling us to see the outcome of each patient, but we can reliably define our workload. We can define whether our attempts to overcome this obstacle is working or not. This is helping this network system. Let's see what is the outcome of leukemia, the most common malignancy in children. We know the diagnosis of leukemia was a heartbreaking news to the patient, a life sentence to the patient, and the journey of cure of leukemia started from St. Jude. The first 4 studies, out of 59 patients, 57 died, and that was the initial result. After these first 4 studies, the same hospital has reported in their last 14 studies that leukemia is curable approximately in 93% of cases. The similar result has also been reported from Children Cancer Study Group. They have shown in their 8 consecutive studies that a disease which was curable in 15% cases, now it is curable in 80% of cases. And a recent report by Stephen Hunger they have shown that the disease-free survival in the 2006-2009 series in 6,000 patients is 92%. The treatment of acute lymphoblastic leukemia in Bangladesh, we started under the leadership of Professor Mannan. The protocol was called UCAL 8. And these are the 2, there are so many survivors. These are the 2 survivors of this protocol. One of them is a medical graduate, another one a master's from Dhaka University working as an executive. After this protocol, we have tried with a number of protocols, UCAL 9, UCAL 10, UCAL 11. But in the late 2000, it has been found that treatment of leukemia should be risk-directed. And risk stratification is done simply on 3 things: age of the patient, initial WBC count, and response to therapy. And from these, we have decided that we should also take the same idea. The ingredient of the protocol was same, just we changed some of the drugs depending on the available resources and local need. Now we are using the modified UCAL 2003 protocol. This protocol have 3 arms. We are using 2 arms. And the drug that has been changed is pegylated L-aspergillus, which is not available, that has been replaced by traditional L-aspergillus. And in spite of using 3 arms, we are using 2 arms. And that was the report outcome of UCAL 2003. The survival was 87%. And we have started enrolling patients in the pond since 2012. And BSMMU, Dhaka Medical College, and Chittagong Medical College are using the same protocol. And we are using 2 regimens, regimen A and regimen B. And actually, in our department, we are using 3 protocols. This protocol along with the protocol for infantile leukemia. And we give all patients a treatment roadmap with a printed from the day 1 to end of the therapy of 1,011 days. And this protocol have the 4 intensive early phases: the induction, then CNS-directed therapy, then followed by interim maintenance, and early and late intensification, and then the maintenance therapy. And from 2012 to 2015, we have registered 872 patients in the PONT registry. And of them, 746 started therapy, and 848 are continuing therapy. If we look at the year-on-year data, we'll see that in 2012, the total patients are 1,007. Of them, 81 started and 45 continuing therapy. In 2013, it was 245, and now 71 is continuing therapy. And 2014, the total number was 3,005, and 62 are continuing therapy. And in 2015, we have 215 patients, 192 are continuing therapy, and 80 are continuing therapy. And I want to confess one thing, that in the 2013 and 2014 data were updated on March. It is not November updated. The 2050 data is updated on March. These are our findings in our institute, and thank you very much for giving the opportunity to have this presentation in front of you.
Thank you, Professor Afiq sir. Would you please have your seat? Now I'd like to invite Professor Pierre Chow to the dais. Please, Professor Pierre Chow, you have some question for you. The first question is by an oncologist, Dr. Mustafa Aziz Sumon. His question is, what is the role of SBRT in HCC, hepatocellular cancer management?
There are currently 4 roles for SIRT in cancer management, and in fact, the publication will come out very soon. This was discussed by an expert panel recently. The first role is really in patients with portal vein thrombosis, because in portal vein thrombosis, all the other treatment modalities actually do very poorly. So that's the first role. The second role will be for patients with high volume locally advanced HCC, which would be impervious to treatment using TACE because the volume is too high. The third group will be for patients that has failed TACE, and this is a very big group of patients because patients originally may do well with TACE, and with a while, after some time, the disease progresses. So this will be the failed local regional therapies. And the fourth group will actually be patients who are actually selected to be on the waiting list for transplantation as a bridging therapy for transplantation. So these are the 4 established indications. And there's a 5th indication which is less established, which is to downstage patients who are marginally above resection or transplantation criteria so that they can be candidates. The 5th one has less data to support, so that's a relative indication. So these are the indications for surgery.
Okay, thank you, sir. And the next question, it is from Dr. Khosru. I don't know his designation anyway. His question is that, is it possible to do liver transplantation in a patient of hepatocellular carcinoma having hepatitis B? If yes, is it available in your center?
Yes, hepatitis B is now not a contraindication to transplant. In other words, patients with hepatitis B can be transplanted. So these patients are transplanted for 2 reasons. They can be transplanted because they have end-stage liver failure. So it's a failing liver and they should be transplanted, after which it is necessary for them to be maintained on lifelong immunoglobulin. The second group of patients with HCC transplanted are those with liver cancer. And again, if they're not operable, there are also indications for transplantation. And yes, such patients can be transplanted at our center in Singapore, and in fact in many places, yeah.
Thank you, Professor Chow. Now I'd like to invite you to have a seat here with us in the dais. Please. Now I'd like to invite Dr. Lim for answering a question for him. Dr. Lim, the question the questionnaire is Dr. Yaqub Ali. He is an associate professor of medical oncology in National Cancer Center. His question is, what is the dose and duration of treatment of non-small cell lung cancer by nivolumab?
Okay, for nivolumab, there only one recommended dose. That is 3 milligram per kilogram body weight every 2 weeks. In the trials, they are given until they are given continuously until the patient progress or unacceptable toxicity. If you look at all the immunotherapies, the initial trials, the usual planned period is 2 years. But if you look at the newer immunotherapy trials, some of the trials, the schedule is they will stop after 1 year, even if they are responding. If you look at them, if they are responding, if they stop after 1 year, you can see that a lot of them, they still remain progression-free after many months.
Okay, I would like to invite you to have a seat with us. Next, I'd like to invite Professor Salam sir to the dais. You have several questions from the audience.
So many questions. So many questions. Let me start, if I can do it. 5 years old boy, right-sided nephroblastoma, 6 into 5 centimeter. Right-sided horseshoe kidney, approximately 4 into 6 centimeter. Serum creatinine, burn, electrolytes all are normal. CT with IV contrast, normal excretion. What will be the surgery? If we can, then nephron sparing surgery will be best for this boy. Needs any adjuvant chemotherapy? No. What about the surgery and radiotherapy? No. Clear margin, nephron sparing surgery or the partial nephrectomy is the best solution for this particular patient. If not, a radical nephrectomy may be a good point, but since it is a horseshoe kidney, we would have to take care of this isthmus and status of the lymph node as well. A sampling of the lymph node might be helpful, but lymphadenectomy in nephroblastoma is a question mark, but can be performed if there is palpable lymph nodes. Am I clear to you? Yes, please.
Thank you for the answer, but I had some controversy regarding this. If it is a horseshoe-shaped kidney and whether nephrectomy should be done or not, or partial nephron sparing.
I think nephron sparing would be the best
Nephron
option.
sparing surgery in case of Wilms tumor, according to the National Wilms Tumor Study Group and Society of International Pediatric Oncology, their advocate is that if the tumor is on the upper pole only, in that situation, the partial nephrectomy is the thing. In other sense, the nephrectomy is the treatment of choice, because from the 1964 to till date, they have seen that if nephron sparing surgery is done, then there is a chance of recurrence. And regarding chemotherapy, whether patient of stage 1 will need chemotherapy or not, that was a controversy thing previously. That has been solved by National Wilms Tumor Study 4. They have a group where no chemotherapy was given in stage 1. But after 2 years of therapy, they have to cease this protocol because they have found there is recurrence. This is why nowadays all Wilms tumor, starting from stage 1 to stage 4, will need chemotherapy.
Professor Afik, I understand your point. My statement was very much perfect for the RCC or the renal cell carcinoma.
Yes, for Wilms tumor.
But for
that is
Wilms
the
tumor,
recommendation.
what Professor S.F Haq is said is absolutely correct. I appreciate.
Thank you, sir.
Thank you. So next question, would you like to mention the bilateral Wilms tumors? So all the times, I'm not having much cases of Wilms tumor, I would have to agree, but because my other colleagues are treating these patients. But our knowledge in support of your opinion, I think it has been sorted out that Wilms tumor needs radiation therapy as well as chemotherapy in the postoperative period, even in the preoperative period as well.
Sir, question was that you did not mention the indication of nephron sparing surgery bilateral Wilms tumor, but our knowledge is that for bilateral Wilms tumor, nephron sparing surgery is needed. What is your comment?
I think yes.
Yes.
Yes, of course, yes.
Thank you, sir.
Okay, next question. Is FNSC is indicated in testicular cancer? I prefer no. If not, then how it can be diagnosed? In fact, the testis sparing surgery has been evolved because of this question. This is a live question, this is a viable question, this is in practice we are facing this problem. So when there is a testicular tumor, the patient would like to understand and confirm before surgical treatment is done that whether this is a cancer or not before the operation. And fine needle aspiration cytology or core biopsy or any kind of scrotal violation is contraindicated. In these circumstances, a Shibashu maneuver has been introduced, and Shibashu maneuver describes that the testis should be explored through the inguinal route, and a vascular clamp has to be applied on the spermatic cord, and then the testis should be opened up. And as you opened up, you can take the sample and send it for the frozen section biopsy. Having understood this principle, the NSS developed because if you can remove the entire tumor, keeping the rest of the testis intact, then it became a testicular sparing surgery. So this is how it developed. So FNSC is contraindicated, rather you should explore the testis if necessary, if you compound it with frozen section biopsy. So next question is the patient with muscle invasive bladder cancer with gross hydroureter with some malignant deposits over the renal pelvic calyceal system with history of absent kidney. It means a solitary kidney, but somebody has got a invasive bladder cancer with gross hydronephrosis. In this setting, since he is a single kidney and muscle invasive bladder cancer, the best treatment could be the radical cystectomy with a form of diversion. If the bladder cancer has not been extended up to the prostate or in the bladder neck, then a orthotopic bladder can be constructed to help the patient. But if it is not ureteric origin, then it's perfectly well. I hope if the question, I don't know who has got the question, who has framed the question, if he can stand up and clear his situation.
Sir, I have done the question, sir.
You have got a question?
Sir, here. Yes. Sir, patient with muscle invasive bladder cancer with history of absent right kidney. So he has also developed left-sided gross hydroureter with some deposits over the pelvic calyceal system of that kidney, sir.
With some?
Sir?
With some?
With some metastatic deposits. With some metastatic deposits over the pelvic calyceal system, which is, what can I say, the CT scan findings or MRI abdomen findings of left kidney, sir.
I am wondering, normally the bladder cancer can give rise to invasion of the uretary orifices, giving rise to gross hydroureteronephrosis, as you are saying.
Yes, sir.
But the secondary deposit usually happens in the lymph node, but not in the calyceal system. If it goes to the calyceal system, then the situation could be this is a separate lesion or a lesion of upper tract TCC. If it is upper tract TCC in the pelvic calyceal system, then it's difficult to manage. If you can do a conservative surgery like nephron sparing surgery, you can do it. But I'm thinking that complete radical surgery involving the nephroureterectomy and the radical cystectomy and put the patient on hemodialysis. If it is recurrence free for 2 years, then you can think for transplant. Renal transplant would be a good solution.
Very complicated one, sir.
Okay, most welcome.
Thank you, sir.
If anybody have got any question, we have answered almost all. Yes, sir.
I know, Dr. Salam, you are very good in your place. You hear me? Hello? You hear me? Okay.
Yes, we can hear you.
The comment is, that for the muscle invasive bladder tumor, that's the treatment is nowadays up to date. Is that your the
radical cystectomy?
Radical cystectomy
Yes.
plus orthotopic or neotropic bladder transplant.
Absolutely correct.
The question is that is there any plan or any future of a transplant of bladder, urinary bladder in the future? There is.
Thank you. I believe that this will be a reality in course of time. Bladder is a very important organ that cannot be destroyed like radical cystectomy. But we had to do it right now during the days. But in the upcoming days, when cadaver transplant will be in place, then I believe that transplantation of the bladder will be a feasible option because it's not very difficult. You remove the bladder, if it is matched perfectly, then you can anastomose the urethra with the bladder and ureter and also establish the vascular connection with internal iliac artery, ipsilateral side, one side. The work will be done. So transplantation of the bladder in case of after radical surgery may be a possible option, but nobody has tried in this field. Rather, orthotopic bladder reconstruction is a popular procedure. We have been done it for the last 15 years, and more than 1,000 cases has been performed in our series. And that also offers a very good functional outcome as well, not only the structural outcome. But having a bladder of original bladder will be a dream. I appreciate the question. Thank you so much.
So, sir, I'd like to invite you to please join us on the dais. And now I'd like to invite the last speaker, Professor Afiqul Islam, to the dais for answering some of his questions. So, since you have many questions, I'm going to hand over the questions to you, sir.
So I have 4 questions. First question I entertained was from Shahinur Kabir. Do you have any program to develop after chemotherapy clinic for long-term follow-up at VSMU? Sure. Without SCT, we cannot have the long-term toxicity of any chemotherapy. And every center where there is treatment facilities for malignancy, there should be a SCT clinic, because the cure should be always associated with quality of life. To ensure quality of life, we cannot improve the quality without knowing the after chemotherapy effect. And after we will learn from the after chemotherapy effect, and subsequent therapy will be modified. The second question is from Lieutenant Colonel Yusuf Ali. I think that is the most important question he has asked. How to measure, prevent toxic death? That is the most important question, and that is the most important obstacle to cure. And if we have learned from the other experience, toxic death was 40% in case of acute myeloid leukemia when they started the therapy. Now it has come down to 4%. Toxic death was also the problem when they started the therapy in St. Jude. For toxic death, what things in our settings, the most important thing will be prevention of infection by improving the situation, by proper hand washing, have a team for infection control, and to improve the nutritional status of the patient. These are the 4 or 5 measures. And another important measure to reduce toxic death is to give treatment risk directed. If a patient of low risk, if you give intensive therapy, there will be toxic death. Then the next question is, what is the funding source for pond? Yes, for maintenance of the pond, we have, in every center, we have data manager. And I will be glad to know that this funding initially that was coming from World Child Cancer. And recently, knowing the importance of this program, the UK aid, DFID, the UK government is funding for these things. What is your comment? Work up for the sustainability of the pond. If you want to sustain treatment of cancer throughout the Bangladesh, you have to sustain pond. Without registration, if you treat, everything will be lost. And have you any data about the cumulative source of ALL treatment in other centers of Bangladesh? Yes, sure. Because in our center, the data is excellent, I have shown. I have received the data from Dhaka Medical College. Out of 471 patients, 58 are continuing treatment. I have received data from Sylhet Medical College last week. Out of 49 patients, 2 patients are only continuing treatment. And the same is from Chittagong. I think I finished the answering all of the questions.
Thank you, Professor Rasi. Officer, please have a seat here with us. Now I'd like to give the mic to the chairperson of the session, Professor Hafizur Rahman Ansari sir. So, sir, please.
At last we have come in conclusion of S.F Haq Memorial Symposium. The 4 topics has been presented to you. Professor Pierce Chow, he presented an evidence-based approach to management of hepatocellular carcinoma. Dr. Lim Hong Leong, he presented immunotherapy in advanced lung cancer. Professor M.S. Salam, current update of organ preservation in GU cancer management. And Professor Afiqul Islam, pediatric oncology networked database registry initiated in Bangladesh. I think all these 4 topics give us immense information about the present development of respective subject. And I think audience, those who have with keen interest, has given their patience hearing, they will be benefited. And from my side, I give many thanks to these 4 presenters for their nice lectures, and think in near future, in next annual session of Bangladesh Cancer Oncology Center, then they will come and deliberate their in a different topics to our audience or to our members. Thank you.
Thank you, sir. Now I'd like to give the mic to Professor Shariful sir for his comments and concluding remarks.
Thank you, Dr. Shahriar. I have nothing to contribute, but before offering my thanks to all these speakers, I like to give emphasis on the symposium after the name of Professor S.F Haq. He is my teacher, and today I am remembering his name as because the name of the symposium has been given after the name of Professor S.F Haq, who did a lot for the cancer prevention and treatment and establishing the Bangladesh Cancer Society and Bangladesh Cancer Society Hospital. So I am concluding this session and giving thanks to all the speakers and the audience.
Thank you, sir. Now I'd like to draw the attention of the organizers so that that mementos can be given to the participants from our respected teachers. Right. Okay, I'd like to invite Professor Pierce Chow to receive his memento from Professor Hafizur Rahman Ansari, sir. Okay, I'd like to invite the next speaker, Dr. Lim Hong Liang, to receive his memento from Professor Shariful, sir. It cannot hang, I think. It's a wooden thing. It's nice. Thank you, sir. Next, again, I would like to invite Professor M.S. Salam, sir, to receive his memento from Professor Ansari, sir. You deserve more. All of you deserve more. Okay. And now, I would like to invite Professor Afiqul Islam to receive his memento from Professor Shariful Alam, sir.
We have a very close community.
Okay. Now I would like to invite Professor M.A. Haq sir to come to the dais to deliver mementos to Professor Ansari sir and Professor Shariful Alam sir. Yes, sir.
Now, credit will be given to our rapporteur of this session, Dr. Shahryar, and it will be presented by our chairman and the president of Oncology Club, Professor M.A. Haq.
Yeah. After class.
Thank you again to all the speakers and the audience. Now I am concluding this session. All are requested to go for lunch. Thank you all.
Thank you, Honorable Chair and moderator of this session. Now we have come to a conclusion of the S.F Haq Memorial Symposium. Now there will be a lunch and prayer break, and after that, we will come to the session again. And if anyone is interested in a paper viewing session, you can have them on the ground floor, on the left side of this auditorium. And now, after prayer and lunch break, you are requested to come again to these dais to have the next session. held in Hall 3. For your information, pediatric oncology will be held in Hall 1. Advances in hematological malignancies will be held in Hall 2, and free paper session will be held in Hall 3. Attention everyone, for your information, pediatric oncology will be held in Hall 1, advances in hematological malignancies will be held in Hall 2, and free paper session will be held in Hall 3. Attention everyone, for your information, within a very few minutes we will start our session. Honorable guests and participants who are roaming in the stall hall are requested to have a seat in the respective hall. For your information, pediatric oncology will be held in Hall 1, advances in hematological malignancies will be held in Hall 2, and pre-paper session will be held in Hall 3 within a very few minutes. So all of the guests are requested to have their seats in their respective hall. Tawfiq as a moderator and Professor Chaudhuri Yaqub Jamal and Professor Mahbubur Rahman to have a seat on the dais. I will request Dr. Muhammad Tawfiq to conduct the session as a moderator.
Thank you. So we are now going to start our session. What we are waiting for. So I think everyone is fresh after lunch. And now may I request our chairperson, with the permission of the chairperson. So with the permission from the chairpersons, to the left, Professor Yaqub Jamal Baki and Professor Mahbubur Rahman. So may I request the speakers. The first speaker would be AKMA Murshid. So he will be speaking on serum lead level in children with acute lymphoblastic leukemia. So may I request Professor Amirul Murshid Khosru to kindly come to the dais and to speak on this speech. Honorable audience, would you please pay your attention to the dais and to the speakers. We are going to start our session. Thank you.
Honorable chairpersons and learned audience, Assalamu alaikum. Good afternoon. Pediatric oncology is a new subject in Bangladesh, though it was established in 1985, but we reached a little to achieve. I am Dr. Amirul Murshid Khosru from Dhaka Medical College. My topics is serum lead level in children with acute lymphoblastic leukemia. It is Bangabandhu Sheikh Mujib Medical University where pediatric oncology have been started. It is Dhaka Medical College. It is the first pediatric hematology oncology unit in government sector. NIC RH Mahakali. It deals with pediatric oncology. And it is pediatric hematology and oncology ward of Dhaka Medical College. So, acute lymphoblastic leukemia is the most common malignancy in childhood, accounts 25 to 30% of all childhood cancer. The peak incidence is 2 to 5 years of age, and the mostly etiology is unknown, and present with triad, fever, bleeding, and anemia. Overall cure rates of pediatric ALL have improved from virtually zero in 1950s to the current event-free survival rates is more than 90%. Due to development of active chemotherapeutic agents, improvement in our understanding of proper dosing, schedules, and combination of drugs, and significant improvements in supportive agents. In ALL, we know, on another side, we know lead is a common heavy metal which is causing heavy metal toxicity. Lead can effectively inhibit cellular glutathione peroxidase, reducing the effectiveness of this antioxidant defense system. It is chemically similar to calcium, and it can act as weak mutagens, can disrupt gene expression, and regulate cell growth and development. It is a atomic molecular scenario of lead. Lead toxicity is one of the most frequently reported unintentional toxic heavy metal. Exposure and the leading cause of single metal toxicity in children. Children absorb lead up to 8 times more efficiently than adults. So the toxicity occur more in children. Conditions that cause release of calcium from the bones will also release stored lead from bones, thus allowing it to enter into the blood and the other organs. In children, low level, less than 10 microgram per dl lead exposure can result in several developmental disorders like accelerated skeletal growth, cognitive deficiency, distractibility, attention deficit, IQ decline, and slowed growth and delayed sexual maturation. Due to antioxidant effect, it may slow the cure of leukemia. Due to adverse antioxidant effect, it may slow the cure of leukemia. Like high calcium in ALL, it assumed to be raised in this disease. Few study has done to see lead level along with other heavy metals. One study showed lead level, but high lead level, but in Turkish study it was low. The objective of our study was to investigate and compare the serum lead level in acute lymphoblastic leukemia patients and normal individuals, and measures taken if any change observed. It was a cross-sectional study, and it was done in pediatric hematology oncology department of Dhaka Medical College within January 2013 to December 2013. The newly diagnosed patient, both male and female, child from 2 to 12 years age was included, and previously treated children and severely ill children was excluded from the study. There was 30 newly diagnosed ALL patients, and age and sex match 33 control are enrolled. After taking history and physical examination, data collected in a pre-tested questionnaire by doctors assigned, blood samples are drawn from patients and controlled by aseptic way. The drawn blood was scanned for 50 to 30 minutes for formation of clot. Clotting was separated by ringing and reaming. The remaining fluid, that means serum, was centrifuged and supernatant fluid was used for serum lead determination. For long-time storage, specimens were kept below 20 degrees centigrade. Serum lead status was measured using flame atomic absorption spectrometry method, which was done in Chemistry Laboratory, Chemistry Division of Atomic Energy Center, Ramna, Dhaka. Serum lead level less than 100 microgram per liter was regarded as normal. Taking blood and the sampling. It is the Nuclear Medicine Center of Ramna, where the investigation was done. After collection, all data were checked and edited. Data were entered into SPSS version 16. Results are presented on mean, standard deviation, and the student test, chi-square test, and ANOVA test used for significant tests. The aims and objectives of the study, along with its procedure, was explained to the patient's parents, detailed, and written consent was taken. Ethical body of Dhaka Medical College was approved. No significant difference between the control and case in S group. The ALL patient presented with fever, generalized weakness, pallor, bleeding manifestation, and no patient was family history of ALL. On physical examination, we have get anemia in 50% patient, palpable lymph nodes 26.7%, purpuric rash, palpable liver, and palpable spleen. And serum level less than 100 was in 5 patients of ALL, and all the patients of control was less than 100. And more than 100, it was 25 patients, and 100 to 200 was 43%, and more than 200 was 40%. And the difference was statistically significant. Some study by Demir in Turkey showed that serum lead was significantly elevated in ALL patients, and M.K. Schwartz revealed serum lead concentration was high in serum of acute leukemia compared to the control group. In present study, significant difference of serum lead concentration in ALL patients with those of the control, and p-value was highly significant. So, in conclusion, the study revealed that there is significant difference between acute lymphoblastic leukemia patients and normal control in terms of serum lead level. It is significantly elevated in acute lymphoblastic leukemia. This study was done in a small sample and within a short period of time. So our recommendation is a further broad-based multi-center study to validate this observation. Thank you. Thank you for fair.
Thanks to Dr. Amirul Murshid Khosru for your nice speech. So we'll have the questions after the session. So now may I request Dr. Zohra Jamila. Our second speaker is Dr. Momtaj Begum. She will be speaking on evaluation of delays in diagnosis and treatment of childhood malignancies in Bangladesh. So may I request Dr. Momtaj Begum to start her speech on the issue.
জাস্ট স্পেস দিলেই হয়ে যাবে, এটা চাপ দিলেই চেঞ্জ হবে।
এটা না?
হ্যাঁ, এটা ইউজ করতে হবে না।
আচ্ছা, এটাই তো। Honorable Chairperson of this session and learned participant, Assalamu alaikum. My study is evaluation of delays in diagnosis and treatment of childhood malignancy in Bangladesh. This beautiful baby is trying to overcome a obstacle in front, and in this study we are trying to explore the causes which make obstacle in our children in case of malignancy diagnosis and treatment. So my aims is to find out the probable component for the delays in diagnosis and treatment of childhood malignancies in Bangladesh, like this wise person. At present, many childhood malignancies are curable when diagnosed early and managed properly with protocol-based therapy and supportive care. But early diagnosis of childhood malignancy is often difficult because the symptoms are non-specific and similarity of symptoms with other common diseases of childhood. So we can see in case of abdominal pain, there are patients at first treated as a case of ACR or school phobia. Sometimes parents think that the child complains this to avoid school, and even some physicians treated this type of symptom as a school phobia or ACR, and also in some cases of headache like this. And other things, lack of awareness about childhood cancer among parents and general practitioners as well. Again, another, when malignancy is diagnosed in children, it is unexpected and difficult to accept by the parents. Many of them think that it is not curable and better to go home rather than wasting time and money. And like other developing countries, in Bangladesh, there are also inadequate facilities for accurate diagnosis of childhood cancer, and still there is inadequate number of pediatric oncologists for the management of children with cancer. For this reason, there are long delay in diagnosis, and this long delay in diagnosis adversely affect prognosis. In this study, we categorize the delay 3 types: patient or parents delay, second diagnosis and or doctor's delay, and third treatment delay. It is a cross-sectional study. Population was diagnosed malignancy cases in pediatric age group of both gender, and the duration was January 2014 to June 2014. And National Institute of Cancer Research and Hospital is the study place. Total 171 patients were enrolled in the study, and protocol was approved by the ethics committee. Informed consent taken from the patient or guardian. Suspected or confirmed diagnosed cases are referred to NICRH, and when any child attend outpatient department, at first we took a detailed history of the patient, and then a thorough examination was carried out. Particulars of every child were recorded, and thereafter we reviewed all investigations which were already done. Further investigation, if the diagnosis was not confirmed, and after confirmation of the diagnosis, we collected data in the pre-tested questionnaire. We designed standardized questionnaire to collect data from guardian through face-to-face interview during child's first or second treatment course or follow-up. The operational definition of patient delay, interval between appearance of the first symptom and seeking first medical advice from a registered graduate medical practitioner. Consultation with alternative medicine like homeopath, herbs, traditional healer were not considered as first medical contact. Doctor's delay are defined as gap between first contact with the medical graduate and confirmed diagnosis of malignancy. If patient visits several doctors before confirmation, all visits are not considered here except first visit for calculation. And treatment delay are defined as time lapsed between confirmed diagnosis of the malignancy to starting of anti-cancer treatment. And total delay, the time interval from the onset of disease-related symptoms to starting anti-cancer treatment. We divide the time as less than 30 days, 31 to 60 days, 61 to 90 days, and more than 90 days. We collected first prescription as evidence of first contact with a physician to calculate the patient delay. Collected data were tagged, then data are cleaned, and SPS 17 version was used for calculation. Qualitative data are analyzed by chi-square and continuous by t-test. P-value less than 5 was considered as significant. Result. This is the malignancy which we are treated. There are so many cases. I am not going in details. In case of patient delay, less than 30 days, there is 92 patients, that is about half patient has less than 30 days delay, and 11% 31 to 60, 16, 61 to 90, and more than 90, 18. And doctor's delay, also about 50% patient has less than 30, and 31 to 60, 32, and 61 to 90, 82. Treatment delay was, this is a major portion, patient has less than 70 days, and 31 to 60, 22 days. And total delay, less than 30 days patient, only 1.8% patient start treatment. We also try to explore the knowledge of the respondent about malignancy. In questionnaire, we want to that malignancy is which one is a serious disease, malignancy, tuberculosis, like this. Maximum patient give that malignancy is a serious disease. And we also want that what are the source of hearing about malignancy, radio, TV, like this. Maximum patients said they are known from the radio or TV. Another was causes of malignancy. Maximum answer, that is tobacco, jorda, or leaf, betel leaf is a source of malignancy. In one thing, that patient delay by gender, we see that in case of male patient, the delay is less, but in case of female, it is more. In case of male, it is 110, 106 days, and in case of female, it is 110. The time gap between first appearance of symptom and first contact with a medical professional, in case of children less than 2 years of age, it is 92 days, but in case of children above 2 years, it is 145 days, and it is statistically significant. We also try to know the educational level of the father and mother. In case of father educational level, the relation is significant. That is, more educated father has come a bit earlier, and it is statistically significant, but mother education has no role. And another important thing we've found during our study, that many of the parents don't heard about the childhood malignancy. And it is, those are making late. They said that we don't know about childhood malignancy after my child getting malignancy. We can hear this or after coming this. And this difference is also significant. And another thing is malignancy is curable. This is also, but it is not statistically significant, the difference. Association between family income and malignancy, it is also significant. It is probably quite natural. Those family have more income, they are come earlier. In Bangladesh, there is no population-based cancer registry, so it is not possible to say how much children are diagnosed with malignancy in our country each year. According to our registry in the Department of NICRH, 2,166 new patients were diagnosed from the 2008 to 2015 October. Early diagnosis of malignancy is a primary goal in oncology department because it permits earlier treatment and with improved prognosis and cure can be achieved with a minimal adverse effect. This delay is occurred due to misinterpretation of the early symptoms, poor access to health care facilities, and sometimes completing household work that sometimes patients think that I do these things and bring this child afterwards. Here with delay is usually a relative term. Considering our present socio-economic situation, we consider 1 month as a cut-off point as delays in different stages. In our study, it was found that children less than 2 years of age had to wait less than older children, which is statistically significant. And probably this is due to younger child are more close to the parents, so any symptoms are noticed earlier. And older children may be more self-dependent regarding their health than younger one. On average, the female child had to wait more days to see a doctor for her ailment than the boys. Statistically significant difference was noted between the families regarding monthly income. And those parents who heard about the childhood malignancy beforehand were more prompt to seek treatment for their child. The influence of increased parents' knowledge and awareness of the child's disease on timely diagnosis is also supported by the finding of the negative association between the father's education and diagnosis delay. In more than half of the cases, doctor's delay was less than 30 days. In about 32 cases, this delay was 31 to 60 days. In aggregated, the 70% of the cases had to wait more than 3 months for the treatment to start. That is, yet our treatment facilities is not up to the mark. That is not sufficient. About 15% had to wait for 31 to 60 days. And very negligible percentage of patients got treatment before 30 days. Limitation of the study, the sample size was not so large, single center, and another limitation was accuracy of the information, initial onset of symptoms due to the recall bias. Raising awareness about the earlier symptoms of childhood malignancy in the society and among the physicians can solve this problem. I think that one day we can also overcome this problem and our child will be cured. Thank you.
Thanks to Dr. Mumtaz Begum. So now we are inviting the third speaker, Dr. Zohra Jamila Khan, who is working as Assistant Professor in Department of Pediatric Hematology and Oncology in Dhaka Medical College. She will be speaking on pain management in children with cancer, an observation in a pediatric palliative care unit in Dhaka. Dr. Zohra Jamila Khan, please.
Now the next.
Honorable Chairperson, reporters and learned audience, Assalamu alaikum, good afternoon. I am Dr. Zohra Jamila Khan, here to present a topic on pain management in children with cancer. Pain is one of the most distressing prevalent symptoms in children, requiring palliative care support. It is also one of the most feared cause for parents. A child's pain can be very distressing for patient, families, and health professionals as well. But fortunately, management of pain is very much straightforward and easy to manage by multidisciplinary approach and proper assessment of the pain and effective correct administration of the pain medicine and proper titration and withdrawal orderly. Me and Dr. Shahinur did the work background. Cancer pain in children is deeply distressing for the family and child. In our country, childhood cancer is diagnosed too late. Even though it diagnosed early, many of the patients' parents cannot afford treatment, and often there is treatment failure. Most of the patients' last days experience with severe pain and multiple symptoms. It was a retrospective observational study, and duration of the study was May 2006 to October 2014. Place of the study, it is a parents organization recognized internationally, Ashik Palliative Care Unit, Dhaka. Study population, cancer patient less than 18 years of both sexes attended palliative care unit. Sample size, total 624 patients were enrolled. Purposive sampling technique was adopted, and selection criteria was less than 18 years of both sexes, children with cancer of palliative stage. Data were collected from patients' register book and bedhead tickets by a checklist. Data were checked, cleaned, and edited properly before analysis. Analysis was done through Microsoft Excel and was evaluated by frequency, percentage, table, and figure. Ethical consideration. Written consent was taken from the concerned authority. Aim of our study to assess demographic profile of the patient who came in the palliative care for pain and other symptoms, to observe type of cancers and clinical profile, to observe treatment modalities needed for pain management in pediatric palliative patients, and to observe pattern of response to pain medicine. Majority of the patient resides outside Dhaka, and it accounts at 82%. These figures shows distribution of the patients by age group. Majority of the patients are below 5 years, that is 41.85%. And the cause is probably our patient in these setups are retinoblastoma, and it is the commonest age group for retinoblastoma patient. Males are preponderance, males preponderance are more, and it is accounted 65%. This is a trend of patients attending in palliative care unit from May 2006 to August 2013. Initially, first year, there was only 21 patients, and gradually referral system improved from the different hospital of the Dhaka, NICRH, BSMMU, Dhaka Medical College, and other private center, Islami Eye Hospital. Distribution of palliative care unit patients by type of malignancy. Commonest malignancy was observed solid tumors, and it was accounted 63%. This is the disease profile, most common patients. We have treated retinoblastoma, and majority of retinoblastoma are admitted with metastatic stage, recurrence, and second most common malignancy was observed acute lymphoblastic leukemia. Pain. Regarding pain in children cancer, there was a survey published in New England Journal of Medicine in 2000. 80% child had experienced pain with cancer, and 27% had relief from pain by effective pain medication. In Journal of Pain and Symptom Management in 2003, it was published that children who died of cancer experienced pain 53% in the last week of life and 31% on last day of life. These are the pain. Cause of pain is actually multifactorial, multidimensional. Physicians are often concerned about the biological cause of the pain, that is tissue damage, nerves, release of neurotransmitter, but there are so many other factors, psychological, environmental, and socio-cultural. If you don't address the other factors, we cannot properly manage pain, and we cannot introduce safe narcotics for pain management. For proper pain assessment, it is important to perform thorough assessment of a patient's pain, To safely and effectively treat their pain, a full assessment needs proper history, physical examination, investigations when appropriate, and use of standardized assessment tools. Children are the best authority to express their pain. Always we should be very careful about ignoring their complaints, as children rarely invent or exaggerate their pain. Healthcare providers should always look for an organic cause for a child's pain. We can memorize this mnemonic encompasses following features: character of the pain, C for character of pain, O for onset, location and radiation, D for duration, exacerbating factors, relieving factors. We can remember colder. Pain scale should be used to assess pain intensity in all children. Self-report is the gold standard for children aged 4 years and older. This is a FLAC scale, which there are 5 components: appearance of face, movements of legs and arms, cry, intensity of cry, and consolability. Those who are involving with management of pain in children can preserve this chart in their mobile or any site, and they can assess pain easily and score it. FLAC is relevant for 3 years and under children. This is a modified revised face pain scale. The phases show how much something can hurt. First phase shows no pain, and then gradually it's up, and there is severe pain, score 10. This is a numerical rating scale. It is applicable for children more than 8 years. What are the possible causes of pain? We have to find. There may be bone marrow infiltration and bone expansion, and there may be pressure effect by metastatic solid tumor, sepsis, localized infection, mucositis, pancreatitis. There may be fractures, pathological fractures, neuropathy, and raised ICP may be the underlying cause. There are many ways to relieve pain. One is basic, is non-pharmacological and pharmacological strategies. Regarding non-pharmacological strategies, we can use acupressure, relaxation, meditation, play therapy, music therapy. This is the new WHO guidelines, 2012. Previously it was 3-step ladder. Now it is 2-step ladder, very straightforward. For mild pain, only paracetamol and ibuprofen, and for moderate and severe pain, recommended opiates is recommended, and it is only morphine. In our study, 63% of patients shows pain scale score 4 to 7, and 37% severe pain 8 to 10. 8 to 10 score in 37%. In this center, they did not use the proper pain scale, or they did not follow WHO guideline 2012. That's why they used different types of medicine for pain control: paracetamol, ibuprofen, gabapentin, tramadol, ketorolac, and morphine. 37% patient needed morphine. All the patient who needs paracetamol initially, pain control was not effective, then gradually switch over to the other drugs, and finally pain control by morphine. Other modalities for pain management given for palliative chemotherapy, metronomic doses of chemotherapy, rhythmic, periodic, and it has no specific protocol. It can decide by physician according to the patient's condition and intensity of pain. Palliative radiotherapy given to 6.8%, steroid in 40%, and acupressure in 5%. Effects of morphine. With morphine, pain reduced after 24 hours in 63%. And the score became 1 to 3, and pain reduced score and reached score 4 to 7 in 17% and pain not reduced at all in 20% patient. Side effects of morphine was observed mainly constipation in 90% cases, nausea in 7%. Sorry, there is spelling mistakes. Nausea, I couldn't correct it, and there are others 3%. This picture shows actually what is quality of life. Pain, what a subject expresses herself or himself is the quality of life. This first picture is with severe pain when the score was 10, and the second picture after relieving pain, the baby looks very happy. To summarize, out of 624 patients, majority were less than 5 years. Male preponderance was observed. Majority of patients came from outside the Dhaka. Solid tumor is more common. Commonly observed pain score was 4 to 7. Recommendation: sensible and empiric approach is needed for pediatric pain management. Study on pain management needed multidisciplinary approach. Further clinical trials are needed to evaluate clinical efficacy and safety of opioid analgesics. Study to be done prospectively. Thank you everyone for your time and patience sharing.
Thanks to Dr. Zohra Jamila Khan. Now we are inviting the last speaker of the session, Dr. Shahanur Islam, the Associate Professor of Pediatric Surgery of Dhaka Medical College. Dr. Shahanur Islam, please. She will be speaking on mediastinal cystic teratoma with right-sided extrarenal Wilms tumor, a case report. And before starting her speech, may I draw the attention of Dr. Muhammad Shakilur Rahman and Dr. Muhammad Harunur Rashid, the speakers in the next session, to contact the volunteers to our left with their slides to be presented. Dr. Muhammad Shakilur Rahman and Dr. Muhammad Harunur Rashid to contact the volunteers. Thank you.
Good afternoon. Welcome to this session, Honorable Chairperson, learned audience from home and abroad. I am Dr. Shahanur Islam from Department of Pediatric Surgery, Dhaka Medical College. My topic is mediastinal benign cystic teratoma with right-sided extrarenal Wilms tumor, a rare case report. Abstract. Mediastinal teratomas with extrarenal Wilms tumor are rare tumors in childhood. We report a case of 26-month-old boy with a mediastinal benign cystic teratoma with extrarenal Wilms tumor. The child presented with severe respiratory distress, fever, and features of left-sided pleural effusion, abdominal pain, and distension. We discussed the diagnostic workup, radiologic and operative findings, treatment and review of the literature. Introduction. A teratoma is an encapsulated tumor with tissue or organ components resembling normal derivatives of more than one germ layer. The tissues of a teratoma, although normal in themselves, may be quite different from surrounding tissues and may be highly disparate. Teratomas have been reported to contain hair, bone, teeth, and very rarely more complex organs or processes such as eyes, torso, and hands, feet, or other limbs. Usually, a teratoma contains no organs, but rather one or more tissue normally found in organs such as the brain, thyroid, liver, and lung. There is also extrarenal tumor means, extrarenal Wilms tumor means excluding a primary tumor in the kidney. Now, this is a baby of 26-month-old boy presented with fever, chest pain, respiratory distress, abdominal distension, and pain for 8 months. Now, how we evaluate the patient? His fever was low-grade, intermittent, not associated with chills and rigor or night sweat. However, he had no history of hemoptysis and contact with tuberculous patient. He also suffered from respiratory distress, chest pain, as well as heaviness of left chest almost all the day and night. Respiratory distress was not relieved by any medication. Pain is so severe and he is used to scream. Abdominal pain was dull aching in nature, not associated with jaundice, vomiting, hematemesis, melena. He had anorexia and loss of weight, but no urinary and bowel complaints. During his illness, he got admitted 9 times in different hospitals, evaluated with chest X-ray 16 times, ultrasonography of abdomen 4 times, and CT scan of chest 2 times. Treated with many antibiotics, anti-asthmatics. Undergo minor chest surgery 5 times and a major surgery, mini thoracotomy and open drainage. On general examination, he was irritable, ill-looking, dyspneic, mildly anemic, and no lymphadenopathy was found. On respiratory system examination, revealed features suggestive of left-sided pleural effusion with multiple scar marks and a sinus tract with pulmonary discharge on anterolateral chest wall on left side. Now, para-abdominal examination revealed right kidney was palpable, palatable, and non-tender. Liver and spleen were not palpable. Other systemic examination revealed nothing significant. Now, laboratory stages. Complete blood count are normal. Liver function test and renal function test normal. Urinalysis normal. Coagulation profile, ECG and echocardiographic findings normal. Pleural fluid study shows nothing significant. Imaging studies. His chest X-ray suggested left-sided pleural effusion, hydropneumothorax with pleural thickening and collapse of the left lung. Another CT scan of chest assisted collection having high density content occupying left hemithorax with multifocal eccentric calcification with small air space, which suggests large left-sided empyema thoracis. Ultrasonography of the abdomen shows well-defined hypoechoic mass measuring about 3.9 into 2.7 centimeter and mid and lower zone of right kidney, mild ascites with left-sided pleural effusion. Impression was right-sided nephroblastoma with left-sided pleural effusion. IVU examination shows right-sided renal mass, but both kidneys excreting normally. Now, CT scan of chest and abdomen shows pneumothorax with pleural thickening and collapse of left lung and a right renal mass. CT-guided FNEC from renal mass shows not conclusive evidence, so review the report and shows blastomal cell of a nephroblastoma. Now, on the management part, Department of Pediatric Hematology Oncology started the preoperative chemotherapy and simultaneously referred to patient to thoracic surgery. Thoracotomy was planned and done. On exploration there was a huge mass occupying left hemithorax, making very difficult to insinuate the finger between ribs and mass. The pus evacuated through the previous sinus tract. At the end of sinus tract, we suddenly discovered some hairs within the mass which actually appear as light at the end of the tunnel. Histopathology was sent and shows multiloculated cystic mass measuring about 12 centimeter in maximum diameter, showing skin, bones, cartilage, and sebaceous material microscopically. Microscopically, it shows cysts are lined by stratified squamous epithelium with areas containing hair shaft, respiratory epithelium, and sebaceous material. No granuloma or malignancy seen, and diagnosed as benign cystic teratoma. This report was fine after the operation, but in operation the chest was opened deliberately, whole mass was removed, lung was expanded satisfactorily, no evidence of metastasis, postoperative period was uneventful. The child got relief from respiratory distress and made ready for accession of renal mass. Now the patient was referred to Department of Pediatric Surgery for accession of renal mass. Supraumbilical transverse, right-sided transverse incision was given, abdominal survey was done, other kidney, liver, peritoneum was normal, the mass on the lateral border of the right kidney. Frozen section report was positive for malignant cell, totally removed with capsule, postoperative period was uneventful. Histological findings suggest Wilms tumor. There are three components: blastomal elements, mesenchymal elements, and epithelial components. Now we again review the previous pathological report. All slides are reviewed. These reveals a Wilms tumor, no teratomas component is seen, diagnosis Wilms tumor. Immunohistochemistry is advised for confirmation and possibility of external Wilms tumor may be considered. Immunohistochemistry will suggest Wilms tumor. Now the patient again referred to Department of Pediatric Hematology Oncology for postoperative chemotherapy. After giving the chemotherapy schedule, now he is on regular follow-up for last 18 months. He is growing well in good health without any adverse event. Screening of other siblings, ultrasonography of whole abdomen 3 monthly up to 8 years, and ultrasonography reports of another sibling normal. Now discussion. Mediastinal teratomas are the most common extragonadal germ cell tumors. Approximately 25% of anterior mediastinal masses in children. Age of presentation is wide. Children, the majority of patients are asymptomatic with mediastinal mass discovered incidentally when the thorax is imaged for another region. Mass that become symptomatic can do so in a variety of ways: mass effect, respiratory distress, etc. Reports of mature teratoma simulating organized empyema in children have been reported by some. Teratomas get infected with contagious foci in lung parenchyma or via the blood stream in our case, as there was no obvious cause of fever, cough, breathlessness, chest pain, and contrast intensities can show areas of consolidation which prompt us to consider bacterial infection of large cystic teratoma. Appearances on chest radiography are usually indistinguishable from many of other causes of an anterior mediastinal mass. Calcification may be visible. CT is the mainstay of diagnosis. The appearance will depend on the type of teratoma and whether or not a cystic teratoma have ruptured. They are all, however, usually located in the anterior mediastinum. The findings of extrarenal Wilms tumor outside the course of germ cell migration, such as those arising in the inguinal area, would suggest that they may not necessarily be teratoid but may have originated from misplaced primitive nephrogenic blastema. The extrarenal location of teratoid Wilms tumor has led to be debate on whether the origin is embryonic or neoplastic. So, as per our search, association of benign cystic teratoma with extrarenal Wilms tumor has not yet been reported. So it may be the first case identified as a rare association of mediastinal benign cystic teratoma with extrarenal Wilms tumor. In conclusion, it may be stated that association of mediastinal benign cystic teratoma with extrarenal Wilms tumor is very much rare. Wilms tumor with respiratory distress may be anything other than metastasis. Apparently, looking pleural effusion is not always pleural effusion. Shows the clinician awareness of this rare association may prevent misdiagnosis and delay in appropriate treatment. Now, recommendation are a benign cystic teratomas may sometimes behave as empyema or pneumonia, or sometimes behave as its malignant counterpart. Our case highlights the need for careful evaluation of chest X-ray and CT scan of chest and abdomen by treating physicians, which may clinch a rare diagnosis of an uncommon disorder. Acknowledgement for Department of Pediatric Surgery, Dhaka Medical College, Dhaka, Department of Radiation Oncology, Dhaka Medical College, Dhaka, Department of Radiology and Imaging, Dhaka Medical College, Dhaka, Department of Thoracic Surgery, Dhaka Medical College, Dhaka, Department of Pathology, BSMMU, Dhaka. So, in case of childhood malignancies, we must approach through multidisciplinary approach by forming a tumor board in the early management part for the quality of life. Thank you for patient hearing. Thank you for giving the opportunity to give this presentation. Thank you all.
Thanks to Dr. Shahanur Islam. Now this is the question and answer session. So may I invite the first speaker to respond to the question. Dr. Professor A.K.M. Amirul Khosru. What are the measures to decrease the serum lead level in ALL patients?
Thank you. Serum lead level, if it is elevated more than 450 microgram per DL, per liter, then we should measure, take some measure like chelation therapy by dipenicillamine or succinar and other drugs is possible. For our patient, where there is lead level is around 200 microgram per liter, it should be avoid the more lead exposure, lead containing diet, and maintain a calcium level which hypocalcemia may cause lead, hypocalcemia may cause reabsorption of lead from bones. So maintain a proper calcium level, avoid tumor lysis syndrome, and proper management of the tumor lysis syndrome, and maintain the fluidity. All these measures will record the high lead level. Thank you.
Thank you, Dr. Amirul Masud Khosru. This is the question to our second speaker, Dr. Mamtaj Begum. How the patient delay and professional delay can be reduced?
Thank you for the question. First, the patient delay. It is the time that we must create awareness among the people about the childhood malignancy. We can ventilate the message that malignancy is not a disease of adult. Children can also suffer from malignancy, and we can create this through campaign, through TV or paper, and also by general meetings like this. And if the people can know that the childhood malignancy is curable and it must be addressed by a proper way, then we can reduce the delay. And second question, the physician delay, it is also, we can ventilate the message among all physicians, that is health professional, that childhood malignancy must be treated in a proper way. We always say that a child is not a mini adult. It must be treated by an appropriate pediatric oncologist, and it is, if we treat it in a proper way, in a proper place, at that time it can be cured. So by giving this message to our colleagues, by making seminar, symposium like this, we can minimize or reduce the physician delay. Thank you.
Thank you. So the third speaker, Dr. Zohra Jamila Khan, Associate Professor of Pediatric Hematology and Oncology, Dhaka Medical College. This is the question from Dr. Alauddin. Please tell us about the management of morphine side effects.
Thank you. We have already discussed in our practice, we got prevalence, more common side effects is constipation. And constipation is manageable constipation. And with prescription of morphine, if you do not prescribe laxatives, the prescription is considered incomplete. So we can easily manage constipation by prescribing laxative and lactulose, in severe cases Aqualax, and sometimes when there is morphine, duration of morphine given for more than 2 weeks, then it needs sometimes enema, bisacodyl, and other side effects is pruritus, and it is due to histamine release. Antihistamine is enough, chlorpheniramine, like histacin, and another is nausea. And morphine-induced nausea is easily manageable by domperidone. And in adolescent, haloperidol is recommended, but not ondansetron.
Thank you, Dr. Zohra Jamila Khan.
Thank you.
So no question. May I ask questions for the fourth speaker? So there is no question for the fourth speaker. So now, may I hand the mic over to the chairpersons?
Thank you. First of all, I'd like to thank the speakers and then the audience. There are 4 speakers in these sessions from the pediatric oncology. First speaker, Dr. A.K. Moshe, has nicely presented in lymphoblastic leukemia cases the level of serum lead in these cases, and highlighted its importance in the outcome of the disease. You know, more than 90% of ALL cases are cured with currently available treatment, though 10% are unfortunate to not have a good life. They don't survive. There are many causes, and among those, high lead level may be one of those. And I think from this discussion presentation, time has come to have more studies about the implications of high serum level in those cases which do not survive, particularly those 10 cases. Thank you very much, Dr. A.K. Moshe. Second one is presented by Dr. Mumtaz. She has beautifully presented the cause of delay in the treatment of childhood malignancies in her series. And it is true that if you delay in treatment in any cases of malignancies, the outcome is very worse. And you know, there is a very popular slogan in our country, Shuchona Dhorle Para, Cancer Jai Jashara. So we need to disseminate this slogan among our people to make them aware so that the patients, particularly the children having cancers, come to the proper physicians, proper center to have a very early diagnosis, to get early treatment so that we can be able to cure a significant number of patients. Third speaker, Dr. Zohra Jamila Khan, she presented in her talks the use of analgesics in the childhood cancer patients and have shown that most of the cases she has used paracetamols followed by morphine, I think. But I don't know whether she had followed the WHO ladder for the use of analgesics, because I have found that you have used tramadol, which is a mild opioid analgesics, is used in less number of patients than used in morphine cases. So why, I don't know. And you didn't mention the use of adjuvant therapies in these settings. So what is your comments?
Beforehand, can I tell something? Well, before Johra Jamila Khan, I just want to tell one thing, because she really had given the account of 2006 to 2014, if I am not mistaken, and she has given that from 2012 onwards, the new recommendation from the WHO has come up, and the WHO has said like that for mild only paracetamol, and for moderate and the severe morphine. And beforehand, when he was following, it was a retrospective study, it was followed, something were given indiscriminately, sometimes tramadol or other painkillers as such. So I think that was the thing that what she will really be telling on your query as such. Thank you.
Thank you, sir. Chaudhary Yaqub Jamal, sir. You have partially have answered my question. Actually, it is in my limitation of study, I have mentioned that due to retrospective study, and study was observed from 2004, and WHO guideline two-step ladder pattern was recommended at 2012. And there are so many other doctors in that centers, they are working after hours when usually I am not available at that time. They use it, they didn't follow the exact recommendation. This is the limitation of study. And we are using adjuvant drug, ibuprofen and paracetamol, along with morphine when needed. Only 3 drugs we are using: paracetamol, ibuprofen and morphine nowadays, and nothing else.
Thank you, Professor Mahbub. I am really thankful to the speakers, audience, and the organizers as well, because I have been invited here in this very august gathering to chair a very special sessions which cover the pediatric oncology as such, and 4 very important papers have been presented as such. The first one was serum level in children with acute lymphoblastic leukemia by Dr. Aminul Morshed Khorshu, and it was a very important paper. I think Khosru has a very, interesting predilection for doing research with serum levels of things. If I am not mistaken, his thesis for MD was serum zinc level, and he studied it in Atomic Energy Commission. And it is very interesting that the patients who kind of had this acute lymphoblastic leukemia had their serum lead level, which are almost 10 times higher than the control. It is really interesting, and I was explaining, I was expecting some kind of postulation, even if not a kind of specific remark about why this could have happened. It is 10 times higher. And somebody has asked how can this lead level can be lowered, I think. Environmentally, lead as such has come up lately as environmental pollution, other things. Lead has really been a very interesting and very important topic as such. So this type of research will definitely lead us to think about the pros and cons with the acute lymphoblastic leukemia, particularly in children, which is the commonest malignancy in children as such. Thank you, Dr. Khosru. Next was the evaluation of delays in diagnosis and treatment of childhood malignancies in Bangladesh. It was an important paper as well. I think, the objectives of the papers was maybe to assess the diagnostic, delay as such in Bangladeshi populations. Delays in diagnosis and treatment. So this is very important because what she has mentioned, that a good number of people knowingly or unknowingly go to practitioners. Sometimes they go to the homeopaths or things like that. This is not their mistake. But when some graduates are dealing with the patients and subsequently are making mistakes in referring or putting the patient in the proper place due to lack of knowledge, due to lack of training sometimes, but sometimes somehow things are being mistakenly going to or not being placed in the proper way that the proper treatment should be taken care of. So this is an important topic as well. And I should be thankful to Johra Jamila Khan, who for quite some time is taking care of the patients with palliative patients. Megan Doherty from Canada has come here in BSMMU, and she, along with Dr. Johra Jamila Khan and one of our students, Dr. Momena, is working very hard to give a proper shape to the pediatric oncological palliative care. And if I am not mistaken, they have done a workshop in Chittagong outside Dhaka recently. Am I right? I think yes. And lastly, Dr. Shahinur Islam, Associate Professor, Pediatric Surgery, Dhaka Medical College, has given an account of very interesting mediastinal cystic teratoma with right-sided extrarenal tumor. And she was mentioning it could be the only case in the world, maybe. So thank you very much. Thank you for patient hearing. And thank you all for being here.
So now, may I request Dr. Professor A.K.M. Khosru to come to the dais too and to take the memento from Professor Mahbubur Rahman. May I request the second speaker, Dr. Mamtaj Begum, to come to the dais to receive her memento from Professor Mahbubur Rahman, please. May I request the Dr. Zohra Jamila Khan, Associate Professor, Dhaka Medical College, to receive the memento from Professor Chaudhuri Yaqub Jamal. May I request Dr. Shahinur Islam to come forward to receive his memento from Professor Chaudhuri Yaqub Jamal. Thank you. May May I request Professor Kamaluddin, Department of Oncology, Sirat Medical College, to come forward to the dais to present the memento to our today's chairpersons. Thank you, sir. Thank you.
Now I will request our session chair, Professor Chaudhuri Yaqub Jamal and Professor Mahbub Rahman, to hand over the memento to our moderator, Dr. Muhammad Tawfiq.
So we are declaring the session concluded to inviting you for the next session. Thank you.
Thank you, Honorable Session Chair, Professor Chaudhuri Yaqub Jamal and Professor Mahbubur Rahman and moderator Dr. Muhammad Tawfiq. Now is the end of the pediatric oncology session. Now we'll start the session on medical physics and radiation oncology. And for that, I would like to invite Professor K. Siddiqui Rabbani and Professor Sadiq Malik and moderator Dr. Sadia Sharmin to have a seat on the dais. For your information, I would like to invite again Professor K. Siddiqui Rabbani, Professor Sadiq Malik and moderator Dr. Sadia Sharmin to have a seat on the dais. Now our session will be on medical physics and radiation oncology. I would like to request Dr. Sadia Sharmin to conduct this session as a moderator.
Assalamu alaikum. Now the session is on medical physics and radiation technology. Our first speaker is absent. Now we start our session with our second speaker, Karthik Rajmoni. He will present on a preliminary evaluation of respiratory gated volumetric modulated arc therapy in the true beam liner accelerator, a dosimetric study. Karthik Rajmoni.
No, it will be inside the slide, no problem. It's okay. Yeah, good evening, everyone. First of all, I thank the Scientific Committee of the Bangladesh Cancer Congress 2015, and I do thank the chairpersons and the repertory of this session. My topic is of presentation as a preliminary evaluation of respiratory gated volumetric modulated arc therapy in a true beam linear accelerator. It's a dosimetric study we conducted in our center. Obviously, interfraction is a big problem with the radiotherapy. During the course of the treatment, obviously there are volumes of moving, especially in the lung and abdomen. And there are new tools, which is 4D-CT. Really you can understand, how the internal organs moves with the internal respiration. The most difficult thing is, there is a blurring of internal structures during the CT simulation. This gated treatment can reduce the dose to the normal tissues, and really we can save the normal tissue and escalate the dose to the target. In this study, we try to evaluate the accuracy of the gated VMAT delivery. For an example, if you see these two slices, when you try to do an CT scan for a radiotherapy purpose, if you don't do it like an 4D CT, if you try to do it in a normal routine CT manner, like you have an axial CT or you try to do it in a slow scanner, obviously you get a lot of artifacts. It's very difficult to define the anatomy, and it's always very difficult to contour the structures. Here you can see in the left side, there is it's just touching the liver. Really we cannot define the lung properly. But if you're using the 4D CT data, really, with a particular bin, there'll be no much of an artifact. You can really clearly see the tumor. And with a lot of functional imaging also included in radiotherapy, really we can accurately target, we can delete the target. For an example, in this slice, if you do with a free breathing PET CT, you can see the mismatch with the target. There is an obvious difference with the mismatch with the target. But when we try to do with a 4D CT based PET CT, you can exactly match the PET data with your CT data. Really, it avoids normal tissue damage. Really, if you want to do an SBRT or an SBRT where you want to escalate a lot of doses, really you can reduce the doses to the normal tissue, and accurately we can target the tumor. In conventional radiotherapy, normally with small moving volumes, but we really don't know how the volume is going to move. So that we give a standard margins, okay, like we give an CTV, and we given something about 1 or 2 centimeter craniocaudal margin, and we given PTV margin for setup errors. Obviously we end up in a larger volume. And dose, obviously we give a lot of dose to the normal tissues, and dose escalation is very difficult. And most of the times, standard margin underestimate the tumor motion. Sometimes if you give 2 centimeter also, it's not very adequate, especially when you have a target very close to the diaphragm. And what geometry use for the dose calculation? Because the target is moving, it's very difficult. Here with 4D CT based, radiotherapy, in a moving volumes, it's obviously we can use an maximum intensity pixel, and normally we use an end inspiration phase, because tumor stands there for a longer time, so that we can do it in a gated window. We can use an end inspiration phase. You can really save a lot of normal tissue. And obviously dose escalation is possible because we are going to treat a very small volume and less dose to the surrounding normal tissue. Here it's a typical example, how that dose distribution changes. If it's we think it is in static movement, but once there is a target motion, you can really see how the target moves inside the dose distribution, and especially the dose distribution entirely changes. And most of the times if you see at the end inspiration, the tumor stands there for a longer time. So it's always better to just get it on that window, particularly at the end inspiration. And normally we give a margin as where the tumor moves in an inhale and an exhale position, we give a larger margin, and always we end up in a larger margin. Why not we can treat in a particular position? That's a part about gated radiotherapy. We can target the tumor at a particular gate, and you can gate that window and just treat the tumor at that window. Really, tumor spends a lot of time, at the exhale position, and so that most of the times we used to do a gated radiotherapy on the exhale position. This is a typical example of our lung gated VMAT. You can see the 4D CT, how it moves. We haven't, all the 4D CT has been divided into 10 phases. You can see that the tumor is moving, and we have to make sure the entire dose distribution, this covers the tumor during the motion of the treatment. The entire respiration cycle, we have to make sure the tumor is within the target during the course of the breathing cycle. So that making an ITP within 40 CT, which we make sure, the tumor is inside our target volume. And this is one more example I have it for an liver patient here. Here you can see it, we can really confirm it very well, and you can see how that internal organs are moving inside. But during the internal organ motions, we are covering the entire tumor volume. That's more important. The 40 CT, it makes sure we are covering the entire internal target volumes. Whatever the moment it is there, we are covering the entire volume during the course of the respiration. This 40 CT helps this to make sure that during the course radiotherapy with respiration, we are covering the entire internal target volume. What we did is we took an end inspiration respiratory cycle, and we used an pinpoint CC01 ion chamber for our verification purpose. And the plan has been created, the lung plan and the liver plan has been created in the TPS. And we just divided into two parts. One is an absolute dosimetry, one is a fluence verification. And the pinpoint chamber is used for the absolute dosimetry part, and iMatrix is used for your fluence verification part. This is how the experimental setup it is with the machine. With the gantry holder, we attach the iMatrix, and you can see on the table, you can see there is an infrared marker attached with an moving respiratory phantom. This will allow you to give an respiratory cycle, and we used to, what are the patient respiratory cycle? We are going to do it in an end phase. Normally, we take 90, 0, and 10, and we try to do a gated in that area, and we try to irradiate the machines with this gantry holder, so that as per the irradiation, it will acquire all the data in the iMatrix. And this is our gamma evaluation screen, where the top one, which is in the red, shows from the TPS, and the second one, which is the green one, which shows the measured data. You can see really a good match. More than 99% of pixel are passing within plus or minus 3% dose and 3% distance. And this is one more liver patient, and this also passed very nicely. We use an 3% 3 mm criteria, which also more than 99.7% of the pixels are passing. To conclude my presentation, gated VMAT has a potential dose escalation compared to the free breathing technique. Absolute dosimetry of all the test patients were within plus or minus 2%. Gamma evaluation using iMatrix results more than 97% pixels were passing within 3 mm distance and 3 mm dose criteria. Our dosimetry results were encouraging and give us confidence that our planned delivery fluence were within the acceptable clinical limits. With this positive dosimetric results, we are planning to implement the gated VMAT in our institution in the near future. Thank you very much.
Thank you, Karthik, for your informative presentation. Is there any question to Karthik Rajmoni? Now I request our next presenter, Mohammad Anisuzzaman Bhuiya. He will present on influence of jaw tracking in intensity modulated and volumetric modulated arc radiotherapy for head and neck cancers, a dosimetric study. Mohammad Anisuzzaman Bhuiya.
Good evening, everyone. Thank you very much for giving me the opportunity to share my clinical experience. Basically, intensity modulated radiotherapy nowadays becoming a standard practice for head and neck cancers, and incorporating with advanced imaging technology like PET-CT and MRI improves to confirm the target and OAR very precisely. And IMRT technique basically improves local control and overall outcome, dose escalation for the target, and critical organs under the tolerance improve the quality of life. easy. Here, the typical dose distribution for an VMAT and IMRT dose delivery. In VMAT, gantry rotates 360 degree and delivers from every angle. And in IMRT, dose delivers from fixed gantry angles. Normally for head and neck cancer, in our practice, we use 7 fields. Here, the video shows the dose distribution from a rapid arm, and it's with the static jaw. And in next video, you will see the jaw tracking is working. That means jaw is beyond the MLC movement, and it can track to the target as well. Here, the IMRT static jaw versus the IMRT jaw tracking videos. In left side, you will see the fixed jaw is fixed, and in right side, MLC jaw is moving towards the MLC movement. Now my study, dosimetric study on the fluence of jaw tracking in intensity modulated and volumetric modulated arc radiotherapy in head and neck cancer. I am Mohammad Anisuzzaman Bhuyan, a medical physicist, United Hospital Limited. The overview of my study is patient selection, contouring of target and OARs, treatment planning, a dose prescription, plan analysis results, and summary. Retrospectively, 10 patients, previously treated 10 patients selected for this study, and mostly the larynx and vocal cord, and the stage was T1, T2, N1, and M0. Contouring of targets and OARs. All patients were immobilized with custom-made thermoplastic mask, a CT simulation with slice thickness 2.5 millimeter. The targets and OARs were contoured slice by slice on CT images. The body was segmented automatically by Eclipse planning system version 11. Isotropic margins of 3 mm were created from CTB to PTB. All the patients dose precision done by simultaneous integrated boost technique. Here the high risk CTB dose prescribed for 70 gray in 35 fractions, and the intermediate risk CTB got the dose 63 gray per in 35 fractions, and low risk CTB will receive 56 gray in 35 fractions. In treatment planning for IMRT, we use 7 fixed field with sliding window techniques, and gantry angles are 0, 51, 100 to 153. Basically, all the gantry angles maintaining with the same distance, and we use the optimization version Eclipse DVU optimizer 11.0. and planned dose rate was 400 monitor unit per minute. For rapid arc, for all the patients, we did dual arc and 178 control points per arc. Planned dose rate 400 monitor unit per minute, and we use Eclipse PRO optimization version 11. Dose constants used in treatment planning, basically for all the priorities, we kept the mean dose kept by 25 gray, and spinal cord we maintained our dose max dose 45, and target coverage was 95 to 107%. This is the total body dose of comparing with jaw and static jaw. Here this graph shows the dose versus the volume, and If I magnify it, then you can see in lower doses, the volume is too much. That means in lower doses areas, the much more volume will get a bigger dose. And in statistically, if we want to see, then we can see for V5 areas, the mean variation is around 4%, where the V30, the variation was within 2% or 1.8%. The same thing for volumetric modulated arc therapy, comparing to jaw and static jaw technique. This is also a graph for the whole body, and if I magnify it, then again we can see some difference, but it is not that great with comparing to IMRT. And in statistical evaluation, I found B5 is around 2.6%, and the B30 volume is around 0.6%. Critical organ dose comparison for IMRT, static jaw and jaw tracking. For right parotid, we found around more than 4%, that is in the mean dose of our suppose 24.1 plus and minus 4.9, and for jaw tracking we found 23.06 plus minus 4.02. If count it as a percentage, that it will become around 4%. The parotid we found around 4 to 5% dose difference, but in spinal cord it is not that much. It is again we found less dose difference in jaw tracking options. This is again the dose difference percentage for VMAT, and in this is again the dose comparison for VMAT structure. Here also we found the dose difference, and we found less difference in the spinal cord, and also very close difference with the parotid also. In summary, I think both jaw tracking and static jaw IMRT plans can achieve comparable target dose coverage. Jaw tracking IMRT displays a superior OAR sparing than static jaw IMRT plans, and the results were clinically significant. Jaw tracking IMRT significantly reduces the low dose volumes comparing to the static jaw IMRT. Jaw tracking rapid arc result shows insignificant results compared to static jaw rapid arc plans in OARs and low dose volume sparing. In conclusion, IMRT jaw tracking results are of clinical importance, especially for the patients with large and complex targets, highly radio sensitive organs, and for patients with local recurrent or secondary malignant lesions within a previously irradiated area. Rapid arc jaw tracking were not clinically significant due to less amount of monitoring unit with comparing to IMRT. Thank you very much.
Thank you, Mohammad Anis, for your nice presentation. Now I request Mohammad Harunur Rashid, our last presenter, to present his topic on quality assurance of microselectron HDR remote afterloading brachytherapy unit.
Respected session chair and learned audience, good evening, Assalamu alaikum. My presentation is quality assurance of microselectron HDR remote afterloading brachytherapy unit. I am MD Harunur Rashid, medical physicist, Department of Oncology, Bangabandhu Sheikh Mujib Medical University. Contents. Here are the contents of my present introduction. Quality assurance QA in the radiation therapy treatment process is essential to ensure an accurate dose delivery to the patient to minimize the possibility of accident exposure. At the end of the commissioning measurements, before the equipment is put into the clinical use, quality assurance tests have been established. This studies our experience in the quality assurance and quality control of the microselectron HDR brachytherapy is discussed. One of the main objectives of radiotherapy meshing is to ensure an accurate and safe close delivery to a target volume while avoiding unnecessary delivery to surrounding healthy tissues. The radiotherapy meshing for treatment techniques are classified into two categories. One is external beam radiotherapy EBRT, another is brachytherapy. Here we discuss about the brachytherapy meshings. Brachytherapy, the word brachytherapy is derived from the ancient Greek words bra, which means short or close, and which was several meaning including medical treatment of therapy. Brachy is a form of radiotherapy in which radioactive sources are placed inside or near the tissue to be irradiated. History. The first successful brachytherapy treatments are performed on after Marie and Pierre Curie discovered of radium 1898. This picture shows radium 226 surface applicator are used the treatment of skin cancer. This is the another picture of after loading. Brachytherapy sources are usually inserted into the catheters or applicators when the radioactive brachytherapy source is positioned in the patient after the surgical procedures. After the insertion of the applicators, the technique is called afterloading. Rolf Siebert first proposed the concept of the remote control afterloading in 1937. Here the story of brachytherapy. My objective. The main objective of this study is to deal with the structure of quality assurance and quality control program of HDR remote afterloading brachytherapy unit, QA and QC procedures of HDR remote afterloading unit, nucleotron microselectron HDR-B2 was done at Department of Oncology, Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. Quality assurance. Quality assurance is all those planned and systematic action necessary to provide adequate confidence that a product or a service will satisfy given the requirements of quality. Reactive source, soil type ionization chamber, electrometer, source position simulator, source position check roller, survey meter. Radionuclides have a history of use of sealed source in brachytherapy, but only 6 cobalt 60, cesium 137, strontium 90, radium 192, iodine 125, palladium 103 are commonly used. Radium 220.
অফিসে যান, আমার পরিবার ফোন দিয়ে বলছে যে ফাতেমা আবারে কোন যে আমার একটু ব্যবস্থা করে নিতে। পরে আমি গেলাম অফিসে, যে বললাম যে আপা এই ঘটনা এই ব্যাপার আমার 2-3 দিন আরও খেটাই দিচ্ছে আমার একাকারি। আমার কয় এসব কোনো ঘটনা না, তোমার বউ চালাকি, এত মানুষ থাকতেছে তোমার বউর সমস্যা। বললাম আমার বউর সমস্যা না, তোর লগে তো আরও মহিলা আছে, এগোরও সমস্যা। এখন আপনি একটু জিগাই দেখেন, কয় আপনি জানগা আমি মেসেজ দিয়ে পাঠাই দিতেছি, দেখি করণ যায়। আমার পরিবারের কান্দা দেখলে আপনার চোখ দিয়ে পানি আইব। আমার বোর যে কান্দা এটা দেখলে আপনার চোখ দিয়ে পানি আইব। হাউ করে খালি কান্দে মোবাইলে, যে আমারে নিয়ে যাও, আমারে বাঁচাও, নাইলে আমার মারিয়ে ফেলাই দিব। এখান থেকে এই 1 মাস পরেই, পাঠানোর 1 মাস পরেই পরে ইউনিভার্সিটির ফুলাবান আছে, এই ইউনিভার্সিটির ফুলাবানে রাতে যেয়ে বলছে আমার বউ। বলার পরে ইউনিভার্সিটির ফুলাবান নিয়ে থানায় দেওয়ার পরে থানার থেকে আবার ওই যে মালিকের বাসায় দিয়েছে, ওই মালিকের মেসেজ দিয়ে দিছে, হ্যাঁ এসে থানায় পারে নিয়ে গেছে। আমার পরিবারে নিয়ে যে পরের দিনকে রাইতে আবার মারছে, মারিয়ে এবার ওই যে পরের দিন আনছে মেডিকেলে ভর্তি করেছে, 5 দিনকের কথা কই যে তুমি 5 দিন থাকবা মেডিকেলে। তখন আমার পরিবার বলছে যে আমার তুমি এই 5 দিনের মধ্যে তুমি আমার নিয়ে যেতে পারবে, আর 5 দিন পার হয়ে গেলে নিয়ে যেতে পারবে না, তো তুমি আমার 5 দিনের ভিতরে তুমি একটু নিয়ে চিন্তা ভাবনা করো। আমি বললাম আমার তো দ্বারা হইতেছে না, আমি তো একর কাছে বারে বার যাইতে চাই, আর আমার খেলাই দিতে এসব কোনো ঘটনা না, কোনো সমস্যা না, তুমি যাও আমরা দেখতেছি। কাগজপাতি দেয় তা দেয় 2 লাখ টাকা লাগবে, তোমার বহুত সমস্যা 2000 রিয়াল, আমার বিমান ভাড়া লাগবে 36,000, আর নাইলে আমি বললাম যে আপনাদের ব্লগেরই তো একজন আইছে মহিলা, সিলেট বাড়ি, ভাই এটা জানো তুমি? আমি বললাম হ্যাঁ আমি জানি। এই লোকের লোক আমার কথাই হয়েছে, একটুই হবে, এই লোকের খালা আইতাছে, আপনারা কি বলেন? কয় না আমরা জানি, আইব না, ওটা আমার আয়ত্তার ভিতরে না। পরে আমি বললাম যে ফোন দিয়ে কথা কন, পরে ফোন দিয়ে আর কথা কয় না। পরে আমার পরিবার যখন মেডিকেলে রয়েছে তখন আমি গেলাম, আরো মহিলা আপনি কামে এগোরও সমস্যা, কয় হাউস ভিসা, কয় বাসা বাড়ি। তাহলে এখন আমার পরিবার কই আছে আপনি একটু জিজ্ঞান তো, আপনি মোবাইলে কথা কন। এখন আমার পরিবার হাউস ভিসা, তাহলে এখন মেডিকেলে কেন? তখন বলো সব তুমি বুঝবা না, এই ফাতেমাই আমার কয় সব তুমি বুঝবা, দেখেন তুমি যাও, আপনি জানগা আমি মেসেজ দিয়ে পাঠাই দিতে, তোমার পরিবার আমরা এনে দিব না, দেখি করণ যায়। আমার পরিবার দিছেন হাউস ভিসায় কামে, আমার পরিবার হলো মেডিকেল, বোর যে কান্দা আজকে 5 দিনের জন্য আপনারা এটা কি শুরু করে দিয়েছেন। পরে যে আমার হুমকি টুমকি দিয়ে আমার খেদাই দেয়, মানে আমি গেলে আমার ভাতটাই দেয় না, আপনি আমার চিনিই না। পরে যে কান্দে মোবাইলে আমি যোগাযোগ করছি। নির্যাতনের ঘটনগুলি আর কোনো আঠাই কোনো প্রসেস নাই, মানে মারিয়ে ঠ্যাং ঠং একবার ভাঙিয়ে লাইছে, জোর করে ধরে ঘরের মধ্যে আটকে রাখে, আর এসব কাম করে মালিকের পরিবার যখন থাকে না, যে আমারে নিয়ে যাও, আমারে বাঁচাও, নাইলে আমার মারিয়ে ফেলাই দিই। মালিকের বউর মালিকের থেকে আর বাচ্চা 2টা, আর মালিক থেকে বাসাত থাকার পরে এই 1 মাস পরের মধ্যে নিয়ে 1 মাস পরে এটা অত্যাচার পরে ইউনিভার্সিটির নির্যাতন করার পরে এটা সহ্য না করতে পারে, তখন আমার কাছে ফোন দিছে যে এই ব্যাপারে আমারে নির্যাতন করতেছে, ফুলাবানে রাতে যেয়ে বলছে আমার বউ, বলার পরে সম্ভব হইতাছে না। তখন আমি আইছে এগরে বারবারই বলি অফিসে, থানায় দেওয়ার পরে থানার থেকে আবার ওই যে মালিকের বাসায় দিতে বারবার রিকোয়েস্ট করি আমি আগের কাছে। পোলাও আছে, পোলার বাবু আছে, আবার বন্ধু বান্ধব আসে রাইতে, আবার মাঝে মধ্যে গাড়িতে করে নিয়ে যায়। একদিন রাতে 12টা বাজে আমার ফোন দিছে, আমি তখন জিজ্ঞাসা তুমি কই, আমি তো জায়গা চিনি না, আমার গাড়িতে করে জানি কই নিয়ে যাইতেছে, এরা 4-5 জন বন্ধু বান্ধব। আমি তখন বললাম যে তোমার এক জায়গায় কি গাড়ি খাড়ায় না? কয় খাড়ায়। আমি বললাম তুমি বাইরে কি পুলিশ টুলিশ দাও না? কলে এটা বাংলাদেশের মতো না তো, যে রাস্তা দিয়ে মানুষজন হাঁটে কি কিছু দেখা যায়। কয় গাড়ির মধ্যে ঢুকলে বাইরে আবার পরের দিন আনছে মেডিকেল, গাড়ির ভিতরে তো লক করাই, এটা তো হেরা বাইরে যাইতেছে, আমারও লক করে থুয়ে যাইতেছে, অন্ত আমি খুলতে পারি না, তাই আমি পারবো কেমনি? আর বাড়ির ভিতরে যখন ঢুকাই তখন তো বাইরে আগের থেকেই তালা মারি ফেলাই, 4 তলা 5 তলা বিল্ডিং এর উপরে। কয় এখন আমার তো মরা ছাড়ার কোনো পথ নাই, কথা কই এরা যখন আমার কাছে যায়, 5 দিন থাকবা আমার যে অত্যাচার করে পরিবার বলতে সময় যে, তখন তো আমি কুল হইতে পারি না। আমার সাথে শেষ কথা হয়েছে গ্যাসে মাসের হলো 22 তারিখে, এরপর আর কোনো যোগাযোগ নাই। ওই দিনই বলছে যে আমার দ্বারা আর নাই হবো না, আমার তো খুব কষ্ট লাগে। আর 5 দিন আমার একটা পোলা আছে, পোলাটাই যে এতিম হয়ে গেছে গা, লেখাপড়া বন্ধ হয়ে গেছে, মা নাই, আমার 5 দিন লেখাপড়া বন্ধ, আমি থাকি বাইরে একটু কাম কাজ করি টুকটাক, আমি কাম না করলে তো আমার ভাত খাওয়া যায় না। মানে আমি কাম করবো না, এটার পিছিয়ে দৌড়বো। 3 মাসের ভিতরে কোনো টাকা পয়সা আমার কাছে না। আমি তো এখন দেয় না, বেতন দেয় না আমার ঘরে দিতে। আমি একদিন বলছিলাম যে বেতন টেতন দেয় না, কয় বেতন হেরা দেয়, মালিকে বেতন দেয়, কিন্তু আমারে দেয় না, অফিসে জমা দিয়ে দেয়। কলে বেতন অফিসে জমা দেয়, এসব কোনো ঘটনা না, কোনো সমস্যা না, তুমি যাও। সুদের টাকা ঋণ বাড়তেছে, হ্যাঁ টাকা নিয়েছিল ৭৫,০০০, এখন প্রায় 1 লাখ হয়ে গেছে। এখন তো সবাই এরা চাপ দিতেছে আমারে ফোন দিয়ে দিয়ে, যে আপনার বউ টাকা নিছে, এই টাকা আমাকে দিতে হইব, কেমনে দিবেন? টাকা তো হলো ব্যারাক সমিতি, মানে হেরা তো আর এটি বোঝে না। আজ 3 মাস গেছে, 3 মাসের ভিতরে নিজেই বাঁচে না, এখন কই আছে আমি তো খোঁজই জানি না।
জীবনের চলার পথে নারীরা নির্যাতিত, লাঞ্ছিত হয়, কখনো স্বামী দ্বারা, কখনো নিজের পরিবার দ্বারা,
36,000
সমাজ বাঁচার তাগিদে হয়তো একটা ভালো চাকরি জোগাড় করে জীবন কাটাবার স্বপ্নে বিভোর হয়ে তারা যে স্বপ্ন বনে, সেই স্বপ্নই একসময় ফাঁদ হয়ে ধরা দেয়। তারা পাচার হয়, প্রতারিত হয়।
আমি জানি এই লোকের সাথে আমার কথাই হয়েছে, এই লোকের খালা
আমার মাধ্যমে অফিসে আসছে এবং আমার মাধ্যমে গেছে, এবং এটা আমাদের অফিস থেকে যায় না, এটা গেছে ইফতিশার ইন্টারন্যাশনাল থেকে। কেউ যদি কোনো অভিযোগ দেওয়ার প্রয়োজন
আইতাছে, আপনারা কি বলেন? কয় না আমরা জানি, আয়ত্তার ভিতরে না। পরে আমি বললাম যে তাহলে আপনি ফোন দিয়ে কথা করেন, পরে ফোন দিয়ে আর কথা
একটু রিভাব।
পরে আমার পরিবার যখন মেডিকেলে রয়েছে, তখন আমি গেলাম যে আরো মহিলা আমি পাড়ামো না। পরে আমারে আপনি কামে ভাই হাউস ভিসা আপনি ভাই বাসা বাড়ি, তাহলে এখন 12:30 আপনি ওয়াইফের নিয়ে একটু অফিসে আসেন। আমি বললাম কেন? ভাই আসেন, আপনার লোক একটু দরকার আছে। আমি বললাম যে না আমি অফিসে আসতে পারবো না, আমি ভাই গরিব মানুষ, আমি কাজ কাম করি। আমার পরিবার কই আছে আপনি একটু জিজ্ঞাসা করেন, আপনি মোবাইলে কথা করেন। ভয় পান নাকি যে আপনি এখন আমার পরিবার? আমি ভয় পাই, আমি পাঠাবো না। বলছে আপনি গরিব মানুষ, 20-22 হাজার টাকা বেতন পাইবো, আপনি একটু ভালো হইব, আপনি পাঠান, আপনি আসেন, আপনি রয়বেরে নিয়ে আপনি আসেন। পরে আমি বিষয় তাহলে আমি মেডিকেলে গেলাম, তখন বলো সব তুমি বুঝবা না, বলছে যে যা কিছু করার দরকার সব আমি করে নিব, আপনি খালি একবার অফিসে আসেন।
এত ঝামেলা দরকার নাই, উনার ওয়াইফ গেছে বিনা পয়সায় ফেরত আসতে বলে, উনি
কি আর বিনা পয়সায় গেছে?
টাকা পয়সা দিয়ে নিয়ে চলে আসবে। আর যদিও
অফিসে টাকা না দিলে গেছে নাকি?
আমার কমপ্লেইন গেলে যাবে মন্ত্রণালয়ে, যাবে থানায়,
সব তুমি বুঝবা, তুমি যাও, আমি জানগা, আমি মেসেজ দিয়ে পাঠাই দিতে, তোমার পরিবার আমরা এনে দিব না।
যদি কোনো ভুল করে ওই লাইসেন্সের নামে আপনারা মন্ত্রণালয় থেকে লাইসেন্স কে কমপ্লেইন দিবে, আমি না আমি ওর কাছে সমস্যা সমাধান হইতে গেলে আপনি গঞ্জ ওখানে যদি মন্ত্রণালয়ে এসে আমার এটা
আমার পরিবার দিছেন হাউস ভিসা কেন বানিয়ে আইবো? আমার পরিবার হলো মেডিকেল। আর বোর যে কামটা আজকে 5 দিনের জন্য আপনারা এটা কি শুরু করে দিয়েছেন? পরে আমার হুমকি দিয়ে আমার এখানে মানে আমি গেলে আমার ভাতটাই দেয় না। আপনি
ক্যান্সার একটা ভয়াবহ শব্দ, সেকেন্ডেই আপনার জীবনের সমস্ত আলোগুলো বন্ধ, আপনি অন্ধকারে হাতড়ে বেড়াচ্ছেন। এই ভয়াবহ ক্যান্সারকে নিয়ে আমরা যারা কাজ করি, আমরা যারা চিকিৎসক, আমরা যারা সমাজসেবক, আমরা যারা সাংবাদিক, তাদের সবাইকে নিয়ে একসাথে কাজ করার জন্য প্রফেসর ABMF করিম স্যার অনকোলজি ক্লাব প্রতিষ্ঠা করেন। প্রফেসর ABMF করিম স্যার বাংলাদেশের ডাক্তারদের মধ্যে একজন সফলতম চিকিৎসক ছিলেন। তিনি বলতেন,
প্রথম কথা হলো যে ক্যান্সারে না ভোগা সবচেয়ে ভালো। তার জন্য কিছু নিয়মকানুন মানতে হয়, যেমন একটা হলো সিগারেট না খাওয়া, পান না খাওয়া, স্বাস্থ্যের নিয়মকানুনগুলো মেনে চলা। এইগুলো করলে 100 ভাগের মধ্যে 50 ভাগ ক্যান্সার কমে যায়। আর তারপরেও যাদের ক্যান্সার হয় তারাও খুব সাবধানে সিগারেট একদম খাওয়া নিষেধ, না হলে অনেকেরই ক্যান্সার হবে না। তবে ক্যান্সার হলে তো হতেই পারে, তার জন্য চিকিৎসাও এখন খুব ভালো আছে এবং ইনশাল্লাহ তারা আরও ভালো থাকবেন।
তিনি বলতেন ক্যান্সার প্রতিরোধযোগ্য, ক্যান্সার আরোগ্য করা সম্ভব, এবং তিনি বলতেন যে আমাদেরকে এগিয়ে যেতে হবে। এই অনকোলজি ক্লাব বরাবরের মতো এবারও আয়োজন করতে যাচ্ছে বাংলাদেশ ক্যান্সার কংগ্রেস 2015। অনকোলজি ক্লাবের যারা বর্তমানে যারা আছেন তাদেরকে সবাইকে নিয়ে আমরা আজকে উপস্থিত হয়েছি। আমাদের মাঝে আজকে উপস্থিত আছেন অনকোলজি ক্লাবের প্রেসিডেন্ট প্রফেসর M.A. হাই স্যার, উপস্থিত আছেন অনকোলজি ক্লাবের বর্তমান সেক্রেটারি জেনারেল প্রফেসর A.M.M. শরীফুল আলম, অনকোলজি ক্লাবের বর্তমানের ফরেন অ্যাফেয়ার্স সেক্রেটারি ডক্টর A.F.M. কামাল উদ্দিন। তো স্যার, আলোচনার শুরুতেই আমি অনকোলজি ক্লাবের প্রেসিডেন্ট ডক্টর প্রফেসর M.A. হাই স্যারকে জিজ্ঞেস করতে যাচ্ছি যে স্যার, এত বড় একটা আয়োজন, এই যে BCC 2015, এইটা আয়োজনের উদ্দেশ্যটা কি স্যার?
এটার উদ্দেশ্য অনেকগুলো আছে। মধ্যে একটা হলো যে কনফারেন্স যেগুলো আমরা করি সাধারণত, সেখানে দেশের যারা ক্যান্সার নিয়ে ডিল করতেছেন তাদের মধ্যে নিজেদের মধ্যে একটা ইন্টারাকশন হওয়া, যে কে কী কাজ করতেছে না করছে এটা জানানো, প্লাস বিদেশ থেকে আমরা যে ফ্যাকাল্টিদেরকে নিয়ে আসি দাওয়াত করে, তারাও এসে আমাদের সাথে তাদের সাথে ইন্টারাকশন হয়, যাতে করে দেশে আমাদের কী হচ্ছে বিদেশে কী হচ্ছে এটা সম্বন্ধে আমাদের একটা জ্ঞান বাড়ছে আর কি। কারণ সবাই তো বিদেশে যে কনফারেন্সগুলো হয় সেখানে সবাই যেতে পারে না, আমরা সবাই যেতে পারি না, গুটি কয়েকজন আমরা সাধারণত যাই, অ্যাটেন্ড করে আসি। বিদেশে অনেক কিছু কাজ এগিয়ে যাচ্ছে, তারা আমরা সেভাবে আগাচ্ছি কি না সেটা একটা কম্প্যারিজন হয়, নিজেদের অবস্থানটা আমরা বুঝতে পারি যে আমরা কোথায় আছি। এইটা একটা উদ্দেশ্য। আর একটা হচ্ছে যে আমাদের যে ইয়াং অনকোলজিস্ট যারা আছে তারা যে কী কাজ করতেছে, তারা পাবলিকেশন করতেছে, যে তারা কীভাবে প্রেজেন্ট করতেছে তার কাজটা। কনফারেন্স এটা হচ্ছে যে প্রত্যেকে যে তার যে কাজ কী হচ্ছে না কীভাবে প্রেজেন্ট করতে হবে সেটা শিখতেছে, যাতে করে তারা বিদেশে গিয়েও ওইভাবে প্রেজেন্ট করে আসতে পারে, সেটা একটা বড় উদ্দেশ্য।
স্যার, আমি এখন জানতে চাইবো স্যার প্রফেসর শরীফুল আলম স্যারের কাছে যে স্যার, বাংলাদেশে এখনো পর্যন্ত অনকোলজি সাবজেক্টে যতগুলো বড় বড় কনফারেন্স হয়েছে সবগুলোই স্যার আমরা জানি যেগুলো অনকোলজি ক্লাব করছে, সেই বিষয়ে যদি স্যার আমাদের কিছু বলতেন স্যার।
ধন্যবাদ সুমন। অঙ্কোলজি ক্লাব তো আমরা সবাই জানি যে আমাদের এটার অঙ্কোলজি ক্লাবের প্রতিষ্ঠাতা ছিলেন প্রফেসর M.F. করিম স্যার। উনি আমার টিচার, উনি তো ওনাকে আমি শ্রদ্ধাভরে আজকে স্মরণ করছি। কারণ এই ধরনের যে অঙ্কোলজি কনফারেন্স সেটার মানে আয়োজক ছিলেন উনি, এবং সেটা অঙ্কোলজি ক্লাবের ব্যানারে। তো অঙ্কোলজি ক্লাবের উদ্দেশ্য অনেকগুলোই আছে, তবে আমরা এই মুহূর্তে যেগুলো করছি সেগুলো হলো যে আমরা এখন যে মেইনলি যে আমাদের ম্যান পাওয়ার ডেভেলপমেন্টের জন্য যে ট্রেনিংয়ের ব্যবস্থা করা দেশে এবং বিদেশে। তো দেশে বিদেশে আমরা কাদেরকে ট্রেনিং দিচ্ছি মেইনলি রেডিয়েশন অঙ্কোলজিস্ট যারা তাদেরকে, রেডিয়েশন টেকনোলজিস্ট যারা তাদেরকে, তাছাড়া মেডিকেল ফিজিশিয়ানদের আমরা ট্রেনিং দিচ্ছি আমেরিকা, সিঙ্গাপুর, ইন্ডিয়া, এইসব দেশে আমরা, জার্মানি, এইসব দেশে আমরা আমাদের বিভিন্ন সেন্টারের সাথে আমরা যোগাযোগ করে আমাদের ম্যান পাওয়ার ওখানে পাঠাচ্ছি। এতে করে আমরা আমাদের যে অঙ্কোলজি ক্লাব যারা যাচ্ছেন তাদেরকে পার্টলি ফাইন্যান্সিয়াল সাপোর্টও দিয়ে যাচ্ছেন। তাছাড়া ডেভেলপ ক্যান্সার সেন্টারের থেকেও আমরা ম্যান পাওয়ার এখানে আনতেছি, এটা IE এর মাধ্যমেই আমরা মেনলি আনি এবং এনে হ্যান্ডস অন তাদেরকে ট্রেনিং দিচ্ছি।
ম্যান পাওয়ার ডেভেলপমেন্টের ব্যাপারে স্যার একটা জিনিস আমি যদি স্যার একটু জিজ্ঞেস করি, সেটা হচ্ছে স্যার যেটা বাংলাদেশে স্যার প্রথম একটা কনসেপ্ট স্যার করিম স্যার চালু করেছিলেন, যে স্যার অনকোলজি ক্লাব থেকে আপনারা ছাত্রদেরকে একেবারে মানে মিনিমাম ইন্টারেস্টে ফাইন্যান্স সাপোর্ট করে বিদেশে পাঠাতেন স্যার, যে একটা নমিনাল একটা ইন্টারেস্ট নিতেন, যে একটা 1% ইন্টারেস্ট, স্যার সেই বিষয়ে যদি আমাদেরকে একটু বলতেন স্যার, ম্যান পাওয়ার
সেটাই আমি
ডেভেলপমেন্টের
তো
ব্যাপারে।
বললাম যে করিম স্যারই এটার আয়োজক, এবং এটা করিম স্যার যে ফাইন্যান্সিয়াল সাপোর্টটা, যদিও করিম স্যার যখন এই আয়োজন করেছেন তখন অঙ্কোলজি ক্লাবের ফান্ড বলতে তেমন কিছুই ছিল না। করিম স্যার নিজেই সেই উদ্যোগ নিয়েছেন, বলতে তোমাদের এগুলো নিয়ে চিন্তা করতে হবে না, টাকা যা লাগে আমি দিব, এরকম একটা স্যারের সবসময় একটা বুকে অনেক সাহস ছিল, যে সাহসটা আমরা এখন অনেক ক্ষেত্রে দেখাতে পারি না।
মেইনলি অনকোলজি ক্লাব এখন ফোকাস করছে যে ম্যান পাওয়ার ডেভেলপমেন্টের ব্যাপারে।
আমাদের দেশে ক্যান্সারের ইনসিডেন্স বেড়ে যাচ্ছে অনেক, ক্যান্সার প্রকোপ বেড়ে যাচ্ছে অনেক, কিন্তু সেই তুলনায় আমাদের ম্যান পাওয়ার নাই, ইকুইপমেন্টস নাই। সেই জন্য আর কি মেডিকেলি আমাদেরকে ম্যান পাওয়ার তৈরি করতে পারলেও অন্তত কিছুটা আমরা সার্ভিস দিতে পারবো পেশেন্টদেরকে,
মানে কোয়ালিটি সার্ভিস,
অবশ্যই
কোয়ালিটি সার্ভিস দিতে পারবো।
আমার মনে হয় স্যার এখানে আরেকটা বিষয় আমি বলতে চাই, যে পৃথিবীতে এখন মেডিকেল টেকনোলজি যেভাবে আগাচ্ছে, সবচেয়ে দ্রুত আগাচ্ছে ক্যান্সার ট্রিটমেন্টের টেকনোলজি, এবং এটা এত দ্রুত আগাচ্ছে যে এটা উন্নত বিশ্বই এটার সঙ্গে এখন তাল মিলাতে হিমশিম খাচ্ছে। সেখানে আমাদের মতো একটা উন্নয়নশীল দেশের জন্য সেখানে তাল ধরে রাখাটা খুবই কঠিন। কিন্তু একটা মেশিন দেশে চলে আসতে পারে, পয়সা হলে মেশিন আসলে, কিন্তু যে মেশিন চালাবে তার দক্ষতা তৈরি করাটা এত সোজা না। এবং করিম স্যার নিজে যেহেতু উন্নত বিশ্বে কাজ করে এসছেন, উনি তাই এই বিষয়টা অনুভব করেই উনি সম্ভবত এই বিষয়টা সবসময় জোর দিতেন যে বাবা, মেশিনটা বড় কথা না, তোমাদের প্রশিক্ষিত হতে হবে, তোমরা বিশ্বমানের প্রশিক্ষিত চিকিৎসক হতে হবে। কারণ আমাদের এখানে শুধু ওষুধ দিয়ে চিকিৎসা না, আমাদের যে টেকনোলজি, যে রেডিওথেরাপি, মেডিকেল ফিজিক্স, এটা এমন জটিল একটা বিষয়, এটার জন্য যদি বিশ্বমানের একটা প্রশিক্ষণ না থাকে তাহলে মেশিন নিয়ে এসেও খুব লাভ হবে না। আমার মনে হয় এই কারণে স্যার এই ব্যাপারটা খুব জোর দিতেন, এবং আমরা এখন স্যারের সেই চিন্তা চেতনাকে ধারণ করে ওই চেষ্টাটাই করে যাচ্ছি অনকোলজি ক্লাবের পক্ষ থেকে, যে আমরা যে ম্যান পাওয়ার, বারবার বলছি ম্যান পাওয়ার এই কারণেই যে অন্য সাবজেক্টের সঙ্গে আমাদের পার্থক্যটা এখানেই, অন্যান্য মেডিকেল সায়েন্সের সাবজেক্ট এত দ্রুত আগাচ্ছে না, প্রতিদিন এখানে একটা পরিবর্তন হচ্ছে, সেটার সঙ্গে তাল মেলানোর জন্য আমার মনে হয় বিশ্বমানের একটা প্রশিক্ষণ আমাদের দরকার।
স্যারের মধ্যে আরেকটা চিন্তা ভাবনা ছিল, ক্যান্সার ট্রিটমেন্টের জন্য শুধুমাত্র রেডিয়েশন অঙ্কোলজিস্টই সব কিছু করবে না, এর জন্য ক্যান্সার অ্যাকুরেট ট্রিটমেন্ট দেওয়ার জন্য রেডিয়েশন অঙ্কোলজিস্টের পাশাপাশি রেডিয়েশন টেকনোলজিস্ট এবং মেডিকেল ফিজিসিস্টের যে প্রয়োজন আছে, সেটা স্যার খুব বেশি উপলব্ধি করেছেন বলেই যে ক্যান্সারের সাথে রিলেটেড যে অন্যান্য সাবজেক্টের আছে, যেমন ইএনটি অঙ্কোলজি, গাইনি অঙ্কোলজি, এইসব সাবজেক্ট, এইসব সাব স্পেশালিটিগুলোরও ম্যান পাওয়ার ডেভেলপমেন্টের জন্য স্যার অনেক উদ্যোগ নিয়েছেন, এবং সেটাও আমরা করে যাচ্ছি, এখনও করে যাচ্ছি। আমরা খালি যে আমরা রেডিয়েশন অঙ্কোলজিস্টদেরকে ট্রেনিং দিচ্ছি তা কিন্তু না, আমরা ট্রেনিং দিচ্ছি অন্যান্য মানে অঙ্কোলজিরই অন্যান্য স্পেশালিটির সাথে।
ডক্টর এফ এম কামাল উদ্দিন কে জিজ্ঞেস করতে চাচ্ছি যেটা, যে আমরা জানি যে একটা সায়েন্টিফিক কংগ্রেস আয়োজন করার সবচেয়ে বড় কঠিন চ্যালেঞ্জটা হচ্ছে সায়েন্টিফিক সেক্রেটারির। তো এবারের বাংলাদেশ ক্যান্সার কংগ্রেসের সায়েন্টিফিক সেক্রেটারি হিসাবে আপনি যদি এরকম একটা বড় কংগ্রেস, যেখানে সারা দেশের অলমোস্ট বড় বড় দেশ যেগুলো আমরা বলতে বুঝি, সিঙ্গাপুর, লন্ডন, মালয়েশিয়া, অস্ট্রেলিয়া, এরকম দেশ থেকে, বিভিন্ন দেশ থেকে ফরেন গেস্ট নিয়ে আসছেন, তারপরে আমাদের বাংলাদেশের প্রায় এবার আমাদের হাইয়েস্ট রেজিস্টার্ড পার্টিসিপেন্ট প্রায় 650, এতগুলো মানুষকে আয়োজন করতে যে আপনি কিভাবে এটা আয়োজন করলেন, আর আপনি এটা করতে যে কি ধরনের চ্যালেঞ্জের সম্মুখীন হলেন?
অনকোলজি ক্লাবের ব্যানারে যখনই আমি যে কোনো দেশে যোগাযোগ করেছি, আমাকে খুব বেশি বেগ পেতে হয় নাই, আমাকে পরিচয় দিতে হয় নাই। আমার মধ্যে দুটো লাইন যখন লেখা থাকে, দিস ওয়াজ ফাউন্ডেড বাই প্রফেসর এম.এফ করিম, ওই একটি কথার জোরে খুব সহজে কেউ আর আমাদের আমন্ত্রণকে না করতে পারে না। আমার মনে হয় এটা একটা অনেক বড় একটা ব্যাপার আমাদের জন্য। আর দ্বিতীয় কথা হচ্ছে আল্লাহর অশেষ রহমত, যে প্রথম থেকে আমরা দেখেছি যে হয়তো বা মানুষের মধ্যে এটার চাহিদা আছে কিন্তু আয়োজন হতো না, তাই যখনই আমরা আয়োজন করতে গেছি দেশের মধ্যেও আমরা প্রচুর সাড়া পেয়েছি। আমরা 2012 সনের প্রথম এসএফের সময় 175টা অ্যাবস্ট্রাক্ট জমা পড়েছিল, যেটা একটা মানে সবাইকে বিস্ময় করে ফেলেছিল, বিস্ময়কর ব্যাপার, কিভাবে এটা সম্ভব, কিন্তু এটা সম্ভব। তো সেরকম এটা একমাত্র অর্গানাইজেশনাল প্রোগ্রাম যেখানে আমরা অনকোলজিস্ট মানে ক্যান্সার বিশেষজ্ঞ ছাড়াও অন্যান্য অ্যালাইড সাবজেক্ট, যেমন গাইনিতে যারা ক্যান্সার নিয়ে কাজ করেন, ইউরোলজিতে যারা ক্যান্সার নিয়ে কাজ করেন, শিশু বিভাগে যারা ক্যান্সার নিয়ে কাজ করেন, প্রতিটা সাবডিসিপ্লিনের সবাইকে আমরা একসঙ্গে করি। তাতে গিয়ে হয় কি এটা একটা মিলন মেলার মতো তৈরি হয়, এবং তাতে সবাই এটাতে একটা অন্যরকম আমার মনে হয় যে একটা উৎসাহ খুঁজে পান। তাই চ্যালেঞ্জ নিঃসন্দেহে, কিন্তু এই জিনিসগুলো আমাদের জন্য সহজ হয়ে যায়। আর আমরা আরেকটা জিনিস চেষ্টা করি যে টিম ওয়ার্ক করার জন্য, যে সবাই মিলে কাজ করি। এখানে এককভাবে কোনো কাজ করি না। এখানে আমাদের সায়েন্টিফিক কমিটিতে সালাম স্যার চেয়ারম্যান আছেন, তারপরে যে বললাম স্যাররা আছেন, আর আমরা যারা সবাই মিলে যখন কাজ করা শুরু করে দেই আর সবার যখন এরকম একটা সুন্দর রেসপন্স পাই, তখন কঠিন কাজটাও সহজ হয়ে যায়।
আসলে ইম্পর্টেন্ট জিনিস হচ্ছে আমার মনে হয় যে কোঅপারেশন।
স্যার নিঃসন্দেহে স্যার, যে আসলে এটা আমার মনে হয় স্যার আমাদের মধ্যে এই জিনিসটা বীজটা স্যার তৈরি করে দিয়ে গেছে। স্যার সবসময় নিজের কথা বলতেন না, স্যার সবসময় অন্যকে বড় করে দেখানোর একটা প্রবণতা, আমরা স্যারের কাছ থেকে যে জিনিসটা শিখেছি। স্যার
এই বিষয়ে কামাল ভাই আমি যদি একটু আপনার মাঝখানে কথা বলতে একটু ইন্টারফেয়ার করি, মিডিয়া পার্সোনালিটিদের যে লাইফ টাইম অ্যাচিভমেন্ট অ্যাওয়ার্ড দেওয়া হতো, সেরকম আমাদের সাবজেক্টে যাদেরকে আমরা মনে করি যে যাদের কন্ট্রিবিউশনটাকে মানে কোনোভাবেই অস্বীকার করার মতো না, সেরকম মানুষদেরকে আপনারা সম্মান দেওয়া শুরু করেছেন। সেই বিষয়ে যদি মানে আপনি কিছু বলতেন স্যার।
শুধুমাত্র লাইফ টাইম অ্যাচিভমেন্ট দিচ্ছি তা না, আমরা আরও অনেক কিছু করতেছি। যেমন আমরা অন্যান্য স্পেশালিটিরও যারা পায়োনিয়ার তাদেরকেও আমরা উৎসাহিত করার জন্য এবং তাদেরকে স্বীকৃতি দেওয়ার জন্য তাদের কাজের এরকম কোনো অ্যাওয়ার্ড দেওয়ার চেষ্টা করছি। তাছাড়া আমরা যেটা করতেছি ইম্পর্টেন্ট জিনিস হচ্ছে যে সেটা আমরা প্রত্যেক যে এসএফওর সাথে আমাদের একটা মানে সম্পর্ক আছে, সেটা তো আপনারা জানেন বোধহয় যে সম্পর্ক এসএফওর সাথে সম্পর্ক। আমরা কিন্তু
এসএফওটা যদি স্যার আপনি একটু ডিটেইলস বলেন, এসএফওটা কি?
এসএফও হচ্ছে সার্ক ফেডারেশন অফ অঙ্কোলজি। আমরা যে অঙ্কোলজি ক্লাব কিন্তু সার্ক ফেডারেশন অফ অঙ্কোলজির বাংলাদেশ চ্যাপ্টার।
মানে সার্ক ফেডারেশন অফ অঙ্কোলজি স্যার মানে বাংলাদেশ থেকেই স্যার প্রথম এটা
মানে সার্কের প্রবক্তাও বাংলাদেশ, সার্ক ফেডারেশন অফ অঙ্কোলজির প্রবক্তাও বাংলাদেশ।
স্যার এবার আমি স্যার একটু খুব মানে একটা সেনসিটিভ বিষয় নিয়ে আলাপ করতে চাই স্যার। মানে বাংলাদেশে কারোর যদি স্যার মানে প্রথমে যদি মানে ক্যান্সারের মতো একটা ডায়াগনোসিস হয়, মানে যারা একটু আর্থিকভাবে সচ্ছল বা মধ্যবিত্ত এবং চিন্তা করে যে বাংলাদেশে কি আসলে চিকিৎসা করা সম্ভব কিনা, তো স্যার এরকম একটা সায়েন্টিফিক কনফারেন্সে তো স্যার সারা দেশের যেখানে ডাক্তাররা আসে, যেমন আমাদের এসএফওতে লাস্ট যে স্যার আমাদের সার্ক ফেডারেশন অফ অনকোলজিক্যাল কংগ্রেস ছিল, সেখানে প্রায় 80-85 জন বিদেশি গেস্ট এসেছিল। এবারও স্যার আমাদের প্রায় 24 জন মানে বাইরের থেকে গেস্ট আসছে স্যার। তো এদের সাথে আলাপচারিতায় স্যারকে আপনি মনে করেন যে আমরা আসলে অনেক পিছনে, নাকি স্যার আমরা এদের সমানে, নাকি স্যার আসলে আমাদের অবস্থানটা কি? এটা যদি স্যার আমাদের মানে আমাদের সাধারণ মানুষদের জন্য একটু বলতেন স্যার।
আমাদের ডাক্তাররা এদের যে জ্ঞান কম তা না, যথেষ্ট জ্ঞান আছে, কিন্তু এরা একটু ওভারওয়ার্কড ইন দ্য সেন্স যে আমাদের সংখ্যা কম কিন্তু রোগীর সংখ্যা অনেক বেশি, যে কারণে রোগী আমরা সময় কম দিতে পারি, বেশি রোগী দিতে সময় দিতে পারি না। রোগীর চাই যে তার কাছে আমরা বেশি করে কথা বলে তাকে বোঝায় সুন্দর করে, সেই জিনিসটা আমাদের পক্ষে একটু ল্যাকিং হয়ে যাচ্ছে। এটা একটা বিরাট ল্যাকিং আমাদের জন্য। প্লাস আমাদের ফ্যাসিলিটিস কম আছে, তো আগেই বলেছি আমি, সেন্টার মাত্র কয়েকটা হাতে গোনা, রোগী সেই তুলনায় অনেক বেশি। সেটা একটা প্রবলেম, যে কারণে আমরা কোয়ালিটি ট্রিটমেন্টটা দিতে পারছি না। এই কোয়ান্টিটেটিভ ট্রিটমেন্ট দিতে গিয়ে, বেশি লোকের একসাথে চিকিৎসা দিতে গিয়ে কোয়ালিটি ট্রিটমেন্টটা আমরা দিতে পারছি না।
রোগীদেরকে স্যার আমরা আসলে কি বলতে পারি যে স্যার আমরা কি আমাদের রোগীদেরকে যে স্যার আমরা মানে বিশ্বমানের চিকিৎসা যদি নাও দিতে পারি, আমরা কি স্যার স্ট্যান্ডার্ড চিকিৎসা কি দিতে পারছি স্যার?
আমি এখানে একটু ইন্টারাপ্ট করতে চাই যে আজকে আমাদের দুজন এক্সপার্ট ছিলেন ইন্ডিয়া থেকে। একজন হচ্ছে ম্যাক্স ক্যান্সার সেন্টারের ডাইরেক্টর ডক্টর হরিত চতুর্বেদী, আরেকজন টাটা মেমোরিয়াল হসপিটালে অ্যাসোসিয়েট প্রফেসর বেদাং মূর্তি। হরিত চতুর্বেদী বলছিলেন যে আমি 2010-এ বাংলাদেশে এসেছিলাম, আজকে হাই স্যারকে কথাটা বলছিলেন যে স্যার আই ক্যান সি যে গত 5 বছরে বাংলাদেশে বেশ ক্যান্সার ফিল্ডে প্রচুর উন্নতি হয়েছে। আমি এবারের আপনাদের কংগ্রেসে এসে আমি পরিবর্তনটা দেখতে পাচ্ছি। আর বেদাং বললেও যে ও 2013-তে বাংলাদেশে ক্যান্সার ইনস্টিটিউট ভিজিট করেছিল। তো গতকালকে একটা আমাদের প্রি কংগ্রেস ওয়ার্কশপ ছিল, সেখানে বললো যে আমি অলমোস্ট সেম গ্রুপ অফ ডক্টরসদের সঙ্গে আমার ইন্টারাকশন হলো, কিন্তু আমি 2 বছরে দেখলাম যে এখানে বেশ একটা পরিবর্তন, মানসিকতার পরিবর্তন, চিন্তা চেতনার পরিবর্তন চলে এসছে। তো সেই জন্য আমার মনে হয় যে এই কংগ্রেসে আমি জন্য স্যারের মাঝখানে আমি ইন্টারাপ্ট করতে বলতে চাচ্ছি যে এরা কিন্তু এই কনফিডেন্সটা আমাদের দিয়ে যাচ্ছে যে আমাদের মধ্যে যে পজিটিভ পরিবর্তনটা হচ্ছে এবং খুব দ্রুত হচ্ছে, গত কিছুদিনে এটা আউটলুকের একটা চেঞ্জ হচ্ছে, চিন্তাভাবনা চেঞ্জ হচ্ছে, এবং এতে আমাদের এই রিফ্লেকশনটা আমাদের ট্রিটমেন্টে পড়ছে। মানে তাতে আমাদের কনফিডেন্স লেভেল বেড়ে যাওয়াতে আমরা, আমার ধারণা যে এত কিছুর মধ্যেও আমরা আগের চেয়ে অনেক জোর গলা আর একটু ভালো চিকিৎসা দিতে পারছি। হ্যাঁ, আমাদের 160টা রেডিওথেরাপি মেশিন দরকার, সেখানে মাত্র 20টা আছে, এটা একটা লিমিটেশন। আমাদের ওষুধপত্রের দাম অনেক রোগীর পক্ষে দেওয়া সম্ভব না, আমাদের ডাক্তারের সংখ্যা কম, কিন্তু তারপরেও আমরা চিকিৎসা দিচ্ছি। এবং এখনও অনেক রোগী আমাদের স্যারদের কাছে চিকিৎসা নিয়ে বিদেশ গিয়ে ঘুরে এসে আবার বলেন যে স্যার আপনারা যা বলেছিলেন ওখানে একই কথা বলেছে। এই জিনিসগুলো কিন্তু আমাদের জন্য আমি মনে করি একটা পজিটিভ জিনিস, এবং এভাবেই আমরা ধীরে ধীরে আমার মনে হয় গেলে
আমার কাছে যদি নলেজ থাকে, আমার কাছে যদি ইকুইপমেন্টস থাকে, তাহলে আমি উন্নত মানের চিকিৎসা দিতে পারবো না।
স্যার আমি হাই স্যারের কাছে, আমাদের প্রোগ্রামের প্রায় শেষ পর্যায়ে স্যার আমরা, তো স্যার আপনি আমাদের এখন মানে আমাদের সাবজেক্টের মানে অভিভাবক স্যার এক কথায় আর কি। তো স্যার সামনের বছর আপনাদের অনকোলজি ক্লাব বা সারা বাংলাদেশের অনকোলজি ফিল্ড নিয়ে মানে ক্যান্সার সাবজেক্ট নিয়ে স্যার আপনাদের পরবর্তী ভবিষ্যৎটা কি, এবং স্যার আসলে আমাদের দেশের যে গরিব মানুষ যারা ক্যান্সার পেশেন্ট, যারা স্যার মানে গরিব মানুষ যারা স্যার আর্থিক সচ্ছলতা নাই যাদের যাওয়ার, এদের জন্য স্যার আপনাদের কোনো মানে কোনো মানে সামনে কোনো প্রোগ্রাম আছে কিনা?
আমাদের পার্টিকুলারলি বলতে গেলে গরিব পেশেন্টদের জন্য আলাদা করে আমাদের এখনও সেরকম কোনো আমরা কার্যক্রম নিতে পারিনি। একটাই করছি যে আমরা ফার্মাসিউটিক্যাল কোম্পানিগুলোকে বলি যে তোমরা যতটুকু পারো কম খরচে কম দামে ওষুধগুলো মার্কেট করো। ইতিমধ্যে আমার দেশে দুটো কোম্পানি অলরেডি প্রোডাকশন শুরু করেছে, তারা মোটামুটি কম দামে ওষুধ দিচ্ছে। তো ওটা দিয়ে কিছু হচ্ছে, কিন্তু তা সত্ত্বেও আরও অনেক লোক আছে যারা ট্রিটমেন্ট করতে পারে না। অনেক সময় কোম্পানিও এগিয়ে আসে গরিব পেশেন্টের জন্য কিছু কিছু দেয়, এইভাবে করে যাচ্ছে। কিন্তু যে একটা সাংগঠনিকভাবে যে কিছু করা, সেটা আমাদের পক্ষে এখনো করা সম্ভব হয়নি।
তাছাড়া স্যার আমাদের একটা কিন্তু আমাদের স্যার অঙ্কোলজি ক্লাবের পক্ষ থেকে কিন্তু স্যার আমাদের একটা টার্গেট আছে যে আমরা একটা ক্যান্সার সেন্টার করতে যাচ্ছি,
স্যার
চেষ্টা করে যাচ্ছি, আমরা জানি না কবে পারবো।
তো আমরা অনুষ্ঠানের শেষ পর্যায়ে সবার জন্য শুধু একটা কথাই বলতে চাই যে বিশ্বের সর্বাধুনিক রেডিওথেরাপির মেশিন লিনিয়ার এক্সেলেটর হয়তো আমাদের নাই, কিন্তু আমাদের
আছে
পর্যাপ্ত নাই, বাট মানে স্যার আমি স্যার আধুনিক সর্বাধুনিক 5 মেশিনের কথা আমি বলছি, যেটা স্যার সর্বাধুনিক মেশিন হয়তো আমাদের নেই, কিন্তু আমাদের আছে প্রফেসর এফ করিম স্যার। বিশ্বের সর্বশ্রেষ্ঠ চিকিৎসক হয়তো আমাদের নাই, কিন্তু আমাদের আছেন প্রফেসর এম.এ. হাই স্যার। স্যার বলতেন যে ক্যান্সার তোমাকে পিছনে টানবে, কিন্তু তোমাকে সামনে এগিয়ে যেতে হবে। বাংলাদেশের মানুষ এই আমরাই 1952 এনেছি, আমরা 1971 এনেছি, আমরাই পারবো। আমরা আমাদের যারা সিনিয়র টিচার আছেন তাদেরকে সাথে নিয়ে আমরা যারা নতুন জেনারেশনে আছি, আমরা আমাদের দেশের চিকিৎসাকে বিশ্বমানে নিয়ে যাব। আমাদের সাথে যারা অনকোলজিক্যাল সোসাইটি হিসাবে আছেন, অনকোলজি ক্লাব আমাদের সাথে থাকবেন, এছাড়া বাংলাদেশের যারা সবাই অনকোলজি নিয়ে কাজ করছেন তারা সবাই থাকবেন। ইনশাআল্লাহ আমরা বাংলাদেশের ক্যান্সার চিকিৎসাকে বিশ্বমানে পৌঁছাবো। ধন্যবাদ।
আপনারা দেখছেন চ্যানেল আই।
ছোট্ট বন্ধুরা এবং সম্মানিত দর্শক, সবাইকে সাদর আমন্ত্রণ জানাচ্ছি শিশুতোষ সংবাদ ভিত্তিক অনুষ্ঠান ক্যানেস্তারা উপভোগ করার জন্য। চলুন উপভোগ করা যাক ক্যানেস্তারা।
আমার চিনিই না, পরে যে করে কান্দে মোবাইলে আমি যোগাযোগ করছি। নির্যাতনের ঘটনগুলি আর কোনো আঠারই কোনো প্রসেস নাই, মানে মাইরে ঠ্যাং ঠং একবার আইয়া লাইছে।
Thanks to all dancers, very good presentation. Now we have Tagore song, Rabindra Sangeet, by our renowned artist Rizwana Chaudhuri Bonna, who is the renowned artist of Bangladesh and beyond Bangladesh, all over the world. And she is also the principal of Suresh Dhara. Now I am requesting Rizwana Chaudhuri Bonna to come over the dais for your presentation of Tagore songs.
সম্মানিত সুধী মণ্ডলী, নৃত্যের তালে তালে গেল অ্যাগনেস রেচেল ও তার সহযোগী দল। অনুষ্ঠানের এ পর্যায়ে রবীন্দ্রসঙ্গীত পরিবেশন করতে আসবেন স্বনামধন্য সঙ্গীত শিল্পী রেজওয়ানা চৌধুরী বন্যা। আমি রেজওয়ানা চৌধুরী বন্যা ওনাকে মঞ্চে আসার জন্য বিনীত অনুরোধ জানাচ্ছি।
ভালোবেসে সুখে নিভৃতে যতনে আমার নামটি লেখো তোমার মনের মন্দিরে। ভালোবেসে সুখে নিভৃতে যতনে আমার নামটি লিখো তোমার মনের মন্দিরে। ভালোবেসে সখী নিভৃতে যতনে আমার নামটি লিখো তোমার মনের মন্দিরে। আমারও পরাণে যে গান বাজেছে তাহার তালটি শিখো তোমার কনক মন্দিরে। ভালোবেসে সখী নিভৃতে যতনে আমার নামটি লিখো তোমার মনের মন্দিরে। ধরে রাখেও সোহাগে আদরে আমার মুখর পাখি তোমার প্রাসাদ প্রাঙ্গণে। ধরে রাখেও সোহাগে আদরে আমার মুখর পাখি তোমার প্রাসাদ প্রাঙ্গণে। মনে করে সখে বাঁধিয়া রাখিও আমার হাতেরও রাখি তোমার কনক কঙ্কণে। ভালোবেসে সখী নিভৃতে যতনে আমার নামটি লিখো তোমার মনের মন্দিরে। আমারও লতা
many thanks to Rizwana Banna for his melodious Tagore songs. And we will keep your name all over the hearts of Bangladesh and Bengali. Thank you. Now our next artist is modern Bengali song. Artist is a very renowned one, Anupama Mukti, very sweet singer of this time. Anupama Mukti, I will request Anupama Mukti to come over the stage for her presentation.
গানে গানে ছন্দে ছন্দে বেলা অনেকটাই বয়ে গেল। সুধী মণ্ডলী, আমরা অনুষ্ঠানের প্রায় শেষ পর্যায়ে চলে এসেছি। অনুষ্ঠানের এ পর্যায়ে আছে একটি আধুনিক গান। আধুনিক গানটি পরিবেশন করবেন শিল্পী অনুপমা মুক্তি। আমি শিল্পী অনুপমা মুক্তিকে মঞ্চে আসার জন্য আহ্বান জানাচ্ছি।
একটি আমন্ত্রণ, আমাদের আজকের অনুষ্ঠানে যে সকল সম্মানিত শিল্পীরা, মিউজিশিয়ানরা এবং ডান্সাররা সবাইকে আমাদের আজকে ডিনারের সঙ্গে অংশগ্রহণ করার জন্য আমরা বিনীত অনুরোধ জানাচ্ছি। আমাদের এই আধুনিক গানের পরেই ডিনার হবে রাতের। আপনারা সবাই আমাদের সঙ্গে ডিনার খাবেন। থ্যাংক ইউ।
আসসালামু আলাইকুম। আমার আগে এগিয়ে গেলেন শাকিল ভাই এবং তারপরে বন্যাদি। তো বন্যাদি যা বলে গেলেন, তারপরে আমিও ঠিক ভেবেছিলাম এ ধরনের কিছু একটা বলবো, কারণ যার পরিবারে একজন ক্যান্সার পেশেন্ট থাকেন তারাই জানেন যে আপনাদের গুরুত্ব তাদের কাছে কত। তো আমার মা একজন ক্যান্সার পেশেন্ট, তো আমি ভালোভাবেই জানি যে তাদের কি অবস্থা হয় আপনাদেরকে ছাড়া। প্রত্যেকটা মুহূর্ত আমরা আপনাদের শরণাপন্ন হতে চাই, যদিও আপনারা অনেক ব্যস্ততার মধ্যে আমাদেরকে সময় দেন, আমাদেরকে সহযোগিতা করেন। সেজন্যে সকল ক্যান্সারের সঙ্গে জড়িত যত ডাক্তার আছেন সবাইকে অনেক অনেক ধন্যবাদ। আর আমরা চাই, দিনে দিনে তো ক্যান্সার অনেক বেড়ে যাচ্ছে, আমাদের সকলের চাওয়া থাকবে দিনে দিনে যেন এটা কমতে থাকে। ক্যান্সার একেবারেই যাতে নির্মূল করা সম্ভব হয় সেদিকেই যেন আমরা এগিয়ে যেতে পারি। আমার খুব পছন্দের একটা গান গাইছি। মিঠি মিঠি তারার সাথে কইব কথা, নাই বা তুমি এলে আকাশের ওই মিঠি মিঠি তারার সাথে কইব কথা, নাই বা তুমি এলে তোমার স্মৃতির পরশভরা অশ্রু নিয়ে গাঁথব মালা, নাই বা তুমি এলে আকাশের ওই মিঠি মিঠি তারার সাথে কইব কথা।
চলে নাই বা তুমি এলে সেই হারানো দিনগুলি যদি মনে পড়ে সেই হারানো দিনগুলি যদি মনে পড়ে ভুলে যেও গো সবই চিরতরে আমার গোপন ব্যথা আমার গোপন ব্যথা তুমি কবু বলনি তো আমি কবু জানিনি তো না সুন্দর স্বর্ণালী সন্ধ্যায় কি বন্ধনে জড়ালে গো বন্ধু, এই সুন্দর স্বর্ণালী সন্ধ্যায় কি বন্ধনে জড়ালে গো বন্ধু, কোন রক্তিম পলাশের স্বপ্ন মোর অন্তরে ছড়ালে গো বন্ধু, এই সুন্দর স্বর্ণালী সন্ধ্যায় কি বন্ধনে জড়ালে গো বন্ধু। আমলকি পিয়ালের কুঞ্জে কিছু মৌমাছি এখনো যে গুঞ্জে, আমলকি পিয়ালের কুঞ্জে কিছু মৌমাছি এখনো যে গুঞ্জে, বুঝি সেই সুরে আমারে ভরালে গো বন্ধু, এই সুন্দর স্বর্ণালী সন্ধ্যায় কি বন্ধনে জড়ালে গো বন্ধু। বাতাসের কথা সে তো কথা নয়, রূপ কথা ঝরে তার বাঁশিতে, আমাদের মুখে কোনো কথা নেই, শুধু দুটি আঁখি ধরে রাখে হাসিতে, বাতাসের কথা সে তো কথা নয়। কিছু পরে দূরে তারা চলবে, হয়তো তখন তুমি বলবে, কিছু পরে দূরে তারা চলবে, হয়তো তখন তুমি বলবে, জানি মালা কেন গালে পরালে গো বন্ধু, এই সুন্দর স্বর্ণালী সন্ধ্যায় কি বন্ধনে জড়ালে গো বন্ধু, কোন রক্তিম পলাশের স্বপ্ন মোর অন্তরে ছড়ালে গো বন্ধু, এই সুন্দর স্বর্ণালী সন্ধ্যায় কি বন্ধনে জড়ালে গো বন্ধু।
আজকের এই বিশেষ আয়োজনে আমাকে আমন্ত্রণ জানানোর জন্য অনেক অনেক ধন্যবাদ জানাচ্ছি, আর সেই সঙ্গে যারা আমার সঙ্গে যন্ত্রে ছিলেন তাদেরকে অনেক অনেক ধন্যবাদ। আজকের এই আয়োজনের শেষ গান গাইছি, আবারও দেখা হবে সেই প্রত্যাশায় শেষ করছি।
সাত ভাই চম্পা জাগরে জাগরে, ঘুম ঘুম কাটে না ঘুমেরই ঘরে।
Now we have our laser show. A part of the laser show was not completed. So this part will be shown to you now. Laser show and then raffle draw. But by this time we will start also the dinner, and raffle draw will be here in the stage. And I will request all the guests, that is the artists, musicians, dancers, vocal artists, all are requested to participate with our dinner. Please be with us. Thank you.